Coś mówię, coś mówię, coś mówię. Rzadko się zdarza, żeby mikrofon bez kabla działał. Hop, 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 hi, 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 ha, ha, ha. Tu. 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 Hej. Tu. Tu.
Jest case na 01? Pusty jest? Co? No to kurwa, zabieramy ten case i... Tyle czasu do operacyjnie wydałem z 01 na case.
Znaczy on nie jest dedykowany taki, ale się tam fajnie mieściło.
Poczekaj, z Soboty. Dobra, działa, nie działa. Konferencja. Wiesz co, mam coś takiego. Z kina do foyer. Telewizor tylko przy kinie. Może powinniśmy na czas konferencji jednak postawić tu jakąś paczkę, z której ustawą o tym napisać. Ale to przecież dopiero wieczorem. No i skradnie jedną jest jedynkę.
Teraz?
No.
A, dobrze, no tylko.
Tylko musicie dogadać z chłopakami od wizji, czy oni embedują dźwięk, kurwa, na ten telewizor, tak? Bo tam pewnie jakiś SDI zapierdala, ale nie wiadomo skąd.
Tu, hej, hej, hej. Hop, hop, hop. Hi, hi, hi. Za dużo?
Nie, ja mam na 0 godzin, ale nie ćwiczę.
Okej. Hej, hej, hej. Nie, no myślę, że tak będzie. Hej, hej, hej. Tu.
Dobrze, nie, gejnarze.
Okej.
Na 0 jest, ale nic nie ma.
Dobrze. Okej.
A z Balurumu? Słuchajcie,
Balurmie nie.
dwójki? No, to samo. To
W
samo?
Balurmie?
Tak. I na
Ale
dole też
kurczę,
to samo.
mówiliście, że tylko 3D i hala piąta dzisiaj. Bez Balurumu.
Dostałem informację, że mam od was dostać. Mogę wam dać 2 XLR-y? No, dobra.
Dobra, idź potem. Tego, że jak ktoś da też ma przywieźć, tak? Bo tam hala piąta przygotowaliśmy. Szkoda, żeśmy wczoraj nie posprawdzali, jak to będzie chodzić. Bo...
Wczoraj nie było mnie. Ja i tak dzisiaj, wiecie, przyszedłem w sumie prawie na gotowe. Właśnie.
O, no, tu.
Dobra, to jest
No
jeden.
nie,
Tu.
dam sygnały,
Hej,
tak?
hej, hej.
I to będzie
Tu.
kanał 1, to będzie polski.
Tu. Hej, hej, hej. Hej, hej, hej. Tu.
Tak, są.
Tu.
Gdzie ten pulpity położyć?
Tu. Hej, hej, hej. Hej, hej. Tu. Hej, hej, hej. Hej, hej, hej.
Teraz to nie bawić. To jest na czas na próby jest wczoraj, nie?
Tu, 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 tu. Hej, 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 hej.
No nie, no my damy wam czysty sygnał, ale wiem, że coś w zeszłym roku nie bardzo wam to chciało chodzić. Poczekaj, bo tylko
Tu, 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 tu.
bo tak zawsze do streamingów dajemy chłopakom.
Włożę pudełko, włożę do tego, do pulpitu. Dobra? I drugi. Włączyłeś dwa czy jeden?
Co?
Z pulpitu?
Jeden,
Dwa.
Gdzie jest kupi?
Tu masz ręce, nie. Słuchajcie, kładę. Dobra. Dobra, to jest drugi.
To jest przyklejone. Ja mam czarne. Te dziewczyny to chcą tłumaczyć jeszcze, że się nie buntują.
Wejście, tak?
Tu, 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 tu. Hej, hej, hej.
I teraz tak. Obojętnie, który polski gdzie będzie polski gdzie co? Obojętnie. Dobra.
Tu, tu, tu.
Masz. Dobra. Daj. Tam już nie wszystko zapnę, dobra, masz. Daj tu, no do słuchawki. To jest cały góral ze streamingami, tak się lubi grać.
Dość ciekawy. Kamilku, wiesz co? Ponoć tu są baty.
Włączać?
Z trzeciego. Wiesz co, jest dzieje się rzecz ciekawa, bo najpierw mi się to działo na jednym, co przystrajałem.
Nie ma rozkładania, nie ma nic, ale się
I jak mam wyłączone majki,
Tak, nie wolno ich wyłączać.
to nie musimy rozwijanie baterii.
Bo to jest zamknięte, bo tu nie ma dostępu, nie ma widzenia. Nie mam dostępu do tego właśnie.
Nie, smyczy, bo miały być smycze, ale nie ma smyczy.
Aha, na pewno.
Ja mam całe przeszkolenie.
Ty, 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 ty. Ty, hej, dwa. Ty, hej, dwa.
Nie mamy czasu, tu jak nas ochrona zatrzyma gdzieś to...
No to nie będziemy robić. Aha, Włodek, prezes od Kasi.
Na chwilę zabieram. Zabieram.
Dobra, chodziu, mamy wszystko wbite.
Tu, hej, dwa. Ty. Ty, hej, dwa. Ty, hej, dwa. Hej, dwa. Ty, ty. Ty, ty. Ty, ty. A, poczekaj. Tu jest. Ha. Ty, ty, ty. Hej, dwa. No dalej brak. Ty. Ty, ty, ty. Ty, hej, dwa. Ty, ty. Ty, ty, ty. Ty, 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 ty. Olo, jesteś tam? Ty, ty, ty. ty, hej, 2, hej, 2, 2, 2, hej, hej. Hej, 2, 2, 2.
Działa tu. Wywalają do ściany. Kabelek.
Kabelek. Podaj dalej z tego, z Western.
Oczywiście on tam zawsze laska.
Do tego można tu zostawić.
Co lata będzie potrzebował. Tutaj przynoszę i działa, nie?
Ale zostawiasz, że przestaje. Niestety, kurde. 700 zasięgu, ale
30. Nie, 30 metrów zasięgu.
ale w otwartej przestrzeni.
No dokładnie. Ściany robią brr.
Wchodzi? Hej. Chcesz mniej, czy... Tu, hop, hi. Dobra, to zrobię ci minus 10. Tu. Hop.
No dobra. I ogólnie to jest tak, że chcieliśmy...
Hey, tu. Hey, tu. Hey, tu, hey, tu. Hey, tu, hey, tu, hey, tu, hey, tu, hey, tu, hey, tu. Tu, hey, tu.
Chciałem sobie go wyłączyć, a on zalokowany. Dobra, to już wiesz co,
Czego tam dać już na stół?
zmienię bateryjki, nie wiem ile im tam...
Tu, 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 hej, 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 hej. Tu, 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 hej, 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 tu, tu, tu.
Wynegocjować trochę więcej przestrzeni.
Tam, Maciek?
Kasia Polikowska, ja tu
Maciek,
potem i... Będziemy się widzieć. Ja już tu byłam 2 razy, wiesz? Kasia, tutaj są wasze te kwanty konferencyjne i ważne. Oraz Włodek, woda, mam nadzieję, że dojdzie jak coś tu było. Pocznie z prosecco i różnymi innymi drinkami. Także tu jest, wiesz, tu jest co robić na stoiskach. Możemy trafić z powrotem do kabiny. Lubię sobie. Nie pamiętam, czy ja
Tu, tu, tu.
Ignacie Kalwo. A nie pamiętam.
Can it try to use my computer? Can it try to use? Or it's not ready yet?
Sir, my English is very bad.
My also.
But I'm a sound engineer.
And who's responsible for the connections? Because I would like to speak from my computer. No, but it's not gonna work like that.
Sorry, one moment. with sound?
No, we don't need sound.
Powiedz mi taką rzecz, tutaj pan chce się spiąć z wizją. To jest Sala. Czy jest ktoś? Wiesz co, chodzi o odpalenie prezentacji. Tak, dokładnie, chodzi o wizję. Czy wystarczy wziąć nowy kabel HDMI, czy ktoś przychodzi jeszcze i to obsługuje? Dzień dobry.
Dr. Marius?
Yes.
Okay. Speak Polish, speak English? Prefer English, yes?
I prefer English.
Okay.
Only a few words in Polish.
Okay. I'm moderator, your person, but my English is not no similar to you. But no, it's basically, I think it's for contact. Okay. I'm moderator for your lecture, and I'm preparing because I told about your person.
So you're gonna tell that.
Okay.
Coś
And
przerywa?
you talking about pay, yes?
Well, the Librela and Solencia
Okay,
more
okay,
specifically.
okay. All right. Okay. Because I'm also orthopedic, but in Poland, but I'm not, European certificate because when I start veterinary and hard working, the certificate was behind this. But I have good experience. I think I know what about you.
So that's good. That's good. I hope
All right.
it's gonna be interesting in some way.
Okay. I told people Polish language because they more understand. But if one or two person don't understand, about you are Polish people. I talk on this information. All right.
Okay, but you're gonna tell that in Polish.
Sorry.
You're gonna speak that in Polish.
Yes. I think it's because if somebody not understand, I cannot translate it because this comfort. Okay. We start 9 o'clock. All right.
All right.
Oh, sorry, that was me. Is it? I'm going to, I know, we'll try again, connect. Sorry. Now input here.
I will be speaking in the microphone, right? Yes. One. Okay. Never done it before.
Really? Okay. Nie wiem, nie piłem. Czy to jest dla prelegentów? Did you have some water already? Or
Yeah.
It's yours?
Yeah, it's mine.
Okay.
Yeah.
okay, thank you.
sound is? Sound?
I don't need the sound.
A, okej, super. Okej.
Ale nie dostaję po wejściu, to jest rozszycie. Jedyne, co mi przychodzi do głowy, to to, że może, ale Ale to nie jest kabel, czy są kable kierunkowe HDMI, nie?
No.
To może być to.
Znaczy są opisane, jak są
No
kierunkowe.
więc właśnie.
Obstawiam, że to chyba nie jest.
Świecić?
Możemy go przełączyć w drugą
Możemy
stronę
go
po prostu,
przełączyć.
to będzie najszybciej. Ale obstawiam, że to nie o to chodzi.
Splitter jest albo kabel, albo splitter. Widzisz to?
A my nie mamy, a może mamy jakiś splitter, żeby wam to podmienić.
Dałbyś radę?
Hmm.
Tym bardziej, że wiesz, nagranie to jakby mnie to ryba, ale znaczy nie powinienem tego mówić, tak? Ale
Ale patrz, bo tu się świeci, to jest taki sygnał idzie z niego, nie?
No.
Tutaj nie, więc
no
jakby
właśnie.
wyjście albo kabel. Mamy splitter jakiś HDMI jak coś? A, dobra, już wiem jak to połączymy.
A,
Możemy zrobić lupa
Mhm.
z aut. Dobra, spoko.
to zróbmy żółte. Czyli potrzebujemy jeszcze jeden kabel, czy nie?
Czyli tak, to idzie.
To jest wejście z
kabel.
laptopa, musi wejść do Ninja, a z Ninja musi wejść do tego. Czyli tu out, tak?
Tak.
A ty wchodzisz do rekordera. It's temporary. No i co? Nie możemy tak zrobić.
Dobra, i gdzie to ma jeszcze iść dalej? Na ekran.
No, ale wiesz co, tak? Czekaj. Nie, bo to jest... Tu musimy wejść. Bo źle... Czekaj. Tu musimy wejść. To teraz będzie kit.
Ale to w ogóle nie potrzebujemy robić tego przez splitter, tak? To już teraz.
Jest.
Bo tu jeden kabel wychodzi, to olejmy to splitter, bo tylko jest
A.
rzeczy się może zjebać.
Dobra.
Gdzie idzie do projektora, bo ja jeszcze pogubiłem.
Tu.
To trzeba bezpośrednio do
Sorry.
Ninja, no nie? Tak samo jest zrobione na balówce.
Na aucie.
No.
I tu na aut i z bani.
Tutaj będzie domek siedział?
Znaczy ma przychodzić i podpinać ludzi, tak?
O,
Okej.
jest okej.
No tu nagrywasz prezentację, tak?
Tylko
Tak.
coś przerywa. I to jest pewnie kabel. Ale to jest ten. No spoko. Tak.
Nagrywamy.
Dzięki. Was not sleeping, but
Sorry, how is
Marius?
It's a good moderation. I will tell you the story how we met when I was 2 years ago in Czech when in the United States. Marius was invited by our college conference, and that's how we met. And then heard him talking about brand and to optimize and to choose right patients. I was like, he sounds like he was from Greece, so I need to have him here.
there is a little something a little controversial with many last time there's some publication about this
His exacerbation
chory tam to powiedzieć, bo to ludzie nas nie zadają. Onkologii tak powiedzieć. Oncology is people system level. System level. Last time I was in oncology lectures, congress, Dutch congress, and they said people for is not sure what is nie było badań, wiesz, za dużo. Who's first?
There is no data
Okay.
that it exacerbates. So that was just some independent comment with no database behind.
Okej. Dobra, działamy, nie? Jeszcze 4 minuty. It's downstairs. Many people waiting for registration. Maybe we wait, or we start with I go outside.
Za 5 minut troszeczkę się opóźnimy, bo czekamy na bardzo dużo ludzi jeszcze w rejestracji jest, także żeby po prostu tutaj dyskomfortu nie wprowadzić. czas tam się rejestrują. Ja mam przyjemność Państwa moderować dzisiejszy wykład, mam zaszczyt moderować. Przedstawię Państwu pana doktora Mariusza Aniśkiewiczusa. Mariusz Aniśkiewiczus, tak? Okay, sorry, in Polish. Yes. Także już odmieniłem wszystko. Proszę Państwa, pan doktor jest kierownikiem oddziału ortopedyczno-neurologicznego w Wileńskim Jakowo Veterinarius Centras, tak? Jest też członkiem, to jest oczywiście ten Litewskie Stowarzyszenie Lekarzy Weterynarii Małych Zwierząt. Ja bardzo donośnie mówię. Słychać tam na końcu? Ja wiem. Z mikrofonem. Mikrofon, telefon, pogubię się strasznie. Będę później używał. W każdym razie, proszę Państwa, pan doktor również jest, należy do Europejskiego Stowarzyszenia Ortopedów i Traumatologów. Oczywiście również należy też do tego kolegium neurologicznego Europejskiego Stowarzyszenia. Pan doktor skończył studia w 2020 na uniwersytecie właśnie w każdym razie obronił w 2021 roku obronił doktora doktorstwa na temat tomografia komputerowa, taktyka chirurgiczna i zmiany strukturalno-funkcjonalne przeprofilu krążka międzykręgowego. Także myślę, że jakieś pytania nawet gdzieś tam możemy zahaczyć troszeczkę i o neurologię. No, dzisiejszy wykład poświęcony będzie bólowi, ale to już pan doktor wszystko tutaj Państwu, czyli nam wszystkim przedstawi. Myślę, że to będzie tyle tytułem wstępu. Przywitajmy brawami. Thank you for invitation for our Congress, Veterinary, Small Animal Veterinary Station. We are happy what you today will do our lectures.
Thank you.
Okay?
Good morning. Hello, colleagues. First of all, I want to thanks for introduction. Hopefully it was only good words. And I also want to thanks for organizers who invited me to participate in this Congress. I'm really, really very honest and pleased to be here in front of you and that I have a chance to give my presentation in topic which I think is quite hot in these days, and there's many different opinions about that. So I'm going to talk about Librela solensia, about how to optimize the efficacy in our patients with osteoarthritis. My presentation is going to be more or only case orientated, where I've collected different cases to show to you, and it's not going to be a good ones, it's also going to be a bad cases with some pitfalls and mistakes I've done, and hopefully all that information will reach you and will help you to decide whether or not to use Librela solensia in your practice. And of course, what to expect and what kind of results you can achieve, and maybe inform the owners what can also be the side effects. I think that you all agree that when the new drug comes into the market, it's always difficult to accept it. Yes, because we are not aware of the side effects, we are not, we don't know its action maybe very well, and we're afraid to start using it. And confidence comes, of course, with time and experience and knowledge also, and yes, but and these are normal feelings which I also had in the beginning before I start using Librela. We also need to understand that most of our cases, pets, are gonna be older ones who can have different many types of comorbidities in the same time, and osteoarthritis is not gonna be the main reason for being lameness or difficult to stand up, for example. So we need to keep in mind that information, and all these diseases like joint instabilities, any kind of oncology, neurological conditions, all of these patients will not probably benefit from Librela solensia. And basically this is the most important goal and information I want to share with you, that the proper selection of the cases is, this is the place where it starts from. So we need to understand in which cases Librela solensia will work and give us the best results we can expect. I know it's a little bit boring, but I want to start from the numbers, from the statistics, because I don't want to hide something. I don't have 100 or 1,000 cases. But I also want to show that I'm not giving my experience and knowledge only after 5 cases. So I started to use Librela in 2021 December. But the drug, Librela and Solensia, came into our market approximately 2021 March. So it took me approximately 6 months to start using that drug. And because of the feelings I've just mentioned before, so I was not aware of the side effects. I was not sure how it's supposed to be used in my patients. So the first injection I've tried to in my patient was in 2021 December. And I had the same presentation 2 years ago in my country, in Lithuania, with the local vets to share the experience I got in this almost a year when I was using Librela and was trying to encourage to use the Librela. And of course, my goal was to inform what can we expect from using it. So in that time, I've collected 16 cases in 10 months. And in 12 cases, we see improvement, the quality of life in our patients, and in 4 we didn't. And it was not my only statement that these 12 dogs get better after treatment. Before making my presentation, at that time I was calling to each of these 16 cases clients, and I was asking, what do you think? What do you see? What changes you see in your pets? And 12 of them said that the quality of life has improved by using Librela or Solensia. Nowadays, of course, I'm using also evaluation form. I'm giving that to the owners before the treatment and after the treatment, where they fill up, and it helps me and the owners to understand better, more scientific way, what results we have. So then I had the same presentation last year in Latvia, and I took a different time frame, and in a shorter time, so from 2022 October to 2023 March, I've collected, so it's half a year, I've collected more cases because I saw how potent that drug is, and I, of course, was more courage to use it. So in 14 cases, we see that it helped, and in 4 didn't. And now, before preparing my lecture for you, I took a time frame from 2023 May to 2024 September when I finished my presentation for you. So I got already 24 cases. So the numbers are increasing, but anyway, it's not 100 or 1,000 cases per year. A little bit about the cats. So I don't see many cats with osteoarthritis, unfortunately, but we know, and there's many published studies where it shows that cats suffers from osteoarthritis the same as the dogs. It's just harder for the owners and for the doctors to see them, because if the cat starts to be more to be less active, and the cat is not jumping as it's supposed to be, they think that this is only age-related. But what is the interesting fact that in all these cats with try Solensia, we see the improvement of quality of life in life. And 7 of these cats were Scottish Folds cats, and we know that they have many problems with the joints. And when I counted everything together, so from time I have started to use Librela till now, I collected 329. We've done 329 injections in our 60 cases, and 50 injections of Solensia. And these numbers are only my personal numbers. I didn't count the cases from my colleagues. So these numbers are only my personal. We reported one side effect, which I'm going to cover a little bit later with an example. So, and I want to start from the clinical cases. So The first case I'm going to present was my first case in a real practice. And I'm really very thankful to that case because it opened my mind and helped me to understand how Librela can be potent and help to our patients to have a better quality of life. And that dog was 3 years Italian Spinone dog who came into the clinic without any pre-scheduled appointment because the owner was scared that the dog is not able to stand up on the hind legs, and she thought that the dog was paralyzed, and she insisted to get consultation with a neurologist. So as it was a busy day, I didn't have a lot of time to that client, but I started to examine the dog, and I saw that there's no kind of neurological condition. I saw that the dog is having pain in the hip joints. The hip joints has reduced range of motion. And I said that to the owner that, look, your dog is not suffering from a neurological condition. There's some to be chronic problems in the hip joints. So then we sit down and had a small conversation with them. And I asked them, so, okay, what history your dog has? Because obviously there's some chronic problems in the joints and neurological conditions. And she said that, yes, the dog was diagnosed for hip dysplasia a couple of years ago. She was advised to do the surgery, but she declined to do that. At that time, we didn't have any who was doing the hip joint replacement, and only one colleague started to do that this year. So at that time, I think, I'm not sure, but maybe they were talking about the femoral head osteotomy. So they declined to do that. They tried to control all that situation, the pain management with the painkillers. They even were trying to go to Latvia to do intra-articular injections. And all of that didn't help them so much as they expected to. And this is the X-rays which they showed me from phone during the consultation. So we see how much dysplastic joints are. So incongruity, osteoarthritis, the femoral head are flattened, they're not in the center of acetabulus. So, and that dog is already 1 year old. So having that information, what could I suggest to them? They tried painkillers, it didn't help. They tried intra-articular injection, didn't help. The dog was, and that was at the age of 1 year. Then they showed me what the hips looks 1 year after, so we see how much it developed, the dysplasia. So the only thing which came into my mind that either we need to talk about euthanasia, either to think about surgery if it's possible in this case, but they declined to do that. I don't know the reason, but they declined to do that. And they said that, okay, there's no options I can help you, so please take up painkillers, and hopefully it's going to be fine. But then I remember that I have Librela in my refrigerator, which is sitting for 6 months, and I haven't managed to find the right patient to start using it. And I thought that maybe this is the right patient where I can, suggest to try. Why not? Because there's no any other options to that dog. And I gave that, and I was very honest to the owner. I said, look, I don't have any experience. I don't know what to expect, what can be the side effects. I never tried it before. Everything what I can tell is written in the leaflet. So please take a package. If you want to try, just come back to me. And surprisingly, 10 days after, I see them in the reception, and they agreed to do a Librela injection. And the most interesting thing was that the sister of the owner was a human medicine doctor, which was working in a university hospital. And she actually encouraged her to start using, because by the words of her, she was surprised that that kind of drug is existing in the veterinary medicine, because in the human medicine they don't have that. So at that moment, suddenly my feelings of being scared, uncertain, changed to being happy that I can suggest something new, totally new for their dog. So, and that dog is using Librela since now, so almost for 3 years. And what can I tell from using that 3 years? That dog needed to do the injection strictly every month because a couple of days in the end of action, the drug, owners started to see some changes in the dog behavior and walking. So they needed to do strictly every month. And sometimes when they know that they are going somewhere for holidays or whatever, because they live during the summer nearby sea, so they are doing the injections a little bit earlier, just to avoid of clinical symptoms appear. Because all of treatment before sedation, etc., the dog was quite scared and stressful, so we needed to hold him firmly to do the injection. And one time we couldn't manage to finish the injection. The dog moved a little bit and then the syringe went off and we continued the injection to another part of the body. And during that month we saw that the clinical signs getting worse, and that was the first time when we needed to add additional painkillers. So during these 3 years, no additional painkillers except that one case time. And this is a video how the dog is moving. That was done 1 year ago. And if I would see the dog walking outside, I think I wouldn't even think about any problems in a hip joints. Of course, we can suspect that the hip joints are not, flexible. The way how he's walking, maybe not the totally healthy dog, but what the owner said, that the dog is feeling totally fine, he's active, he's playful, he's doing whatever he wants. And that is the most important thing for me, because when we are talking about the dog who is not able to stand up because of pain, and now we see that he's running, that's everything what I want to hear from the owner. Unfortunately, this dog was not born under lucky star, I would say, because last summer the dog was started to limp on the front leg, and the owners didn't pay attention to that because they thought that Librela was gonna fix that. So they waited for 2 weeks until regular injection will come, and they mentioned that to me, that the dog is limping. But I also didn't pay attention. I thought, well, maybe it's not gonna be a problem. We're gonna do the injection as supposed to be, and it's gonna be fine. I saw that there's joint effusion in the carpal joint, and the dog is feeling pain during the flexion. But 2 weeks more after the injection of Librela, we didn't see any improvement. And then we did the X-rays, and we see that the dog is having carpal instability, we see osteoarthritis, severe joint effusion. So my mistake was, of course, not doing the X-rays at the beginning, because again, I and the owners were thinking that Librela gonna help anyway. But we need to keep in mind, we need to understand that all these conditions, when we have a joint instability, it doesn't matter what kind of instability, carpal instability due to cruciate ligament rupture, shoulder joint instability. When we have instability, the drug, of course, will not help as we are thinking or maybe hoping to help. So the dog was, so we did arthrodesis in that case, and now, of course, the front legs are more problematic than the hind legs. During the anesthesia, we did the X-rays, and we see how the joints are looking right now. But even though we see that the joints are just horrible, we saw how the dog was running and playing. And as I mentioned, after that case, I understood how much potent it can be in our cases. And I think it's the best choice for the owners, for the pets, when we have osteoarthritis and we don't have any possibilities to help them by doing surgeries. So Librela is really effective in these cases. The second case would be Hungarian short-haired Vizsla by the name of Laisvia. At the presentation time, she was 8 years old, with the history already being lame for many years before on her hind leg, on the hind right leg. And she came for me for a second opinion because the limping is already permanent for 3 weeks. So during the examination, I felt that there's a joint effusion and pain in the right knee joint, meniscal bump, crepitus, draw test was negative, reduced muscle mass in her right hind leg, also pain during hyperextension on both hip joints, and reduced range of motion in hip joints. Also, owners mentioned that the dog was, they did the surgery for removing mastocytomas just a couple of months before. So she didn't want to do any kind of sedation or additional evaluation. So I tried the painkillers only. I knew that it's not gonna help in this case because for sure there was some chronic problems. But I just didn't have what to suggest else because they refused to do additional examination. They were already after the surgery, so I gave them painkillers. But of course it didn't help, and after some time we did the X-rays. We see that the right hip joint is damaged, osteoarthritis and subchondral sclerosis, so the muscle mass is markedly reduced. Typical signs in the knee joint, osteoarthritis, joint effusion, osteoarthritis, calcification of soft tissue. So for sure the dog had cruciate ligament disease and meniscal damage, but they were already being limped for 2 years. The same changes are in the left knee joint. We did the X-rays. We see signs of spondylopathia defermans. We can suspect the stenosis of lumbar sacral region. So many different problems. And I wasn't sure what is the main pain coming from. Either was it from hips or the knee. In all of these areas, we see chronic changes. And I already was familiar with Librela, and I decided to use Librela in this case. And we see marked improvement after the first injection. And for that particular case, we managed to reach injection every 5 or 6 months. Weeks, sorry. Of course, the Librela didn't change everything. They still needed to work on a muscle mass, so they went to physiotherapy. The mastocytoma that they had to remove before, it didn't progress using Librela. And this is the only case when we saw the side effects, which was the pain and swelling in the site of injection. But we understood that we need to continue Librela because the dog has many problems, and after a couple of injections, it will not change everything. So we continued treatment, and we never saw any side effects again. So I'm not sure, was it accidental side effects, was it because of Librela or because of the injection itself? But what I want to point out that Librela alone is, of course, is not the only treatment. We also need to think multimodal approach. So all these additional treatment like physiotherapy, laser therapy, joint supplements, and etc. It's also necessary in these cases. And about the side effects, so we managed to control the clinical signs in a couple of months. We restored the muscle mass, and the owner decided to continue the treatment in the clinic closer to here. So we were treating here only for 6 months. And as far as I know, the dog didn't show any signs of mastocytoma regrow at that point. The third case would be typical case, which I think we see quite a lot. So an old Labrador Retriever, at the presentation time he was 12 years old, and he had many problems in the joints. He had diagnosed elbow dysplasia and osteoarthritis in 2018. He was periodically limping in the front legs for many years before. He was using painkillers a lot. And since 2021, the lameness is permanent. And for him, it's difficult to stand up on the back legs also. He's less active. And due to all that long treatment before, he was not able to tolerate that anymore. He had gastrointestinal tract problems. He started to vomit. And when they came to me for a second opinion, what to do next, this is the typical case where we can try to use Librela. And the dog is using Librela since now. So he's already 12 years old. What is interesting that his brother is also using Librela, but a little bit shorter time, for 1 year. But as I mentioned, we need to keep in mind that the old dogs, the old patients, can suffer not only from osteoarthritis, but they can have additional problems, which can mimic the osteoarthritis and can be the important part of our success or maybe bad results. So even though we knew that the dog was diagnosed osteoarthritis, he was suffering from that for many years, we still examined him further. We did the blood results, we did the CT scan, we scanned all the body just to be sure that nothing else is happening. So what we managed to find, only of course what we knew already, the osteoarthritis in a elbow joint, a lot of calcification in a soft tissue. So when we knew that nothing else is happening, we were ready to use Librela. We used Librela for approximately 6 months in the dose of 20 milligrams because his weight was 39 approximately, so it was enough for him. But then after that time, we noticed that it's not enough and the disease is progressing. So we decided to increase the dose. And even though the dog is weighing 39 approximately, we are using the 30 milligrams, which is from 40 kilos. So yes, sometimes if we don't see the benefit from the smaller dosage, which is 0.5 milligrams per kilo. So we need to think about increasing the dose. Also, we need to keep in mind that we need to wait sometimes, in some cases, 2 or 3 even months that the Librela start acts. And of course, if we don't see any effect after 2 or 3 even months, there's no point of use it anymore. Yeah, so he's using Librela for 2 years with a dose of 30 milligrams. The thing is, and we need to inform the owners clearly what kind of results we can expect. So the dog is still limping, mainly on that front leg. But what the owners are happy about that, because that the dog is more playful, he's more active, he shows he is willing to play, it's easier for him to stand up. So even though the dog is limping, the quality of life is markedly improved. And for sure, I'm telling that to each owner that I'm not sure what kind of results we can achieve. Are the dog is gonna be pain-free and will not be limping at all, or maybe he will be limping still, but his quality of life will be improved. So I'm telling to each of the owners that it's very hard to predict the results. The next example is Chow Chow, again, an old patient with old problems in the joint. So he has progressive difficult movement in all legs. He was aggressive, so I couldn't examine him a lot. But what I saw that many of joints are painful, range of motion is reduced, crepitation in the left front legs. And a couple of months ago, the dog was pre-treated due to urinary tract infection. He had increased kidney parameters. They already tried painkillers, gabapentin, which was not effective. And this is the way how he is walking. So we see how difficult for him is to do every step. He tries to run a little bit and he stops after that. Take a look at his fur. How does it look? So the same approach. When we have an old case, even though we have obvious signs of osteoarthritis, maybe it was diagnosed in the clinic somewhere else, but we need to check them additionally. I personally never do injections, Librela, without additional examination, at least blood test or X-rays. And in this case also. So I was thinking that the dog is having some kind of oncology because he looks very strange, but I didn't see any suspicions except that the prostate is increased capacity, increase in size, and maybe he is compressing the rectus. So, of course, many osteophytes in the spine. Due to aggressiveness, I couldn't do more X-rays. But the owners, of course, told us, as I mentioned, that the dog was suffering from the urinary tract infection. So I didn't pay attention a lot at these X-rays. So we gave a Librela, and a couple of months after, we see the changes. So the fur has changed dramatically, yes. We see that it's getting better. The dog is more active. He's playful. Yes, you can argue that in the first video the dog was walking alone, and in the second video he is playing with another dog. And I asked that to the owner, what do you think why these videos has changed? Is it because of the dog? And she said, no, he's running faster, not because of the dog, but because he's feeling much better. Yes, the walking is not perfect, but you know, when we see happy dog, whatever, what else we need? Unfortunately, but 6 months after initial appointment, relapsed urinary tract infection. And then I referred to internal medicine doctor because I knew it's not my case, and I will not interrupt that. So they did the blood results. We see anemia. We see that the kidney parameters are increased, but they knew they were increased before giving Librela because the dog was suffering from urinary tract infection. So our internal medicine doctors did the FNA from prostate, and they found that the dog is suffering from carcinoma. And going back to the X-rays, after seeing that, I would, at that time, of course, I made a mistake not suggesting FNA at that point. But I was confused by information that they were pre-treated before. So oncology doctor prescribed doxorubicin. We discontinued the Librela because of possible side effects and awareness, and we used painkillers only. But the owner said that it was not enough to control the pain, and we came back to Librela again, which helped him to feel better. And even though, of course, oncology problem develops more and more in time, and then metastasis in the liver appeared, and at some point the owner decided to put the dog to sleep. What I want to point out that if we wouldn't do the blood results, X-rays, and only will be doing the Librela without any additional examination, maybe after these 6 months, owner could blame us that all these changes happened due to Librela. So that's, I would say, the main advice before using Librela in all patients. Do as much examination as possible to be safe, to be in a safe place. The next example would be Cavalier King Charles Spaniel Barris by the age of 10 years old of presentation time, which is less active for 3 months. He's not playful. He tends to limp on the right front leg. So during examination, we found that there are reduced range of motion and pain in carpus and in hip joints, bilateral patellar luxation. He also was diagnosed with heart disease, and he was using pimabendan. He also was diagnosed with syringomelia, a churn-like malformation, so he was using prednisolone for a long time. We did, of course, additional blood results. We excluded the tick-borne diseases. We did some mixed ways I'm going to show, but due to the stress and the problem of the heart, we couldn't do this. We didn't want to do the sedation. So we did the Librela injection. And for example, in this case, he benefits from Librela a lot. And for him, it's enough to do Librela injection every 3 months. I know it's off-labeled and it's not written in a prescription, but I personally try to use Librela, as depends on the situation. And if the dog cooperates fine and it's not necessary to do the injection every month, we do that as much as we need. For 2 reasons, of course, financial issues and we're all aware of side effects. So the less drug, any kind of drug, I would say, it's better for the pet. So we did the X-rays on the front leg, so we osteoarthritis in the digits. Maybe it's not visible, but there's some joint effusion in the carpal joint. And I asked, of course, I'm always asking a lot, but sometimes owners are not doing, but sorry for the quality of video, but we see how the dog is moving. The tail is moving faster than his legs, right? Take a look at his face. He looks very sad, and he walks very slowly. And I'm not gonna lie, I was surprised by myself. So after we did Librela, I don't remember exactly, but it was 3, 4, 5 days, something like that. The owner called me. I was a little bit afraid why she's calling a couple of days after we did the injection, because I was not waiting for her call. And she said that, oh, doctor, the miracle happened because the dog was healthy again. I couldn't believe that and asked to film. And this is the same video a couple of days after. Look at his face, he's happy again. So all these videos and feedbacks from the owners help us to evaluate the results. I'm going to show you the video before. And nothing else was done, only the Librela injection. No painkillers, no additional, no drugs. And the owners are coming to the clinic when they start seeing that the dog is becoming in the first video. And the dog is walking alone, there's no other persons, so it's a very nice case. This is a case which was very nice. So we have a 12-year-old boxer with a long history of many problems. So he was operated for cruciate ligament diseases 6 years ago. He has cardiomyopathy. So even cardiologists, they are not allowed us to do any kind of sedation. The dog was very aggressive. I was not able even to examine him because whenever I touch, he tries to bite me. So when we need to do the injection, there must be at least 3 or 4 persons. One owner is holding the leash, another owner is giving the treats to distract the dog. I'm clapping the hands, also trying to distract, and then the nurse comes to the back and is doing the injection. So I couldn't do a lot of examination in this case. but you will see the video how he is moving. When we needed to take a blood test, he was so in panic that he started to breathe difficult, and he managed with the head, bumped into the owner's nose, and then the bleed comes out. So everyone is in a stressful situation, and he was blind also. And before that, and during the treatment, we were discussed about the need of euthanasia for many times, but the owners declined to do that. For some reasons, I couldn't put the video in the slides, so I'm gonna show you from out of slides. So this is a video in the left before the treatment, and on the right after the treatment, Librela. Oh, sorry. Okay, what to change? Is there any possibility? Because it was working before. Maybe extend the. Can somebody show me who's more experienced? Because it was working before we. Yeah.
Make them both options, setups. Czy ktoś potrafi MacBooka obsługiwać? It's MacBook, I don't get it.
Because maybe of this camera.
If we don't manage, just skip it.
But it's a very nice case. I would like to show. Can we took off that camera for a while?
Apple menu, settings.
I'm not working, a lot with that. Yes, of course. Yes.
Do you have no worries about eliminating the nerve growth factor function? Because it serves a function.
Mm-hmm. Yeah.
For the neurological system as well.
Yeah. So, and yeah, this is basically the main goal is to inform that, first of all, if we suspect that we have a neurological condition, there's no point of trying using Librela. And of course, we examine and trying to exclude that that dog is not suffering. There was some cases where the dog had osteoarthritis and neurological condition at the same time. And for example, there was Labrador Retriever who was diagnosed with osteoarthritis many years ago, and then he became weak in the hind legs, and they came to me to talk about Librela because they heard about Librela effectiveness, and they wanted to try Librela on their dog because they believed it's gonna help. And I explained that to the owners that, look, your dog is weak in the hind legs, even though he has osteoarthritis, but he has neurological condition, and Librela is not gonna help you. I was trying to change the mind, and I was not, yeah, but I'm gonna finish here. So I was not forcing, but I was advised not to do Librela injection because I was sure it's not gonna help them. We did the injection, couple of them. We didn't see any improvement, but only deterioration. But was it because of Librela? Was it because of natural deterioration? It's hard to say for me. But of course, if you see the neurological condition, I suggest, of course, to think, is it Librela necessary in your case? Because it's, of course, it can affect. And we want to know, in these cases, we want to have as much nerves as possible, and if we're gonna stop the NGF receptors working, so yeah, it might affect. But there are no studies confirming that, so it's very hard to say. It's very, I would say, personal opinion in that.
If I can interrupt from company and standpoint of view, like, we do not eliminate NGF. Like, it's very important to highlight that. We do not eliminate. We just decrease the excess, which is pathological in the joint with osteoarthritis, and we try to get NGF back to the physiological level. Sorry, Marius.
That's okay, thank you. So I really want to show that video. So in the left, we see the dog before the treatment, and in the right, we see after the treatment. So for sure, he has difficulties to stand up, but if we compare how he's walking without Librela, it's really, really big changes. I'm gonna show you again. And even we were managed to improve the quality of life in this patient, we still were having some discussions about euthanasia, because for sure there were problems, many problems. It was hard for him to stand, not even to stand up, but walk by stairs, and they live in a 4th floor. I'll show you again. So you see how, let's say, fast he's walking on the right and how slowly he's walking on the left. And yes, again, coming back to the results, we need to inform what kind of results we can achieve. And the dog passed away 5 months ago after being treated by Librela 1.5 years. And during that 1.5 years, we didn't have any additional problems related with the heart problems, which I mentioned before. I didn't say that, but I'm gonna say that right now, but he was using painkillers a lot in his life, and he had GI tract problems, and we never had that during the Librela treatment. And even though the end of this patient was sad, but the owners were happy of being able to change his quality of life, and they survived for 1.5 years more. And for a boxer, 14 years old, I would say it's quite a lot. A little bit about the feline cases. As I mentioned, we don't have a lot of them, but this one is also my first case where I started to use Solensia. So the owners came to the clinic because the cat was limping on a front right leg. What happened, nobody knows, because the owners were away, and the cat was left alone for 10 days, and only supervised person came to feed the cat, and that's it. The typical cat which is not willing to walk during the examination in a consultation room, so I managed only to find that the carpal joint is painful, joint effusion and reduced flexion, so everyone thought, myself also, that it's supposed to be some kind of trauma after jumping, unsuccessful jumping. I asked to film the cat, how the cat is walking, because it was difficult to understand the whole picture of the cat. And I had some suspicion that something else is going on. And this is a video how the cat is walking. And we see that the problem is not only on the right front leg. And they showed me the video a couple of days after the initial consultation. And when I saw that, I said that, okay, you have a bigger problem than the front leg. The dog is barely walking in all of the legs. Of course, the front leg is more affected, for sure. That's how it's difficult for him even go to eat. And he's laying down all the day like that. I did the X-rays a bit later. I couldn't manage to find anything suspicious for me at that time. Only except that joint effusion a little bit, but it's left and the right also a bit. I also did and I was totally completely lost in this case because I did the CT scan. I tried painkillers for a couple of weeks, it didn't work. I tried steroids, it didn't work. I tried to immobilize the wrist, it didn't work. I haven't mentioned that, but I even tried the antibiotics for a short time. We did the blood results, we excluded toxoplasmosis, and I was completely lost. And that treatment, if I could say that it was a treatment, lasted for 2 months. And at one point, I said to the owners, look, and I was very honest to them. I said what I was thinking at that point, and I said that I'm completely lost with your case. I don't know what is happening, why the cat is not getting better, and there's nothing I can suggest you. I asked them why you're still coming to me, because I'm not able to help you. I advised to find some maybe second opinion, and I was not afraid of that because I was completely lost. And then after discussed that situation with the owners, I thought that maybe this is the right case to try the Solensia. I've never tried it before in the cat, so that was the first case for me to use the Solensia. And symptoms disappeared after 1 injection of Solensia in 1 week. And this is a video how the cat is playing. I had a talk by phone with the owners after 1 week after injection, and when I asked what results you have, they said that, oh, doctor, the miracle happened, the cat is healthy again. I couldn't believe until I saw the video, and as I am a neurologist also, I'm doing spinal surgeries, and many cases the dogs are paralyzed before the surgery, and when they start walking 1 or 2 days after, nobody tells me what miracle happened in these cases. Owners think that it's happened what's supposed to happen. But honestly, I never heard so many times owners saying the miracle happened after using Librela or Solensia in these cases. So, and this is a proof that in some cases it really helps a lot and it's very effective. So we did. Even though during that 1 month after injection of Solensia, the cat was not limping at all, we were not using any kind of medication. We did a second injection, just to be sure, and the owners agreed to do that. But after that, we discontinued our treatment because in that 2 months of period, we didn't see any kind of symptoms. I advised to use joint supplements, and that's it. And I haven't seen them for 2 years. And they came to me recently, well, not recently, but this spring, because the owner noticed some swelling in the joints, in the hind joints. During these 2 years, what they did was only joint supplements, and that's it. They mentioned that sometimes they saw some decreased activity and maybe start being limp, but as they were giving joint supplements, they were managed to control that. And when I saw the cat and palpated the joints, I immediately understand what is happening, because it was not the swelling of the joints, it was increased size and bony structures in the joints. So we did the X-rays. Maybe it's hard to see sorry for the quality in the front legs, but especially in the hind legs, we see new bone structure appeared in the joints. So that the diagnosis is osteochondrodysplasia in this cat. So when I started to think about this case, of course it's only my personal opinion, but I think that the disease started 2 years ago when they came to me, but I was just not able to find the reason for that. And as I mentioned, there are 7 of these 11 cats we tried Solensia are Scottish Fold, so I suppose that this problem is quite common in these breeds. And now we did again 2 injections in the spring, then we discontinued, and now they came in September and October to do again injections. So yes, we can blame that I'm not following the rules, But for that cat, it's enough to do, well, we did 4 injections per year. And I have similar cases like that, Scottish Fold cats where they have similar problems. And I didn't put that in the slides, but I want just to mention that this cat is not the only one where we are using injection only when the owners are noticing that something is not right, and it can be 3-6 months in between in these injections. And this is a video how the cat is moving right now. Yes, you can argue that he is not very flexible, there's stiffness in the legs, but anyway, it is helping. And we know that we are not able to treat that. The cat will be on Solensia for the rest of the life, as much as it's gonna work, and we explain that to the owners. So that's it with the cats, and I want to come back with the dogs, but to show how important is examination before using Librela. So this is a Labrador Retriever by the name of Armani, who was 13 years old this summer. I've seen him 4 years ago when he had the first consultation with me, and I have diagnosed elbow dysplasia, and we used painkillers at that time because I was not familiar with the Librela. It was not in the market at that time, so we gave up painkillers only. It was enough for him to control the clinical signs. They were living in France, so they were coming into Lithuania just occasionally every summer. And I saw this summer because the owner noticed that the situation is getting worse. Seeing that is an old Labrador Retriever with the osteoarthritis already diagnosed, I already was thinking about trying to use Librela, but as with time, talking with the consultation, I noticed that the dog is not feeling very well. He has also mentioned, the owner, that he has a decreased physical activity and decreased body weight. I saw that the dog has a little bit pale mucous membranes, he's apathic, and increased breathing. So we did the blood results before using Librela. Before deciding to use Librela, of course, we did the blood results, which showed anemia. We did the X-rays, and we found the mass in the abdomen. We went further. We did the CT scan of full body. We managed to identify that as a splenic mass, and 2 days after we took it out, we did a surgery, and by the day of removing the sutures, the owner said that the dog is feeling as 2 years before. He's active, he's in a good mood, and etc. But let's imagine what would happen if I would do injection in that case before, without doing any examination. Probably the dog would be feeling worse and worse in time, and maybe a couple of weeks, couple of months after he would be dead, probably. And now it depends on the owner. Either she would be blaming me because I prescribed Librela. Maybe she would be giving bad comments about Librela, who probably killed their dog. Anyway, it would be my fault. I haven't examined the dog properly before starting to use Librela. Or maybe she would say that because of Librela, after many months after the tumor grew. But after the surgery, the dog was feeling fine for a couple of months. They went to France, and we had an online consultation just recently because the dog is not feeling well again. He's not weighting the head up, he's started to limp more, he's not active, and so on. And they went to a local vet in France where they did the Librela injection, and then she scheduled an appointment with me by online in the evening, and she explained me what happened and what she did she act correctly by allowing to do Librela, what to do next, and so on. So when I heard what is happening, I asked her, did she said that the dog was operated due to oncology a couple of months ago? She said yes. I asked, have you done any blood results? She said no. And that was strange for me. The other thing what was strange for me, the doctor injected Librela and had referred the dog to the neurologist. So for me, the question came into my mind, so if she thought that the problem is neurological, why she did the Librela injection? If she did that because she thought it's going to help, unfortunately, no. In this case, the Librela is not going to help. If she didn't understand the action of Librela, that's another question. Or maybe she wanted to sell the drug. It sometimes also happens, but we don't want to sell the drugs. Of course, we want to treat our patient. So it was strange for me that knowing that the dog was treated by oncology a couple of months ago, and when he started to feel bad, no ultrasound, blood tests, or X-rays were done. And the thing that the dog was not able to lift the head up, it means that either he has problem in the neck, either he's weak. And I wrote down the letter 1 week after by asking how Armani is doing. And I got a big letter by explaining what happened after that consultation, online consultation. So 2 days after, the dog is not getting better. He's even deteriorated. He get to feel worse. He was not able to stand up. And then they organized the CT scan. But the dog didn't manage to survive that night. And as owner told me that the dog was very weak, he was hardly breathing, and he just passed away by stopping breath. And I think, my opinion, either the dog was bleeding inside somewhere in the abdomen or the thoracic cavity, either he had a metastasis somewhere, but most likely he was bleeding somewhere. And again, if we would do injection in these cases without any examination before, we would be in trouble. And I think this is the situation and the cases why there are so many complaints or comments about the possible side effects of Librela and Solensia because of cases like that. And I had even conversation with my colleague, which is a cardiologist, and I noticed that she started to write down in the comments, don't use Librela in my patients, don't use Librela in my patient, and so on and so on. And once I had the conversation, why you are keeping saying that don't use Librela in my cases? And she said that because of the side effects, there are many side effects. And I said, okay, but I'm using Librela for 3 years and I've never seen the side effects except one case, inflammation in the injection site. And I asked, don't you have side effects in your treatment, in your cardiological patients? And I asked, where you hear that there's so many side effects? And she said that there's many comments in the Facebook, in the comments. So every time I hear that there's possible side effects, I always think about that case. Was the patient examined properly before using Librela or Solensia? That's the main question. And coming to conclusions, I also want to mention some cases where I didn't put in the slides because I don't have a lot of information about them, but just few examines. So once I got the cat which was paralyzed in the hind legs, and for sure he had a thromboembolism in the hind legs. So for me, first thought which is coming is why the cat is coming to the neurologist, because he needs to go to a cardiologist, yes? But anyway, as the patient came to me, I tried to help somehow, so I asked what happened. So the owner said that the cat was paralyzed yesterday. We went to a local vet, and the local vet did the Solensia injection and said that if it's not going to help him one day, go to the neurologist. And I said, what? Why? Of course, I didn't say that to the owners, but why the doctor did the injection of Solensia in the paralyzed cat. Again, the same questions for me. Either he doesn't understand the action of it, either he wants to sell the drug, either he thinks that Librela, or Solensia in that case, is treating everything. But we need to understand that Librela and Solensia is acting and help us to control the pain, which is associated only with the osteoarthritis. So what conclusions I've managed to do? That it's perfect or maybe superior drug to control the pain associated with the osteoarthritis rather than NSAIDs and other painkillers, especially in the cases where we have GI problem and kidney problems. No significant side effects were observed. Usually it's enough one injection to get the results, but sometimes, of course, we need to wait a little bit more. And the main goal and the message I want to send to you that be patient and be cautious with the patient which are older ones and can have additional comorbidities with osteoarthritis, because if we miss some diagnosis, we can not even get bad results, but will not achieve what we are trying to achieve. So always perform at least some basic studies like blood, CT, or ultrasound for the cases, even though you have osteoarthritis diagnosed previously by yourself or by other colleagues. So I suggest trust in your diagnosis. So thank you very much. Ready for questions.
Proszę Państwa, faktycznie bardzo ciekawy wykład, bynajmniej dla mnie, gdzie jestem lekarzem praktykującym i zwłaszcza głównie w ortopedii. Także naprawdę bardzo fajne wyjaśnienia właśnie tych kwestii takich internetowych, jakichś takich plotek różnych i tak dalej. Ja sam zresztą zapytałem, ponieważ będąc na kongresie Sasterbergu usłyszałem na onkologii weterynaryjnej, że jednak gdzieś tam jakieś procesy nowotworowe może Librela przyspieszać, że do końca takich badań nie ma. No, tego nigdy nie będziemy wiedzieć, ponieważ sami wiemy, że bardzo często pacjentami są pacjenci geriatryczni. I zapominamy niejednokrotnie o tym. Tutaj bardzo dobrze pan doktor pięknie to wyjaśnił, jak właśnie było przypadek z tą śledzioną, bo niejednokrotnie tak jest, że dajemy Librelę, jest super i następna injekcja, bo pies się gorzej poczuł, właściciel nawet nie chce badań, ale nie ulegajmy temu. Pamiętajmy, że proces nowotworowy, zajmuje się trochę onkologią i to kliniczną i przede wszystkim chirurgiczną. Proces nowotworowy rozwija się u psów bardzo szybko, niejednokrotnie. Jeżeli tutaj iniekcję doktor dawał raz na 3 miesiące, to w ciągu 3 miesięcy ten proces nowotworowy, chociażby taki śledziony, może bardzo szybko się uaktywnić. Także bierzmy to pod uwagę. Ja przechodzę do pytania, więc tutaj pytanie od doktora Grzegorza. Jakie leczenie stosujesz miejscowo w iniekcjach dostawowych obok Librelli ogólnie? Aha, bo to...
Yeah, you can, yeah.
Okay, what's the question once again? All right. No, Marius had no the headphones, so he doesn't hear. Okay. First question, like, what type of treatment you use, like local treatment, with intra-joint injections, like additional treatment next to Librela?
Yeah. So if we have only one joint affected, we have many possibilities to solve the problem. So either PRP on hyaluronic acid, on any kind of laser or physiotherapy is also is helpful. So I also want to point out that Librela is not, like good in all the ways. It's just additional possibility to help in our cases. So if you have a case only one joint is affected, of course you can treat it locally by doing injections into the joint. It's not necessary to do the Librela straight away, but yeah, it depends on the knowledge and experience in that case. So PRP, yeah.
All right, there's no more questions in the application, but maybe someone has a question here in the room. Go.
Thank you. I have also a question about the inflammation process that is in osteoarthritis present, as we know, and Librela doesn't act against it, right? It has no anti-inflammatory action, as far as I know. And we know that in OA we have flare-ups of inflammation. So do you use any anti-inflammatory agents?
No. No. If it's enough only Librela to control the clinical signs, we don't give any additional painkillers or anti-inflammatory drugs, because Librela is supposed to stop the cascade of all that inflammation. So no, we don't use additional painkillers.
And no anti-inflammatory is necessary in,
No.
in your
But
view?
yeah, well, because I mentioned there are some cases where Librela is not enough, especially when we have severe osteoarthritis in many joints, the patient is already geriatric, and for sure we're not gonna make joints healthy anymore. And in some cases, maybe that didn't point out, but yes, there are cases where you use additional painkillers to try to control all that clinical signs. But it depends, because usually when we see the patient which is coming for a second opinion, he was already tried many different painkillers, which at some point are not able to help anymore. So we're trying to treat alternatively by prescribing Librela. If it's enough, that's fine. If we need to add additional painkillers, we are doing that.
I can complement your answer with some insights from a mode of action, because like Librela and Solensia are the result of more than a decade of study around NGF. And we know that it not only sends the pain signal through its receptors on the nervous cells, but also it has the receptors on inflammatory cells. And when NGF is released in the joint, it also will stimulate the inflammatory mediators release. So when we decrease it, we also somehow in a direct way can limit the inflammation severity. Any more questions? Oh, I will be back there. Maybe I will just stay there. Sure.
Because you have told lots of the things about pre-examination before, but what about during the period of treatment about this?
Sorry, what?
The period of treatment. Yeah. Have you done any CTs or X-rays examinations, like images any? Or, yeah, that's the question.
Well, depends what owners want. Yes, of course, it's advisable to check how the joints are changing in time. And of course, as they are coming for injection to the clinic, we're not allowing to do by themselves at home. So we see them anyway every month, or as long as often they need to do the injections. So time by time, of course, we examine them additionally. If we know, for example, that they had a problem to the kidneys or liver, whatever, we're doing periodically blood results. If the dog was having some kind of oncology, yes, additional X-rays. Usually we don't do the CT only for the sake of safety and anesthesia, but we examine the dogs periodically. But the most, I think, sufficient thing is what the owners are saying. I think if the problem would be progressed anymore, in any way, we would see that the clinical signs is getting worse and worse. So, of course, it's advisable to do additional examination during that period of treatment.
Any more questions? Something in the application? Okay, I'm running. I can't run. I'm after my knee surgeries.
Słyszałem o doniesieniach, że nie powinno się właśnie stosować librelli łącznie ze środkami przeciwzapalnymi. Dochodzi ponoć do pogorszenia właśnie objawów od strony zmian reumatologicznych.
That's more kind of question to me. All right, so you asked about RPOA and this information about human experience with together using like anti-NGF maps with NSAIDs, but that was from human experience, human medicine, when in human you have the disease unit like RPOA, so rapidly progressing osteoarthritis, which can happen not only with anti-NGF maps, but with any other treatments. There's many examples. In animals, we do not have RPOA described, so that was only leaflet or label information, and we did 2-week study of using together like Librela and carprofen Rimadyl, and it was well tolerated, but this is only we can recommend, like only 2 weeks with carprofen, nothing more, but we've never met RPOA example in safety monitoring.
Jeszcze pytanie, Mariuszu, jedno. Wspominałeś, to był chyba pierwszy przypadek, leczenie librelą i równocześnie podawanie, jeżeli dobrze zrozumiałem, podawanie dostawowe, leczenie, iniekcja. A, przepraszam, nie słyszałem, wyszedłem na chwilę, przepraszam bardzo.
Dobra, no to w aplikacji mamy jednoczesne stosowanie z NSAIDs and yeah, how to treat the inflammation. So I think we already answered that. Any more? No more questions. So, if you are interested in osteoarthritis and modern approach to the treatment, please join Dr. Beatrice Monteiro lecture today at 7 p.m. because it will be follow-up about modern approach of osteoarthritis pain management. So, and thank you for joining.
Can I give you a question?
Sure.
I'm just wondering, how many of you are using Librela in your practice or Solencia? Okay, many of you. And all of you almost. And who thinks it works, it's helping? Okay.
Nice view.
And how many of you are complaining about the side effects? Perfect.
I'm so happy.
Cool. So probably nothing new I said to you then.
Marius, thank you very much. Amazing lecture. Congrats. And thank you for joining.
strict 45 minutes. Normally. Waiting time.
So it's 45 minutes,
And then it's up.
and then it's 5 minutes for the change.
To change some question after the second.
No, no, we can do questions after 5 minutes. Yeah, yeah. What I change is.
That's
Ready. For the question. What time do you start today? They are like they're Polish. Change your chicken to a more students. Change your mind. Money. What is the money? People who build money. One of your kids is a red, no?
yeah, no, yeah.
Yeah, no, because it was a student, no? It was in the in Warsaw, no? In the already was there. No? What year is it? There. In the middle. It's doing well. The potential.
We see. Yes.
I guess it's like I became a surgeon because my dad was a surgeon for people. So at the end, what you see, you gotta move in Japan. It's very hard just to you want to do the same.
When did you decide?
And then
At the end of the high school?
Yeah, no, I was for a long time until I know I wanted to do surgery.
Yeah.
And then always was medicine. And then the last year I thought, I like dogs and stuff. And I thought, and then the main reason is stupid. I thought in Spain you need to sit the national exam to choose a specialty in hospital. I would have gone into medicine, but I would have been like, in those days you need maybe like out 745, 750 out of 6. You know, and I got there and I was like 8. I was like 8, and so and when I was upside, I was on the lower or the clever, kind of thing. And I thought, now all these guys in and they study, they are theoretically better than they study. And I want to do surgery, which is the top 5. So can you imagine? I was 6 years of medicine, and then I ended up doing oncology. So I can do veterinary medicine. It's going to be easier to do what I want to do. How many? 3 minutes. I'm counting. You take this? No? Or you, this one, yes. Both work. So you can take one and one. Yes. What do you mean to stay?
So good luck. I'm going to sit.
All right. What do you mean light? Do you mean here?
Good luck.
Thank you. There is a... What is it? I guess what you have to stay. There's a camera. Are they recording this? No. There's a camera there, no? So I need to stay here.
I don't know nothing about it.
Nothing about it.
Okay.
Myślę, że możemy wystartować. Witam Państwa wszystkich na dzisiejszym wykładzie poświęconym, znaczy panelu poświęconym zagadnieniom ortopedii. Dzisiejszym wykładowcą będzie nam znakomicie znany i znakomity chirurg Ignacio Cavo, który został zaproszony z Hiszpanii, który został zaproszony przez firmę Phoenix Vet. Także dziękujemy bardzo za tą możliwość. Nacho jest już po raz trzeci na naszym kongresie i tak w sumie 4. raz w Polsce, ponieważ w maju był również wykładowcą na kursie AOVET, z którym również miałem być przyjemność razem z nim instruktorem. W związku z czym Nacho jest mocno związany już z Polską i czuje się prawie Polakiem. Nacho skończył studia w Hiszpanii, po czym po studiach wyjechał do Wielkiej Brytanii, aby zrobić specjalizację z chirurgii. Tam też pozostał, pracując na Uniwersytecie w Glasgow. Zrobił doktorat, zrobił specjalizację z chirurgii, stał się również dyplomowanym specjalistą europejskim w chirurgii weterynaryjnej i po tym czasie, po kilku latach wrócił, po kilkunastu latach wrócił do Hiszpanii, gdzie został szefem, obecnie jest szefem chirurgii w klinice weterynaryjnej Uniwersytetu Europea w Madrycie. Jest również, Ignacio jest również członkiem komisji egzaminacyjnej European School of Veterinary Surgery i pełni funkcję przewodniczącego AOVET na Europę i Południową Afrykę. Miałem osobiście przyjemność uczestniczyć kiedyś razem z Nacho jako uczestnicy w kursie Nano Total Hip Replacement w Cremonie. Byliśmy przy jednym stole, nie wiem czy Nacho pamięta, ale mówię szczerze i z pełnym jakby świadomością. Ten gość naprawdę wie, co robić w czasie chirurgii. Dajmy mu dzisiaj szansę, żeby przedstawił nam to, co ma do powiedzenia, a pierwszy wykład będzie dotyczył zwichnięć stawu łokciowego, tak? Stawu biodrowego i stawu łokciowego i będzie po tym 5 minut przerwy i drugi wykład dotyczący niechirurgicznego rozwiązywania uszkodzeń układu kostnego. Także pierwszy wykład zapraszamy i Nacho, the stage is yours.
Okay, thank you very much. Yeah, I remember our days in Cremona, operating little things, so great fun. So thank you very much for coming. As I mentioned, it's the third time in a row. I'm thinking about applying for Polish citizenship. So I may have some people here to sponsor me. But as long as you keep inviting me, I will keep coming. So we're going to be talking now about elbow and hip laxation, which are certainly hip is the most common joint laxation that we have in dogs and cats. Then elbow is not the second one. Probably the second one I will say is the tarsus. But it's the third one, and I think it's every so often you will see that. And I think I can add a little bit about the elbow laxation because it's something that we did a lot of study when I was in Glasgow, and I took part on development of techniques and things like that, which I think I would like to share with you guys. So hip laxation, this is a little bit the plan that we have. We're going to be talking about just very brief about etiology, how this happened, or when we need to be alert to certain things about how it happens. Patient assessment, just brief comments. So you have to remember that orthopedic surgeon, we are not just carpenters, so we also have know a little bit of medicine and look after the patients. Important anatomy, so we don't get confused when I'm talking about what I'm referring to. And then little tricks about diagnosis and the management that we have and surgical techniques. For me, normally when you have is a traumatic event, normally it's associated with high energy, normally road traffic accidents, and things like that, or fall from a significant height. So laxating a hip is not easy, and despite it's the most common, but it's not because it's a weak joint, it's the opposite. It's one of the strongest one that we have. Now, the important thing, and I put it there in bold, is what I refer to as spontaneous. So you always need, the same when you have a fracture, you need to ask yourself, does it make sense that this animal sustain a fracture? Implying, is it a pathological fracture? It's a fracture that is happening because it's a weakness in the bone. When we have a spontaneous laxation, means is this joint laxated without a real reason. And this automatically need to put alarm bells in our head and try to find out if there is anything which is making this joint weaker. Okay? Normally, in the hip, in my humble experience, I've seen two things normally associated with the spontaneous laxations. One, that you have hip dysplasia, and then you have a poor dorsal coverage on the acetabulum, which is one of the major stabilizers. So hip dysplasia should be high on why this happened. And then the other case that I've seen this is with neurological disease, in where you have some proprioceptive deficit, and then maybe the animal put the range of motion of the joint into funny angles that potentially can contribute to the laxation. Okay, very careful. And when we look at X-rays, very careful with the hip dysplasia. Obviously, we are going to have to look for other additional injuries, because if you have enough force to cause a hip laxation, you may have fractures or some internal damage or things like that. That's why we need to do a proper assessment. You know, it's very spectacular orthopedic condition, the laxation. Everybody goes next to X-ray and says, oh my God, look at the hip laxated. But it's not going to die from that. But it can die from a hemoabdomen, it can die for the problem. So obviously this is in terms of importance, we need to ascertain that the animal is stable, look at everything, blood work, ultrasound of the abdomen, chest X-ray, and just make sure that the animal is safe to undertake the treatment choice that we made. We can have things like that. This is a cat with a hip laxation that he have a diaphragmatic hernia, traumatic. So we need to look at these things. Sometimes they're very obvious, and certainly these take priority compared to the hip. Sometimes you look for the chest in case, and you have to be very careful because if you look like quickly, you say, oh, it looks okay. Actually, but if you look a bit more carefully, you will see that it has a rib fracture. Okay? I don't know if this works. Okay? If you look here, it has 2 rib fractures. It may have no clinical relevance because if suddenly this animal starts having some respiratory distress, maybe this move and they got a pneumothorax, or if it's hypoventilating under anesthesia or something, maybe it's because of this kind of, it's just good to know. Maybe we're not going to do anything different, but we need to look things very carefully, not really quickly in a corridor with no good lights and rush. Remember, this is something that I'll mention here. When you have an animal which is growing, or a puppy, sometimes it's easier. The weakest spot is not the joint, is the physeal, the capital physeal line. So it's often in puppies, it's more likely to have this kind of fractures than to actually have a luxation. But the point that I'm making here is looking, because if we have a hip luxation, we can have urinary tract issues, because you can have a pelvic fracture associated with the hip. And I think something really easy to do, and I will, in any doubt, recommend to do, is to do like retrograde urethrocystogram. It's very easy, and it's gonna, if you have any doubt in the history, it just can show the integrity of the distal urinary tract. And if there is a rupture or something, it's gonna be very, very obvious there, no? Then it's a different story how we're gonna be treating this. Obviously, analgesia, when we have established that the animal is fine, before we do anything else, let's control the pain and keep going with the work. This is really important, and this applies to all the joints. Maybe the importance of one of another, it varies with the joint. But when we have a joint, there is normally 3 groups of things that stabilize a joint. You have what is called the passive stabilizers, which is the tendon and ligaments. You have the active stabilizer, which is the muscles which are crossing the joint, and you have also the bone shape or the anatomy of the bone, which can play a help in to be more stable. For example, if we look at the hip, we have a really important primary stabilizer is the dorsal acetabular rim, the roof of the acetabulum. So you have hip dysplasia, this is going to be a problem. You're going to have much weaker joint. When we look at passive elements, we have a very good one, which is the round ligament that goes from the head of the femur to the acetabulum. And when we look about active stabilizers, we have the gluteal and the psoas muscles. Now, in the hip, the gluteal and the muscle, the active stabilizers, they play a little bit of a secondary role in stability. The important ones are the capsule, the round ligament, and the dorsal acetabular rim. For example, we are talking about the shoulder, it's totally the opposite. The big money is on the muscles, on the shoulder. So if you have muscle atrophy, you start having secondary pseudo instabilities in the shoulder. Okay, completely different story. Important anatomical considerations is in the acetabulum, we have this is cartilage. But here in the center, in this fossa, there is no cartilage. This is where the origin of the round ligament is. And here is where we're going to be having to drill stuff when we're going to do a hip toggle. And it's okay. It's like inside the joint, but it's not really articulating. Okay? This is the origin of the rectus femoris, and it's going to be a landmark for doing ilofemoral suture. Okay? These 2 things, we need to be very familiar to what we have there. Diagnosis normally is a no-way bearing lameness, and they come with this typical appearance where you have the kind of external rotation of the knee, and the leg is under the body. This is normally how they come. So an animal, if they're very stoic and very strong, they may sort of toe touch in a state when they're not walking, but normally with a hip luxation, it's a no-way bearing lameness. These are very simple anatomical landmarks that you can actually recognize in your consultation, and you can already have an idea that you have a luxation and speak to the owner. You're going to put your finger on the tuber ischii, you're going to put another finger on the greater trochanter, and you're going to put another finger on the dorsal iliac crest. And that, in a normal animal, make a triangle. Because the normal way of luxating the hip is craniodorsal. When you have a craniodorsal luxation, the red dot becoming the line between the green and the blue dot. And you can palpate that in the console, and then you're going to have a big idea that you have already a craniolateral, craniodorsal hip luxation. Diagnosis obviously is going to be the clinical signs, this examination, but you're going to have X-rays for sure. I have to confirm what you have it, to know the direction because it's going to influence how you're going to treat it, and to look for other concurrent disease or condition that you can have at the same time. Really important to look for X-rays. We're going to be fundamentally, when we're looking at specifically for the hip, looking, for example, if you think there is hip dysplasia or not, because that again is going to influence dramatically how you treat the luxation, and also looking, what I said, the direction, and remembering that in mature animals is more likely to have potentially a physeal fracture, a Salter-Harris fracture, than an actual luxation. Here, for example, you know, we need to be careful, and we need to assess this carefully. We know here that this hip is dysplastic, okay? This one is not the best X-ray. It certainly is luxated, for sure. But here, knowing that this one is dysplastic, I start to look at it with a lot of concern, okay? And if I look at this, I will be thinking potentially this acetabulum is a little bit shallow. So here, I don't see any osteophyte clearly. I will try to get a better X-ray, try to get a proper anterior-posterior and lateral. Lateral not going to help me that much, but anterior-posterior to make sure that this femur is okay, and have my concern about this acetabulum. So potentially, I will go to surgery with potentially two options, maybe to see whether I can keep it without doing anything, or maybe I need to be prepared. Maybe I had to change and do a hip replacement, or depending on the size, a femoral hernia excision. But be very careful, because if you have the hip dysplasia, you have poor dorsal coverage, and then your surgeries to keep the hip in place is in danger of failure, severe danger of failure. Close reduction is something that I would say do it, attend it. You know, even though you're going to be operating, if the hip is in place until you operate, it's giving comfort to the animal. Now, if you attend this, it's associated with 50% success, okay? 50% of hips that you put in place, they stay, and happy days, okay? So you need to use this towel or a rope with something soft, somebody to do counter force, and then you're gonna try to reduce that. What you're gonna have to do, because normally it's craniodorsal, you're gonna have to externally rotate the leg, so the neck and the head of the femur come out from the top of the ilium, so you get parallel to the iliac wing. You're gonna pull in a craniocaudal direction, so you can bring the head to where the acetabulum is. Then you're gonna derotate, and when you think you are in front of the acetabulum, you're gonna push medially, and you're gonna feel like a clunk that it goes in. Now, when you hear that, the next thing you're gonna do is to give it a good movement in case there is any hematoma or anything there that it can be dislodged, and then your head can be seated deeply, okay, deeper. When you have done that, you need to take an X-ray, because you need to document that your hip is in place, because it may come out. And then people say, well, you never put it in. Well, actually, I put it and it came out again. That's for once what you need to do. And secondly, you're going to have this X-ray, so you know for sure, because I've seen cases that people converted a craniodorsal luxation into a ventral luxation. So they felt, oh, it's sitting nice, but it's not. It's because it's below the ilium. So I've seen that from top to bottom. So X-ray, compulsory to know where we are. This is the description, okay? Describe it, no problem. We talk about close reduction. We need to discuss about this bandage, the Elmer sling. Personally, and the evidence doesn't suggest that it's a huge help in keeping the hip in place. The success between luxating or not luxating is not very clear related to the Elmer sling. And that concerned me because it's difficult to do. You need to be changing these bandages, at least in my opinion, weekly. And I don't think it has a huge difference. And don't like it, and I'll show you why. Different story is if you have a ventral luxation. Okay, ventral luxation, having this type of bandage, which is called a hobbled intertarsal bandage, is really good, because the movement that helps relaxating ventrally is for the animal to open the leg. So the head of the femur go down and then goes under the ilium. So this bandage is very useful. And I think my personal opinion and experience with ventral laxation is that conservative management tend to work a little bit better than craniodorsal, in my opinion. This is a picture of this emery sling. And I did my resident, it was mentioned before, in Glasgow. In Glasgow, it rains a lot. And it's nearly impossible to keep bandages dry. And then a wet bandage is like a death sentence. And these kind of things were not unusual. So we always underestimate the danger of bandages. And in new generations, I think we are not as good as in the past. There is a little bit of an art and technique in these things. And many people, we're losing this. And then a badly executed emery sling is dangerous. So, and in my hands, and in the science, it doesn't show me a great advantage. So I will put it, I will do a close reduction, assess stability. When I put it in, apart from moving, I will see whether it's immediately relaxating or not. If I reduce the hip and I put it to a normal range of motion and come out, automatically I'm gonna go for surgery. If I put it back in place and it gives me a sensation of stability, I speak to the owner. So you have 50-50 chance. Do you wanna try or shall we go for surgery? But if it come out again, we're gonna go for surgery. Some people say, let's wait. Some people say, nah, let's go anyway and fix it. Okay? Be careful with the bandages in general, and particularly inside hounds, like greyhounds or this animal that the skin is like paper. We have many techniques described, and there is one that people tend to ignore, and to me is the difference between failure and success, and it's capsular roughing, suturing the capsule. If you can do a good, strong capsular suture, which is not all the time, because sometimes the capsule is destroyed, but if you can actually get good chunks of capsule and do a decent closure, pretty much the literature says that success is 90%, only doing that. So if you can do a capsular repair and then use any other technique, I guarantee you your chances of failure are very little. Now, if your capsule is gone, then you have to be very careful, because we're losing one of the major stabilizers that we have in the hip. Okay? So we're going to talk briefly about all these techniques that we have there. And total hip replacement and femoral head excision, I will leave it for the animal, which is this plastic, depending on size, financial possibilities, and expertise. Open surgery, as I said, if you can go from the word go, or because of a failure of an open reduction. That's mainly the two indications. But you are entitled, and it's reasonable with a 50% failure, to go and do a hip surgery. Capsulorrhaphic with thick capsule. In a dog, we're talking about 0, polydiaxonon, PDS, so long-lasting absorbing suture, but heavy gauge. So not to 0, we're talking about 0 or 1 to really have a strong holding power. Iliofemoral suture, perfectly valid technique. Probably would say easy to do. It works on craniodorsal. In my opinion, better in small animals, like lighter animals than heavier animals. But it doesn't work on ventral laxations. So you have a ventral laxation, this is not your technique. Depending on the size, we're going to be using different size of drill bits, okay? But normally around 2.0, 2.5 is going to be the size of holes that we're going to make on average. 2 will be for small animals and 2.5 for big ones. And we're going to have to do, in principle, two holes, because we're going to be anchoring a suture between the subtrochanterically on the neck of the femur, and we're going to be anchoring really close to the origin of the rectus femoris. Like that, okay? Ideally. This distance is very variable between breeds and animals. So sometimes you don't have really physical space. So anyway, I would say on the proximity of this prominence, being clever that your suture is not going to be trapping the rectus femoris, but it's going to be anywhere around here where you're going to be putting your suture. And normally what you do is you do a tunnel in an angle, so you don't want to make a hole perpendicular to the iliac wing, because you're not going to be able to catch the nylon or the suture from the other side. You want it to come on a proximal to distal angulation, so you can catch the suture just underneath ventrally here. By doing a mini approach and then sometimes blindly passing a mosquito and grabbing this nylon and bringing it forward. Okay? Then this works better if you convert that in a figure of 8. So you're going to bring this down and this up, so it's like in a figure of 8, not a circling suture. And then what you're gonna do next is to make a hole on the femur, okay? It has to be thereabouts at the end of the trochanter, more or less where the dog is. And I will say reasonably close to this side, this aspect of the bone. And I will say I would like to divide this into, let's say it's 3 centimeters, okay? Leave a third between the hole and the cortex. Okay, so don't do it too close that you end up weakening the area, potentially having a fracture. Okay. So basically what you're gonna do, you're gonna get this suture, and you're gonna pass it from cranial to caudal through this hole. When you drill this hole, be careful that you have the sciatic nerve behind. So with a lot of control. Then you're gonna pass this behind the trochanter and forward in the dog. And you can do this blindly by passing a mosquito under the gluteal muscle, so you don't trap the gluteal muscle. Under the gluteal muscle, behind the trochanter. And then you bring this forward. And then this is gonna be attached to this. And depending what you're using nylon, you can do this metallic crimp, this tube, that you like for extracapsular repair. If you're using some kind of braided strong suture like Liga Fiba, whatever you want to use, then you can knot it. It's important before you knot it that you abduct a little bit and internally rotate a little bit the hip to maximize contact and to put it in a much more stable position. Okay? Results. Not very long series, 14 cases, 20 cases, with something around 80 to 85% success. You at the same time can use these things, suture anchors. I don't tend to like them too much because I feel that sometimes they can be like sort of sewing the suture with movement. Then make sure that it's really, really blunt and there is no sharpness to this eyelet. And the position of this, to me, is a little bit farther up. I would like it to have closer to this promontory where this little mountain where the rectus femoris starts. Next one is the hip toggle. The hip toggle is a replacement of the round ligament, one of the primary stabilizers. Okay? This can be used in cats, in dogs, anywhere. There is sizes for everything. And the toggle is a little metallic tube that we have here that it comes with a hole in the middle. So you can loop through that a strand of nylon or any of these sutures. You can actually make it in principle with a K-wire, but this costs nothing and is much nicer. We're going to have to make a hole there in the origin of the round ligament, and you're going to have to use a big drill bit. We're talking about maybe in a German Shepherd 3.5, even 4. Okay, because you need a big hole to pass that metallic tube with the suture, with a couple of strands of suture. So we're going to make that hole, and we're going to put this longitudinally through the hole with the nylon. Then when you put it here, you're going to have to get a mosquito, straight mosquito, and push it until it's completely on the middle aspect of the acetabulum on the pelvic cavity. And then you're going to grab it and you're going to pull. And you're hoping that that little bar is going to stay against the wall, anchoring that round ligament. Then you're going to have to you're going to externally rotate the femur, and you're going to go on a normal grade fashion, in my experience, better, from the insertion of the round ligament, and following the neck, you're going to make a tunnel, maybe 2 millimeter drill bit, 2.5, depending on the size of the animal. And it's going to come out subtrochanterically here. Okay? Now, you can do that free-handed. You do this with a C-arm. You do it whatever you want. But it's easier for me from here to here. And you need to see the neck. When I do my cranolateral approach to the neck, to the hip, I will do the normal thing. I will identify the middle gluteal. I will identify the deep gluteal. I will do a partial tenotomy of the deep gluteal. I will externally rotate the leg so I can see the neck, and then I will put my scalpel over the capsule, and I will go all the way and I will cut a little bit of the vastus lateralis. In that way, I can reflect it and I can actually see the neck completely. Okay? That's really important to know what you're doing, and particularly to know where the neck is and to get your angle right. If you don't get your angle right, your suture is going to be working in a weird angle and it's going to break prematurely, your round ligament prosthesis. Then you are going to have to bring the two strands that you have on the acetabulum through your tunnel, and then you have two options. Well, you have three options, really, many options. But one of them is you have the two strands, and then you have these plastic buttons that you put one of each strand, and then you knot that. You make that knot on the back of the femur so that round ligament is under tension. And you have put your head in the acetabulum, you move it well seated, a little bit of internal rotation, a little bit of adduction, and then you tighten that strongly. You can use this. You can use another toggle that you can have. Just pass one strand through the toggle and use the toggle to knot it. If you don't want to spend much money, you can make a hole a little bit, well, the same level, a little bit below the iliofemoral suture one, and then you can get one of the strands and pass it through the hole and then knot it. Whatever, I don't care. Okay? But that you are with reasonable tension, and then put that hip through a range of motion to make sure there is no tension, there is no pulling anywhere, there is no coming out. Do a test. Now, I'll tell you something after this technique. This is how it's a luxation. It's a ventral one. I told you iliofemoral suture don't work well here. That for me would be a hip toggle, yes or yes, a ventral luxation. This is how it looks, and this is how it looks. And you need to see how the tunnel is following the neck. And it looks a little bit ventral because the insertion of the round ligament is not in the center of the head. It's a little bit ventral. Okay? This is how it looks. Outcome, 80%, 85%. They're all, apart from the capsulorrhaphic, which is in 90s, everybody's in the 80% of success. Okay? Before I speak about this, I make a little comment here. To me, if the capsule is intact, I will suture the capsule, intact, reconstructible. I don't care which technique you use. My personal preference is the hip toggle, but an iliofemoral suture can be done. If the capsule is smashed, it cannot suture completely, I will combine routinely the hip toggle and the iliofemoral suture. Both of them, they can be done together. They don't interfere. One is intra-articular, the other one is extra-articular. And certainly in an animal which is more than 25 kilos. If the capsule is gone, I'll combine both. And I'm writing on this and waiting to get more cases, but I have potentially, I think the last time I checked, 27 or 28 consecutive, more than 30 kilos luxation of dogs that at the moment have zero relaxation using that criteria. Like, if the capsule is good, I'll use one. If the capsule is gone, I use both. And I have zero relaxation in 27, or no, now maybe in 30. It's not a huge number. I want to get to 50 or 100, and I will publish it. But I think this combination could actually change from 80% success to very close to 100% success. And when you are there doing a iliofemoral suture, it adds 15 minutes to the surgery. It's not a crazy amount of time that you are doing. Transarticular pinning was very, very useful, well, very popular in UK for a while. I don't like it. You know, in cats they were used, but it's an alternative in maybe in a small animal with ventral luxation. You may consider doing that. And basically it's doing what it says on the name. It's putting a K-wire, a stamen, it's not a K-wire, it's a stamen pin in the similar direction of the tunnel for the hip toggle with a pin and then pinning the femoral head to the acetabulum. This is important because the main complication that you have with this technique is breakage of the pin. And the problem is because you undersize the pin. So this list is the clue to less failure. But realistically, what you need to memorize is the first one. 0 to 7, 0 to 8. I don't know how to do it any bigger. And I tell you it's 1.6. Okay? So in a cat, it's a 1.6, which is when you're potentially going to consider doing this. And that's the direction. My advice is to try to get a drill bit, which is 3-4 millimeters smaller in diameter than your pin, maybe a 1.1 or 1.2, very carefully, and I will pre-drill this. And then I will reduce that, and I will normal grade my pin. But knowing exactly what is coming out, and with not a huge deal of resistance, because one of the complications I'll be reporting is like osteonecrosis of doing this procedure in the head. Ventral laxation, small dog. Pin is difficult to get good x-ray because the animal cannot abduct the leg. It can only go backwards and forward, okay? It's like one of these table football. You're converting the dog in a table football little man. It can only move in that direction. Important thing is that you bend over this, because if you don't bend this can migrate interpelvically. And you need to do a second procedure to remove it between 3 and 5 weeks, depending on the hassle that you have with the case, okay? And the success is not, it's okay, it's not amazing. So I'd rather do anything else apart from that. This is not any of my technique of choice. As I said, breakage of the implant is one of the big things, and there's also necrosis, that's why I like to pre-drill a little bit to make the passing of the pin a little bit easier. In this case, it migrated, and I had to take the pin out, but you need to be very careful. When you pass it through the medial wall, the rectum is closed. So you need to be very, very controlling when you pass the pin. And sometimes I remember you are unsure and you have somebody which is not in the surgical field doing a rectal palpation to make sure that you haven't gone too far. This is a technique that is reported. I never use it, to be honest. I have no much experience with this technique. But the idea is to sort of try to make a fake capsule, at least dorsally, to get some support. Okay, you do a transverse hole on the neck, and then you anchor it with this screw and washer, and this kind of dorsally, to try to replicate some kind of capsule. I never use it. I don't know anybody that used this as a first line of technique, but it's there, so I want just to show. Scrutinizing x-rays, this dog, flat coat retriever, had dysplasia, but he had a laxation, chronic. And I used to do, this was for a charity in UK, and they will pay hip replacement, and I was gonna do a hip replacement in this dog, but when I went there, I could not reduce the hip. And then I thought it was gonna be high chance of failure in this hip replacement. It was a light dog, and I converted it to a femoral neck excision. Important to remember, the angles that are correct, you can take the lesser trochanter, but you cannot leave a spur here, okay? When you're cutting, remember, 2 planes. No, it's not only the direction, but it's that your angulation. You have to be perpendicular to the neck. You don't want to have an angle that you leave a spur on the other side. And always feel with your hand the cut when you've done it. In the cut, don't freak out if you see the lesser trochanter. It's in a different plane. You're never going to cut it. It's not interfering with your osteotomy. Anatomy. Okay? This is how far you can push a femoral neck excision. There is a paper from 2007 in JAHA, in the United American Animal Hospital Association. They did single surgery, simultaneous femoral neck excision in dog with hip dysplasia between 1 and 2 years of age and 20 and 30 kilos. They say that the initial recovery was hard. I can guess that. But important thing with the femoral head and neck excision, 2 factors that may help you predict whether you're going to be good or bad. The younger and the lighter the patient, the better. This procedure is done in humans. My father was a hip surgeon, and he told me that I think it's the same. He said, you do this procedure in a young, athletic person, it's going to work. If you do this in a heavy, obese adult person, it's going to be in a wheelchair. And I think more or less apply in dogs. Hip replacement is always an option. We have different possibilities, cementless, hybrid, cemented, whatever we want. And this is my approach to hip laxation. I will do a close reduction under GA. Careful assessment of stability. I will not use an MR sling. I will use hobbles if this is a ventral laxation. It's still unstable and craniodorsal. I'll do a iliofemoral suture of a toggle if I can close the capsule. If the capsule is not being able to be closed, I will combine those 2. If it's ventral, I will potentially do a toggle pin, and I don't care really about the capsule that much in that case. So on canine rental, I will try conservative under GA, but if it fails, I will do a toggle quite relaxed. Oh, sorry. Okay? With this plastic, femoral hand excision of total hip replacement. How am I doing? 10 minutes, no? 10 minutes, good. So elbow laxation, okay, third joint in frequency that get laxated. Normally lateral, okay. Severe trauma, like road traffic accident or a dog or a cat that got stuck in a fence and is sort of hanging from the leg and then moving around and then it laxate the elbow. No weight bearing, they come with the leg normally flexed and supinated. Super painful. Sometimes they can have some neuropraxia. There is a branch of the radial nerve that goes, it comes like cranial to the extensor carporadialis and then cross the joint and it goes under the supinator. So in that region, there are motor branches crossing the elbow. So it could have neurodeficit distal to the elbow, but it can happen. Okay? The anesthesia to be able to reduce this. I'm gonna make a comment now between dogs and cats. They have nothing to do with the anatomy here, and they don't have anything to do in the outcome. So when you're considering a close reduction, which is what we're gonna be speaking next, in dogs it's associated with something like 70 to 80% success with close reduction and subsequent bandages, which is a pain in the neck. So, and when surgery success is pretty much 98% success with surgery. So even in the dog, I will go for surgery because I think it's more convenient for everybody. But in cats, the success of conservative treatment is 60%. So in cat, it's 100% surgery to me, with 100% success in a case series of 37 cats that we did. So elbow laxation in cats, surgery. The elbow in the cat is completely different. You need to have both collateral ligaments ruptured to be able to laxate. Whether in the dog, with the lateral only, you can laxate the elbow. So in cats, elbow laxation represents a much more severe soft tissue injury. And also the cat hasn't got a very prominent anconeus and a fossa for the anconeus to go. So it relies much more heavily in soft tissue, whether in the dog, the anconeus is one of the primary stabilizers in extension. So it's a different concept. So better outcome in conservative management in dog than in cats for different anatomical reasons. This is the technique. This is taken from Fossum, the book. How to do it, you're gonna put in 100 degrees in flexion. You're gonna inwardly rotate antebrachium and push with your hand to hook the anconeus on the back of the humerus. Okay, sorry, the humerus, okay? Then when you have it hooked there, you are gonna basically start extending the elbow while you apply medial pressure on the radial head until it goes in, and you will hear pop, okay? Then X-ray, and then what you're gonna do after that, you're gonna check the stability, and you check that by doing the Campbell test. And the Campbell test is with the elbow in flexion, you are gonna pronate and supinate. Because you're pronating and supinating, you're gonna be challenging medial and lateral collateral. And you're gonna be seeing in which direction the elbow relax. That's the way an elbow is gonna relaxate, by doing the Campbell test. If you do the Campbell test and the angles are augmented, but the elbow is not relaxating, you may be thinking that you're into a winner. But again, you're gonna have to put the dog on a spica or spica spleen. You're gonna have to change this every 5-6 days, and it's an absolute hassle for the owner and for the dog. Whether you do surgery, that's it. You don't need to do anything. You do surgery, confine the animal into a small area for 6 weeks, and that's it. If you have trouble reducing, particularly in chronic cases, intraoperatively, you can use a major scissor as a shoehorn to try to help you bring the bone wherever it goes. Careful, because it's going to potentially damage the cartilage. And has been reported to do olecranon osteotomy. I've never done that, and I've never seen anybody need to do an olecranon osteotomy to reduce an elbow. The major scissor trick, I've done it a couple of times in my life. This is the spica spleen, pain in the ass for the dog with extension leg like this, causing rubbing and issues. So if you do it, for financial constraint, do it. But I think surgery have better prognosis. Okay, surgery better. And the technique that we're going to be using is this, the tunnel ligaments. We call it the Glasgow technique because it was done in Glasgow. Some people call it the Farrell suture, which is my supervisor who invented it. And it's a little bit a cumbersome procedure, but it's actually very good. You're going to be doing 3 holes, one as you were doing at the level of the epicondyle, as you were doing a screw for a fracture. You're going to do one on the head of the radius and one halfway between the articular surface and the end in the ulna. You're going to pass 2 strands of whatever suture. In cats, PDS 1 or something like that could work. In dogs, nylon, in my preference. And so you're going to have to do a mini approach medially. Okay? And then you're going to pass these 2 strands with some, you're going to put some needles from lateral to medial. You're going to feed this nylon through the muscles on the medial side. Then you're going to put, you have 2 strands of the way. You're going to put 1 needle here and 1 needle here. It has to be big needles, pink or above, so you can feed suture through the core of the needle. And then when you have these 2 strands in the middle side, and you have 1 needle from lateral to medial, you are going to try to pass a mosquito forceps, sliding over this needle through the muscle until you touch the bone, and then you're going to turn around, and then until you sort of come parallel to the suture, and you can grab it and bringing close to the bone, out into the needle and out. Okay, this is hard to see speaking about it, but it's better to do in a wet lab. So you have an opportunity to do this, or do it because it's very useful. A trick that was suggested by one of your colleagues yesterday to me, instead of doing this thing of the mosquito, putting it through the needle and grabbing, is potentially using a favela needle. And then you can hook it, maybe the needle, and then you can actually pass it around so behind the muscle. And the idea is not to trap muscle medially, because you trap muscle medially, you have the median nerve around there. So you need to find a way to pass these sutures really medially against the bone, not on top of the muscle. And the same for this one. And then basically what you're going to do, you're going to have 2 strands here, one here, and then you're going to knot it, and you're going to have like a loop here and a loop there. Okay? And that doesn't need any bandaging, anything. Just needs 6 weeks for the animal to be calm. In some chronic cases that you have, probably this is the most chronic elbow I ever treated. So I don't know how it's going to be. I don't know how the cards, but the people were adamant because we don't have real alternative in the elbow. So we don't have a good elbow replacement. We don't have good result with arthrodesis. So in the elbow, sometimes you are a little bit pushed. So maybe it was 3 weeks out. And I thought, let's see how it goes. So it was really hard to reduce. I had to use one of the cases that I used the Mayo scissor trick. So I managed to put it back in place. As you can see my holes for the Farrell technique. This has a little bit a different orientation. I like to start a little bit caudal and try to come a little bit cranial to avoid with this tunnel the coronoid process, which is on the other side. Okay. But I did this process, but I thought that it was so unstable, and I felt like like this elbow wanted to laxate. I thought I'm holding it with the suture, but I think this suture is working harder than usual. So I decided to do something, which is to put a transarticular external fixator to protect. You can see this pocket that is done because of the chronicity. So I put a transarticular type 1A fixator with an A-frame type of connecting bar, 1 long bar here, 1 short bar here, and then keep it there for 3-4 weeks, and then take it out, and then the animal did surprisingly well. Okay? I think I finish here. Questions? Are there any questions? Otherwise, I'm changing.
Tak, mamy pytanie. Okej. Mamy tu pytania do Nacio. Jedno z pytań jest takie. Czy zastosował pan doktor zawiasowe, pozwalające na ruch w jednej płaszczyźnie, stabilizatory zewnętrzne w przypadku zwichnięć stawu biodrowego? Podpowiem, że tu chodzi prawdopodobnie o stabilizator zewnętrzny po redukcji zamkniętej zwichnięcia, aby zabezpieczyć przed ponownym zwichnięciem. Wprowadzało się, taka technika była, miałem okazję też jej stosować, technika wprowadzenia prętów gwintowanych w guz, w talerz kości biodrowej, w kość kulszową i pod krętarzem. I połączenia tego, także zapytajmy się naszego prelegenta.
Sorry, repeat the question, we're going to go late with this. What is the actual question?
About the external fixator to stabilize in the hip.
Yeah.
After the
Yeah. I heard what Jacek was saying, and I have no experience using that technique. I know it's reported, and it makes sense. Now, the question is, with my technique of combining with my sort of line of thinking in switching the capsule and then doing one technique of if the capsule is not working and combining the other two techniques, realistically, I have no relaxations. So I never been myself in a situation to having to do the external fixator. As I said, I have no personal experience, but I have no need in general terms to use that technique with my approach.
Mamy jeszcze jedno pytanie. Czy w metodzie toggle pin stosuje się tensiometr w celu określenia odpowiedniego naprężenia tworzonego więzadła głowy kości udowej? Jeżeli tak, to jakie jest nastawienie tensometru?
They didn't translate that. Or is dead? I can hear you now, yes. Yeah. No, I don't use any kind of device to see the tension. I guess I'm used because of hip replacement to have, when you do a hip replacement and you are looking for the tension, when you put the hip replacement, you have this kind of feeling of there is a little bit of give way, but you cannot laxate it. So I totally do it by subjective feeling. And I think everybody does the same. I don't think that the tension in terms of Newton is a factor for failure in the hip toggle. I think the failure of hip toggle mostly is the wrong direction of the tunnel on the femur. So you're just gonna put the hip in place and you're gonna tighten it. There is no possibility really, I think, that you're gonna over tight the hip toggle in the direction that it's going. It's not really something you're gonna be causing such force that you're gonna be preventing the movement. And at the same time, getting it too loose, if you're keeping pressure immediately when you're doing the knotting, again, it's very difficult. I don't see it's a real clinical problem, the tension on the hip toggle.
Dziękujemy bardzo. Nacho, we can go to the next one. The time, yeah? Przechodzimy do następnego wykładu, który będzie dotyczył niechirurgicznego zaopatrywania pacjentów z uszkodzeniami układu kostnego.
Cool. Okay. This is one lecture that sometimes is like a. What's that? I think of 5 minutes, no? 1 minute. Okay. Okay. They're changing. Good. Okay. This one is normally the only time that non-orthopedic surgeon come to see me. It's the opportunity to see friends that don't like orthopedics. Because we're going to try to be talking about conditions that you can see even in first opinion practice, that you see very routinely, and that with hopefully with the information that I'm going to give you today, you're going to be in a situation to be able to treat this as well, if no better than a specialist or a diplomat, because the management of this condition is based on recognition and pure knowledge and understanding of the treatment. So we're going to be talking initially about this kind of growth, bone and joint disease, and then a little bit about some medical condition, just to situation that not everybody or any animal that have some deformity in the leg or some pathology needs to go through the knife, okay? We're talking about the panosteitis, okay? It's a cell-limiting condition. This is the good news, okay? So you're going to be giving positive news to these animals or these owners. It's a cell-limiting bone disease affecting the medullary canal, at least radiographically and clinically. Included, the incidence is around 2.6 per 1,000 cases, something like that. So many people will see 1,000 cases a year, maybe in a practice. So it's something you're going to be seeing with relatively frequency. So it's something you need to know and you need to recognize, okay? It's important to know, and I'm going to try to be giving you statistics to make you sort of suspect that this is probably the possibility. So you can, when you start ticking boxes, you say this is going to be, and you're going to be looking for this. So I tell you, it's much more common in the front limb than in the hind limb. 4 times more likely to be present in the front limb than in the hind limb. Okay? Now, it's true that it's typical on the description from the owners, what they define as a jumping lameness. So maybe it was limping in the right fore, then in the left fore, then in the right hind, and things like that. So it's often that you can have lameness that is coming and going in different limbs. The good thing about this is that you don't need referral, you don't need a specialist to deal with this. It can be done in any clinics. And also it generates follow-up, consultation, and investigation. So it's a good condition. It's an opportunity to engage the owner. It's an opportunity for the owner to trust you and to know that you know what you're talking about. The good thing is that you're going to actually tell them not to worry, this is going to be okay. So it's a very positive disease. We thought that it's 4 times more likely to be affecting the forelimb, and specifically it's going to be affecting the number one joint, or number one bone is the ulna. So we're going to have lesions in the ulna in 42% of the time. And then the radius, 25%. And then the humerus. And then lately, it's going to be femur and tibia in the real leg. But by far, more common in the forelimb. Ulna and radius, number one in this condition. These other risk factors, they are very, very breed-related condition. The number one is that fellow over there, the German Shepherd. But you also have it in other animals like Rottweilers, Airedale Terriers, Cockers, Afghan Hound, whatever, many of them. But the German Shepherd, by far, number one. So now you have a German Shepherd that, you know, is painful when you palpate the ulna. You start thinking, maybe it's this, maybe it's this. But let's get more data. Age is another key factor here. And this key factor is that is normally between, I would say, 5 and 12 months, where is the peak in this disease. But it has been reported as young as probably 2 months, potentially up to 5 years. That's very weird, okay? Because we always think about panosteitis as a growing animal disease, okay? But I personally have cases diagnosed with 2 years. So I would not say 5 years is an anecdote. It's not very common. But certainly up to 2 years, I have cases, one case actually, let's be honest, diagnosed. So be careful that it's not just up to the 1 year of age that you can diagnose this. And it's a sex predisposition. Males are much more likely to have this disease, so 4 times more likely. So you have an animal maybe of 7 months, which is a German Shepherd, which is limping in the forearm, which when you palpate the ulna is painful, and on top of that is male, you can start thinking that you are getting to the diagnosis. More risk factor, and this is an important thing how you need to evaluate evidence. Because it's saying that if you are a dog, a young dog, okay, which is less than 1 year of age and is heavier than 23, you are 3 times more likely in female and 5 times more likely in dogs that you were lighter. So, but this is not giving me much information. It's describing the breeds which are affected by this. This is a different way of telling me the breeds. It's not a matter of weight. It's not because of the fat. This is describing me the breeds affected. Okay, so somebody needed to publish a paper and they did this. Then this is something that not many people know. You know, sometimes you go certain times of the year to the forest to pick mushrooms, but there is the season of the panosteitis, okay? So the more common is in summer and autumn. So we are now on the panosteitis season. So now potentially is more likely to come to your clinic. We have some hesitation about really what it is. Well, we know that the characteristic, and we can see radiographically, we make mention about this, is these images in X-ray that in England or in English is categorized, like you say, they call it the thumbprint on an X-ray. It's like you have like a dirty fingers and you put your thumb in a glass or a thumb in an X-ray. This is the pathognomonic sign of panosteitis in dogs. But what it is, this whitening on the medullary cavity. There were some concerns it was something to do with vascular proliferation and congestion, or sometimes there are new bones, sometimes they can have a little bit of periosteal reaction. But what we know, we believe there is some kind of increased intramedullary pressure that caused the problem. And the current thought or the evidence that we have is like some kind of protein accumulation there that we don't really know why, but there seems to be an accumulation of protein material there which cause increased pressure inside and cause pain. When you have panosteitis, it's painful to palpate. So the palpation of the bone is painful. This is the study that actually more recently said that the idea is some kind of protein or amino acid metabolism is affected in this dog with panosteitis, and therefore we think we have these accumulations there, okay? The good thing is that it goes away. Diagnosis is going to be anamnesis. It's going to be the breed, the age, what we discussed already. It's a male, forelimb, pain on palpation, all this stuff, okay? You're going to be doing X-ray because sometimes you can have different lesions in different bones. And basically your differential diagnosis, to me, mainly is two of them. Metaphyseal osteopathy, because it's a disease that we will see that it could be in the similar areas. Or I will say elbow dysplasia, because again, those breeds are prone to. And sometimes when you are manipulating the elbow, thinking that what you have is elbow pain, it's not elbow pain. It's pain because you are holding the ulna or you're holding the radius to do the movement. So it could be easy that you get confused. And sometimes you are not confused. The animal has elbow dysplasia and panosteitis. The whole thing can happen at the same time. And then you will need to decide what is the problem. Is the elbow dysplasia or is the panosteitis? And then you will do a more thorough exam, try to touch the ulna individually in isolation to see the pain is coming from there or the pain is coming from the manipulation of the elbow. Treatment normally is easy, is rest and analgesia. Normally we will use non-steroidals, anti-inflammatory drugs. Maybe they are for 10 days, 2 weeks, and not much. But there was a pilot study with this coumarin, which is a proteolytic medication that actually helped to eliminate the clinical signs very fast. I put it there. I have no experience using that drug, but just in case you were to have a case which is really you are not able to control, you know that there is a plan B that you can execute there. What is important is this, that relapses are possible. So they are like moments of outbursts of pain and these things. But the good news is, and you can tell the owner, that the severity of these outbursts of pain with panosteitis decrease with frequency. So the next one is going to be less painful. And also they're going to be sequentially, they're going to be spaced more and more. So you're going to have it maybe in a month or maybe in 2 months and things like that. So they tend to go, subsequent moments of pain are less intensity and each time more space, more separated one from each other. Metaphyseal osteopathy, okay, is a bone disease of fast-growing dogs. The difference here is the incidence is 2.8 per 100,000. The other one was similar but per 1,000. So panosteitis is much more common than this, okay? Age of presentation is different. This is younger, normally between 2 and 6 months of age. Breeds, some of them are similar, like German Shepherd dog, or Labrador, or Boxer también. Great Dane is not very common with panosteitis, but yes with metaphyseal osteopathy. Irish Setter is typical as well. All these kind of big dogs like Irish Wolfhound, all this stuff can have this condition. It's fast-growing and large breed is the one I see more often with this condition. They also have a little bit of preference for male, 2.3 more likely to be male than female with this condition. And also a little bit of season. You have more cases in autumn and the less in winter. So we are now in the season of the bone pain and disorder. So we have, it's now the time for seeing panosteitis and to see metaphyseal osteopathy. This is, in cats, this is not happening. There is only one poor cat in the world that have had this condition. That guy is the only poor bugger in the world to have metaphyseal osteopathy. Now, in the British literature, they refer as metaphyseal osteopathy to a different condition, which is these cats that they're a bit fat, that they have a spontaneous fracture of the physis of the femoral head. This is referred as metaphyseal osteopathy in the UK, which is not the same here. Easy diagnosis, okay? Generates revenue because you need to do tests, blood tests, maybe hospitalization because this animal can be really painful. Opportunity to engage the owner again. Prognosis is generally good, but some cases can be difficult to control. I remember one case that I have in UK that it has to be hospitalized with a methadone, really, really painful. So this condition could be much more severe than the panosteitis. And this one can have fever associated to them, anorexia. With this condition, the animals can get really sick in some cases. What is it? What is happening? What is happening in this anatomical specimen? The clinical sign is what we call the double line. It's a double radiolucent line on X-ray. It looks like a double growth plate. One growth plate is a growth plate, cartilage, and the other one is nothing, death, bone necrosis. This second line is a bone necrosis, okay? That's what happened. The X-ray is an X-ray of that. Etiology has been a lot of possibilities said in the past. Vitamin C deficiency, overfeeding, hereditary, and that's true. That one is true. Infection. They saw in one case E. coli and they thought it might be infection, but there's no really evidence. Vaccine related. It could be, it's not unusual that you have a vaccine and then a few weeks later you have this. So that has not been proven, but I can believe it. And then the Weimaraner, as a breed, they are predisposed to the condition. But I think it's multifactorial. Now, in the Weimaraner, that I don't need necessarily to say that it's in every single dog that this happened, it seemed to be a little bit of an autoinflammatory disorder, immune-mediated to a certain degree, okay? They found some high levels of some kind of interleukins and things like that potentially means that it could be related with some kind of autoinflammatory disorder. Diagnosis is going to be this. It's going to be this double line that you see here. And these animals, they also have this swelling. They have like swelling over the metaphyseal region, okay? And again, it's painful on palpation. And these animals, they sometimes, more often than not, they look ill. They are depressed, anorexic, some can have diarrhea, fever, and they are quite painful in many cases, okay? We're gonna have X-rays, and the more common location for this clinical signs, again, is distal radius and ulna, and also in the tibia. So that's why it's one of the differential that you're gonna have in relation with the that you're gonna have in relation to panosteitis in many instances. Differential diagnosis, I would say panosteitis because of age, region could be there. IMPA, I would say immunomediated polyarthritis because sometimes it could be several metaphyseal regions which are inflamed and you may get confused and think that we are talking about the joint itself, and it's not the joint, it's the metaphyseal region. But it could be a possibility, clinically, at least when you see the animal, and the animal could be with fever, it could be lethargic, it could be not feeling very well. So it could be, will be. Septic polyarthritis is very rare. You know, multiple joints affected, but could potentially be the same. I've seen it maybe in newborn or quite young animals, or some animal with some kind of severe condition that you have bacterial translocation. And potentially you can get confused with some septic fasciitis, which is quite weird, but sometimes it's a condition that you can see, an infection of the growth plate. How are we gonna treat this is the important thing. Normally it's self-limiting. It could be over weeks or months. Sometimes it could be a pain in the neck to go away. You are gonna have to consider analgesia, proper analgesia in moments when the animal is really bad, even to the point of having to hospitalize the animals. And then your major decision is gonna be whether to use non-steroidals or steroids. That's gonna be the main decision. In any case, although there is no huge evidence. If there is not having a balanced diet, I will put a balanced commercial diet just in case. But we know that in Weimaraner's, steroids works better. We know that Weimaraner has some kind of auto-inflammatory condition that has not been proven in any other breed. So we cannot generalize what is happening in Weimaraners to what happens to any other dog. Okay? One thing that we need to warn the owners is because this necrosis is really close to the growth plate. And these are large growing dogs. Okay? And sometimes you can have premature, complete, or partial closure of the growth plates associated with this condition as a consequence. So when you have this, you can say we need to be very vigilant that your dog is not starting to develop weird shaped bones, because if that's the case, you need to come to me and I need to x-ray and see what's going on, because we may have a chance to do something like potentially an ulnar ostectomy and correct a big mess that we may have trouble if we are a bit calm dealing with it. This is the Weimaraner, okay? And they did a study quite good. They are all related genetically, these Weimaraners. And they have something like 22 or something like that, 22, 25. So there were two groups, pretty homogeneous. No huge number, but good enough. And so they give non-steroidals to a group of them, and they give steroids to the other group, okay? So to the group of non-steroidals, half of them, they sort of resolve, and there were half of them that after 6-7 days, the animal was not getting any better, okay? So to those that they were not getting any better, they switch and they gave it steroids, and all of them resolve, okay? And in the group of steroids from the word go, they all work. So how we'll approach a Weimaraner, depending on the severity, if the animal is bad, I will go for steroids. There you go, from the word go. It is mildly affected, I may try with the non-steroidals, but in the moment that I don't getting a response, I will switch to steroids. Now, this is suspecting this auto-inflammatory condition in Weimaraners, how they will translate to another breed. I will personally try with non-steroidals, but in one of these cases, the animal is very painful, I'm not getting no manage to control the condition, I will switch to a steroid. A bit more, not as fast, and I will use it on a Weimaraner, but I know that if I'm not controlling my metaphyseal osteopathy with non-steroidals, I'll switch it to steroids, which is in here. The dose that we're using, I think they were using something like 1 milligram per kilogram once a day here. So at the top range of anti-inflammatory, the steroid. They were not immunosuppressing these animals. Carpal laxity syndrome, okay? And this is something that occasionally we see, okay? Also known as carpal flexural disease. And you're gonna have it comes in two forms. You have hyperflexion and you have hyperextension. You can guess why it's called like that. This guy that you have in the background, he has a hyperflexion. The other ones, they will be plantigrade, a hyperextension, okay? And it has to do because depends on the flexor and extensor dominance. It's an imbalance between flexor and extensors. This is what is happening. They are young animals, okay? This is like puppy between 6 and 16 weeks of age. So real young. More common in big breeds. In my experience, I don't know why, and I don't think a specific breed, but what I've seen is Rottweilers. I've seen this in Rottweilers, my opinion, more than the rest, but it's subjective out of 10 cases in my life. You know, so put in context, it's a very small sample population that I'm giving this. Here we have a little picture of hyperextension, like plantigrade, okay? Could be uni or bilateral. In my opinion, experience more often than not bilateral. Unknown cause, maybe some genetic predisposition because there are some potential breeds that can be involved perhaps, but I think environment plays a huge role here. And particularly with the type of flooring, if you have these puppies in slippery floors, that they don't have grip, it's like the muscle don't develop. Or for example, if you have typical thing that you have a litter of puppies in a box, and depending on the size of the box, if they are all cramped together, it's a situation that they are like jumping on top of each other, but they're not really having a good grip, a good opportunity for the muscles to develop. Diagnosis is going to be, this is non-painful for starters. So the animal, you can manipulate the carpus, doesn't care. It's zero painful. X-rays are normal. You know, there are no abnormality whatsoever. And then when you palpate the leg, it's quite normal. There is no ligamentous issues. There is nothing, okay? And also the age and no trauma. So very young puppy with no trauma, big breeds. You see this, and you can have a suspicion that this is what we are talking about. So when we see that, what's going to happen? What are we going to do? Okay? So the treatment, in principle, is conservative. This is in Spanish, conservador. Apologize, it's conservative. Okay? So what that means, we're not gonna operate on these guys unless we have to. And my opinion and my experience is short and frequent exercise on non-slippery surfaces. Okay? And then over 2 weeks, 3 weeks, some of these animals start to sort of stand up or correct the deformity that they have. Okay? Maybe in my opinion, around 50–60% of dogs may not work this. Okay? Sometimes. And then we have a decision to make. Historically, what I used to do is think of them at some point to do a carpal arthrodesis. And I explain when I would do it. But there was a study done in Turkey. They looked 43 puppies. It was a specific breed, is Anatolian or something like that, shepherd. Some dog very popular there in Turkey. So it's not a lot of variation of breed. And what they did is they put them on a cast. So they put them they forced it with a cast to get the leg in a normal position. And they reported 65.3 improvement in 2 weeks and 100% recovery in 4 weeks. I'm becoming old and cynical. 100% success, to me, is difficult to believe. But there it is. It's published, and we need to give it some thought. So what I will do my standard treatment on short and frequent exercise on non-slippery surfaces. But if I'm not getting anywhere, before jumping to the carpal arthrodesis, I will try the guys from Ankara University approach. I will potentially cast it and see whether that actually may make a difference or not. If it doesn't, then it will need to go for a carpal arthrodesis in the future. That's the paper. Okay. Anybody is interested? What happens in severe cases? In severe cases, you need to do a carpal arthrodesis. The problem is they're very young. And if you do a carpal arthrodesis, you're going to arrest, kaput, the distal radius growth plate. And actually, it contributes significantly to the development of the radius. So at that age, you cannot do that. So then you're going to have to manage this the better way that you can, potentially using external coaptation, these orthotics, or whatever, until the animal is growing. To me, when I would do something, I have one case that sort of kept in my memory. And I did a bilateral carpal arthrodesis for this condition in a Newfoundland, like a big breed, at 8 months of age. And at 8 months of age, I didn't show any obvious deformity or shortening of the limbs, even in a Newfoundland. Okay, so for me, I will do a carpal arthrodesis in pretty much any breed from 8 months and above. And I put that, so why don't you wait till they are fully grown? Because sometimes these people are desperate because they're having soft tissue injury, because of walking wonky and strain. So sometimes there's a huge pressure from the owners to try to give them some answers. So the sooner I will do that is 8 months. This is if you have a challenging hyperextension, the carpal arthrodesis. In theory, if you have a challenging flexural deformity, you could consider carpal arthrodesis, but I will consider potentially before doing some tenotomy of these the flexor tendons, and then it may have a little bit of a strange position of the paw in the floor, but actually can resolve this kind of contraction that we have in these cases. Other things to medically to consider is when you have immune-mediated polyarthritis. That's another condition that it can be done a lot in your practice, okay? Clinical signs, it varies. There is a study from Glasgow in where they found that all the cases, out of 49 cases, all of them have a stiff gait, all of them have pain in a joint, and half of them, more or less, have fever. Other signs like lymphomegaly, half of them, more or less anorexia, lumbar pain in some of them. Lumbar pain makes sense because there is a synovial, there are synovial joints in the articular facets. So it makes sense that it can be painful, okay? But this is more of the old approach or the classical approach, but there's other papers that you say up to 25% of cases of immune-mediated polyarthritis, the only thing that they have is vague signs of illness, like quiet, not moving too much, not eating, so even maybe some unspecific fever. So you don't need to have very specific orthopedic clinical signs to say it's a possibility to have immunomediated polyarthritis, okay? The majority of cases, yes, but not in all of them. And also, historically, joint effusion was considered a necessary sign. The majority of them, yes, you can see joint effusion, but not in all of them, okay? I've been fooled in the past to say it's unlikely. Look, listen, have no real pain, no much effusion, and then when you take a sample of the fluid is abnormal and consistent or compatible with immunomediated polyarthritis. So keep your mind open because there are some cases which doesn't behave in a standard fashion. So you're going to have a suspicion. You're going to do some joint radiographs to see whether you have erosive changes or not, and I will show it to you. And then the whole thing is to get a joint sample. That's the only thing that you're going to have to if you don't do routinely, you need to improve to be able to manage this condition. And it's not difficult. If you found somebody that can show you, it's easy to practice on cadaver. You can put fluid on the joints, even with colorant, like food colorant, to make sure that you grab it. And then you can put it in, put it out, put it in, put it out, and get different people doing it, okay? It's easy to practice. And we're going to be looking at many things. When you get joint fluid, first thing you're going to see is the volume. The volume is increased in immunomediated polyarthritis, the same as the volume is increased in septic arthritis. Your main issue is going to be here to differentiate between immunomediated and infected. That's the key point that you're going to have. So volume is augmented, color is altered, the normal fluid is transparent. When you have immunomediated or septic can change from more yellow to brown, to different colors. The other thing you're going to have to do is we are using gloves to do this aseptically. And when you get a drop or when you get fluid from a joint, the first thing you're going to do is to put a drop in between your fingers, and you're going to open the finger. Normal fluid is not going to break. It's like they have mucin, and it's going to be like, it's going to not break. You're going to be keeping joint in your fingers. This, when you have immunomediated or septic, is very watery. So when you open the finger, it breaks. So it looks this kind of like, this consistency, sticky consistency that you have in normal fluid. The next thing you're going to do is to do cytology of this fluid. And you're going to ask for two things. You're going to ask for how many cells are in this slide using the standard units to get you an idea. And you're going to ask for percentage of neutrophils. That's what you need to know. So if you have nucleated cells for 10 elevated to this kind of 9, the power of 9 per liter. Normal and arthritic joints have very little. Immunomediated and septic, a lot. Rare that you have only 4. We're talking about at least 20, 30, okay? At least like this. So we're talking about seeing in one slide maybe 2, 3 cells to see 20, 40, 60. So a lot of cells. You know, without counting, I can look at a slide and say, too many neutrophils here, something is going on, okay? And then percentage. So you're going to have in septic arthritis, normally more than 90% are neutrophil, and immunomediated can go from 40-50% neutrophils to 100% neutrophils. So there is a lot of overlap between a cytology for septic and immunomediated, okay? The difference is that normally septic is one joint and immunomediated has several joints. So if you have these changes in several joints, likely is that it's going to be immunomediated. But occasionally you can have a septic polyarthritis, so you need to be very careful because a confusion could mean the death of the animal. Because you immunosuppress a septic animal, game over. You're going to treat these animals as they were a cancer patient because cancer can cause this, okay? So you can see whether you have a primary case, idiopathic, or you have a reactive or secondary. And secondary could be secondary to tumors, secondary to inflammation or infection, secondary to medication, okay? So we're going to do chest x-rays, we're going to do abdominal ultrasound, we're going to do hematology, we're going to do biochemistry, we're going to be doing specific infectious diseases that you have in your area. We're going to do x-rays of the joints to see whether we have erosive changes or not. And depending on this, it's not going to change how we treat it in principle, whether it's erosive or not, but the prognosis is going to change. Because you have an erosive polyarthritis is much more aggressive, and the prognosis is worse. Okay, we're going to be doing this. Particular questions. Rheumatoid factor doesn't useless. It's not specific. Don't waste time or money doing that. Antinuclear antibodies, okay, because this could be part of a lupus. This is the immunomediated polyarthritis is the most common sign as part of the lupus, and sometimes lupus have positive antinuclear antibodies, so it's a good thing to do it. C-reactive protein can help you monitor, so it's good to have a baseline and then do sequence at some point, repeat C-reactive protein as a way of controlling the disease. But just think as a cancer case. This is taken from Ettinger, the medicine book. Different classification, but looking for infectious, secondary to distant stimulus, reactive, drugs, neoplasia, primary erosive, non-erosive, and things like that. We discussed that already. Lupus is a multi-immune system condition. Normally, they have positive to ANAs. Polysystemic, polyarthritis is the most common. But you have proteinuria, immunomediated hemolytic anemia, thrombocytopenia, autoimmune skin disease, and this mucocutaneous ulcer. And you need to have some of them to call this lupus. The treatment is the same, immunosuppression, but attention to the other things. And see how the other conditions are doing and whatever you treat. And I don't know how to treat them. I don't know how to treat joints, and that's it. Important, medications. It can cause an immunomediated polyarthritis. Typical one is sulfonamides and Doberman. Like, I mean, a huge percentage, 80%, 90% of Doberman. If you give sulfonamide to a Doberman, it's going to do an immunomediated polyarthritis, very likely. The good thing is that it will stop when you stop the medication. Good news. But all this drug has been reported to be related with that. Okay? And vaccines is a good thing to us. Vaccine up to 30 days later could trigger an immunomediated polyarthritis. And human albumin, in those cases that you need to treat in ICU, reported between 5 to 13 days. That's good, because when you stop this, you'll treat it once and then never relapse. There are specific conditions, like this Sharpei thing, used to call Sharpei fever. Now they're realizing that it is something weird, and they're calling it Sharpei autoinflammatory disease. So occasionally have the tarsal swells. Sometimes you can have immunomediated changes, but it tends to be quite self-limiting. So more often than not, you resolve it with short courses of non-steroidals. But sometimes you may need to do some steroid, but this is part or something bigger. They can have some amyloidosis in the kidney, in the liver. This is a medical condition. So you get the Sharpei with that to the medics. erosive polyarthritis, okay? Luckily enough, not very common. Depending on the paper, 1.9 to 16% of immune-mediated polyarthritis. Affect the carpus, and they got severe damages on the bone and in the ligaments in the joints. And they can end up animal being plantigrade or palmigrade. And it may require medical treatment, and it may require surgical treatment as well, like carpal arthrodesis or tarsal arthrodesis, or sometimes I have cases that I have to do bilateral pancarpal arthrodesis and bilateral tarsal arthrodesis, not at the same time, but progressively as the joints were failing, on top of having to medicate these animals. This is an erosive polyarthritis X-ray. Okay, I draw your attention to this. Okay, this black stuff in between the joint is not air, it's cartilage. Okay, that's telling me that between this bone and this bone there is cartilage and it's contacting. When you have erosive changes like here, there is no black, it's bone on bone. That means the cartilage is gone, bye-bye. This is very, very, very severe. So you are not gonna, it's very hard to control. And on top of that, the massive swelling. And this animal is plantigrade. They have no palmar support. So it means a severe form or an immune-mediated component or condition. Okay? These are you're gonna have to try to, it's very unlikely you're gonna be able to control, to give a treatment and resolve the problem when they're erosive. You are gonna have to maintain this smallest amount of medication that you can give to this animal to more or less control the clinical signs. But it's very likely this dog is going to require some kind of steroid treatment for life, and it's very likely it's going to have to get a pancarpal arthrodesis to have some function. Okay? Now, be careful when you look at this, when you do a carpal arthrodesis, because I've seen cases like this that you have erosive changes in these joints. So if you fuse the carpus, then you're going to be putting more pressure on this, and potentially it's going to start dislodging or affecting that joint. So be careful, because if this is affected, maybe carpal arthrodesis is not the solution, and this animal have a poor prognosis. I've seen my supervisor, Mike, do a pancarpal arthrodesis and then fuse, also do metacarpophalangeal arthrodesis. That's heavy metal, you know, but be careful with that. When it comes to treatment and prognosis, okay, looking at the normal immune-mediated polyarthritis, not the erosive, the normal one, normally you will do a course of immunosuppression and you will have pretty much 50% success. And what I will do 1 milligram per kilogram of prednisolone twice a day for 2 weeks. Then the animal clinically should be fine, but it will have side effects of the steroids, drinking more, urinating more, very hungry. And then what I will do is in 2 weeks, I will take fluid from the joint and see whether that medication is controlling, so we have normal neutrophil numbers, normal cell numbers. If that's the case, my medication is working, and I will start bringing it back. I will halve the dose. I will give in 0.5 milligram per kilogram twice a day for 2 weeks. I will see how the animal is doing clinically. If the animal is doing well clinically, I will have that dose again for 2 weeks. I will do 0.25 twice a day. And at the end of that 2 weeks period, I will take fluid again to make sure with that at such dose, low dose, I still have no neutrophils and normal cells. If at that moment the cells are up, I will need to go back again with the steroid and potentially put a second drug. And at that moment, I will probably say, good moment to send the case to the medic. Okay? And then when it's 0.25 twice a day, the cytology is good, I will keep tapering down the medication until we have no medication, and hopefully we are in the 50% that are cured. 80% will need potentially some kind of small amount of drugs to control the clinical signs. 13% we have relapses, and you do another course later in his life and resolves. And 50% reported like died or is put to sleep because you cannot control the condition. Careful with the septic arthritis. Septic arthritis is a monoarthropathy, normally associated with previous surgery, pre-existing osteoarthritis, penetrating injury, immunosuppression, or a disease causing huge bacterial translocation like a shunt or something like that. Elbow is the #1 joint to have a septic arthritis. Very careful with older dog with a lot of arthritis in the elbow, suddenly super lame, he has potentially septic arthritis. Get a sample, send it for cytology, send him for culture. But only 50% of the joint fluids that you send for culture grows some bacteria. And it doesn't mean that it's not infected, okay? If in doubt, at any point, you don't know whether it is septic or immunomediated, we have an answer, and it's lactate. You use a portable lactate meter. When you take that fluid and you put the drop there, even it's less than 3 millimoles per liter or 4 millimoles per liter, it's 100% reliable, it's immunomediated. If you have 8 or more, it's very suggestive that it's septic, assuming that you have a cytology with a lot of neutrophils and a lot of cells, okay? But this is your best guess for deciding one of another, okay? I think I have 3 minutes. I'm gonna finish with some X-rays that I've been sort of recopilating in my life, which are a bit curious. So we finish on a high, on something weird. This is not that weird, but this is, you know now this, panosteitis. You see this? German, you tell me, you looking at it had to tell me the breed. It's a German Shepherd. It has panosteitis and an anginated anconeal process. It's like the DNA of these people, like everything. Okay. This used to be called anginated medial epicondyle. Now it's like some kind of flexor and physiopathy. And actually looking at it, has subtrochlear sclerosis and potentially has a medial coronoid disease. You now know what is this? It's a flexural carpal deformity in 2 dogs. This is a Springer Spaniel with an angular lid deformity and a line in between the condyle that you can see in the middle of the ulna, which is what is called complete ossification of the humeral condyle. This, nothing major, is called head dysplasia and congenital pubic hypoplasia. The hypoplasia is just an incidental finding, has no clinical signs. This is called a transitional vertebra or asymmetric pelvic attachment. Weird. These, some pathological fractures in different places. This dog, we did all the tests. We did look for the calcium, for a nutritional secondary hyperparathyroidism, nothing. And then we do the culture of fibroblasts. And this is the only dog in my life that I've seen with osteogenesis imperfecta. This bone cyst. Now you're getting weird. Congenital hypothyroidism. This is like a flame. They call it like retained cartilage core. It's like a mild form of metaphyseal osteopathy. I will define it. It'll be like a epiphyseal dysplasia, but actually in this case was the only case I've seen in my life of rickets, hypovitaminosis D. Another bone cyst. And this, you see a little reaction here. This is a septic fasciitis, an infection of the growth plate. Really painful, and then there was like a purulent accumulation underneath the periosteum. This has nothing to worry about. Is a nutrient foramen fibrous dysplasia. nothing to worry about. And I finish here. I just say thank the organization for inviting me again, and for my friends from Phoenix, Vet, to bring me again, and everybody.
Tak, mamy jeszcze jedno pytanie na koniec. Pytanie dotyczy choroby panosteitis. Czy jest możliwe stosowanie sterydów? Czy ma pan doktor jakieś doświadczenie?
No experience and no need. I think it responds very well to non-steroidals. It's basically an analgesic treatment, and steroids don't provide analgesic. So no need and no experience.
Na tym zakończyliśmy. Dziękuję państwu bardzo. Nacho, gracias.
operator.
Hi,
Lydia.
Miss
Hi.
Lydia?
Yes.
Excellent.
And I see we have a small problem
Yes.
with color. Probably is related with the cable.
Right,
Maybe
but
when
our-
we can switch.
It's no cable problem. I think it's this one.
Ah, okay.
Oh,
Now it's okay.
Now it's okay.
Okay,
But
good.
we don't have.
The source on the screen, yeah.
Well, I've
Ja powinienem to normalnie to wypluwam. Zaraz zobaczymy jeszcze.
How are you?
I'm
Stressed?
doing well, thank
Yeah?
you.
Yeah? It's a long line, your lecture.
Oh yeah, there was a long
Very
line to
long,
go
yeah.
out too.
No.
Yeah, a long line of people who like surgery and a long line
Yeah.
of people who like medicine.
Yeah, internal medicine, yeah. So surgeon goes out.
Is that
You need something?
just some water?
Okay.
That's it.
Sygnał wchodzi.
Dzień dobry, to znowu ja. Pytanie mam, czy wszystko nam działa.
Not really. We have a problem.
Nie działa. Nie podaje sygnału na... Znaczy tak, to podaje sygnał, bo niczego nie zmienialiśmy. Natomiast jest przelotka. Tak. Co jest za przelotka? To jest na Maca przelotka. To jest pana agenta.
I nie działa?
Znaczy działa, bo ja mam tu sygnał, ale nie mam tam.
Exactly.
Działa
yeah.
dalej, tylko kabel. A ten kabel co dokąd idzie?
I think
Do projektora.
if it goes there, the phone is with them. Not with
Gdzie on wchodzi? Pokażesz mi? A ja nie mam pojęcia. On idzie do projektora, tam, pod ścianę.
I will have, but I didn't use my interactive because I didn't know if it would work. I didn't use the interactive software.
Ja zmienię kabel, wiesz, między Ninją a laptopem.
Because I've been see that doesn't work. So I've learned to be very simple with technology.
Just question to
Yes.
the audience.
Yeah.
Yeah, okay. So during the introduction, I give some sentences to cooperate with you during the lecture.
Okay. Very good.
To be more active.
Co ja myślę, że to jest za słaby sygnał HDMI może być. Jeżeli to jest w ogóle możliwe, bo tak, ja mam, ale nie mam... And you used this connection, yeah? Okay, this device. Yeah. Maybe. Yes, please.
Yeah, I have. Yeah, of course.
Because I'm sure the trouble with colors is caused by your device. I think it's cable connection. The one cable is not connecting well and not transferring, you know, not...
Well, let's try with that.
Let's try with that, yeah.
Try with this one. Is the C? Yeah. Okay, here is HDMI.
Nie. HDMI, nie, HDMI. O, jest.
Okay.
Ale jest. To najważniejsze.
You have a charger?
Ja mam sygnał.
Jakbyś miał jakiegoś drugiego akademika, to byłoby super.
Jeszcze jedną rzecz sprawdzimy.
Dobra, idą panowie z kolegami. Moje kolegi czasem też zabrał.
Który?
No, moja akademika jest działania wczesne. No nie wiem, kto zabrał. Trzymam mi chyba idą już z zapasem. Czyli z tych nas...
To jest wejście.
It's always the same story.
To nie przerywa Ninja,
Something
przerywa
wrong.
źródło.
Czyli tam ta
Nie,
przelotka?
to już jest pani przelotka. Jest.
Jeszcze jedna. Aha.
Czy ona potrzebuje zasilania dodatkowego? Miała pani jakieś problemy z nią? Nie.
Nie potrzebuję takiego coś.
And also put here your charger during the lecture. charger.
Oh
for your
yeah, and my
laptop.
charger is here. I
Yeah.
can do it independently.
Yeah, and we can put the charger
Otherwise
here or
Yeah,
the
directly
extra.
on the computer, yeah.
Yeah, because sometimes, you know, level of battery
Będziemy walczyć, tak.
decrease. Co może powiem, że potrzebujemy jeszcze 5 minutek, co?
Tak. Przez rejestrator przychodzi sygnał na rzutnik.
My jeszcze będziemy potrzebować jakichś 5 minutek, żeby się tutaj podłączyć, także spokojnie jakieś 5 minutek jeszcze. Przepraszamy za małe opóźnienie.
Zrobimy tak, żeby puścić. This is brand new Mac? Or
Yes, brand new. It says Ninja TV, Ninja V.
It's caused some issues, the newest ones, and try directly on the screen.
Without this equipment.
FX Deck Standard.
To jest problem, bo może być problem dlatego, że to jest nowy Mac. Teraz tak, ja przepiąłem bezpośrednio na rzutnik.
Ale jak masz sygnał, no to raczej tak sobie
Ale, no więc powinien iść, nie?
No o to mi chodzi. Tam wszystko jest jak było, nic tam nie opina, bo nie ma żadnych.
Ale zobacz, ja teraz przepiąłem i nie wchodzi na... A może sobie wyłączyć?
Connected to
Przepraszam, z powodu ograniczenia ilości miejsc na sali prosiłabym, żeby się ścisnąć maksymalnie, żeby też było łatwiej wchodzić nowym uczestnikom. I prosiłabym też nie o kładzenie swoich rzeczy na krzesło obok. Dziękuję.
I na przykład też nie działa?
Ten też nie działa. W sensie...
Znaczy bezpośrednio wypuszczony z laptopa, nie hula, ale jak wepnę, zobacz.
Ale czekaj, ale wykrywa ekran, czy nie?
Co? Jak Ninja wpinam, Ninja mi pokazuje, ale nie wysyła dalej. A teraz mam tak.
A bezpośrednio idzie?
Bezpośrednio nie poszło. Dobra, panowie, zajmijcie się. Zobacz.
Jest na Ninja, tak?
Jest na Ninja, ale Ninja może przesłać na...
A projektor jest włączony?
Okay, I can borrow mine.
Panowie? Ale nie wyświetla, że brak sygnału. Musi być na czarno. Nie przełączy...
Ale ja mam sygnał.
Ale tu jest sygnał i to już nie idzie przez ten, tylko przez...
Wchodzi do rejestratora i wykrywa to samo.
Tak.
Bezpośrednio 1 do 1. Nie ma na...
Coś mi zabrał moje kabelki, wiesz co, zmiany na zapas.
Które kabelki?
Yeah.
Nie znam się na spróbujmy, może...
Tylko, że nie mamy prezentacji, żeby ją zgrać.
A technik hotelowy gdzie jest?
Był, idzie na górę właśnie dopytać o...
W komputerze jest realizator, jest komputer realizacyjny, który zarządza rzutnikiem, bo to jest projektor kinowy, nie?
A nie mamy jak rzucić prezentacji. Wiecie, w jakim ona jest zapisie? To jest PowerPoint, czy to jest...
To jest chyba ten
Kinowa.
makowy.
Ale gdybyśmy go rzucili na jakiegoś pendrive'a...
Ja mam pendrive w sobie.
A mamy innego laptopa?
Tak, ja mam swojego.
A możemy spróbować tego drugiego laptopa, zobaczyć czy puści?
Pochwalmy go tylko, zobaczmy czy ten przez przelotkę wygluje.
No tą wodę to ja muszę zabrać.
Albo tu podstawić. Ale to jakieś zwierzaki na polski już.
No dobra. Pendrive. Tu jest.
O nie, jest, żyje.
Jest zielony ekran, ale nie ma nic.
Nie, to nie jest Mac, a tam na górze jest problem. No. Trzeba dzwonić do hotelu.
See, it's not my computer, it's...
My
Oh, now it's
phone?
happening. Okay.
So maybe we can transfer your presentation into my computer?
Może coś zaczytał, bo wolno ładuje, nie?
Whatever
Nie,
needs
no to
to
sama
happen.
specyfika.
działa, tylko jak nie działa. Musimy przestać, bo to jest... Przeszliśmy tam, zgrajmy tam. Tak, słucham.
Can you... Yeah. So you can use my computer?
Yeah, that's okay.
Yeah.
Anything
Yeah.
that makes it work, right?
Yeah, yeah.
Walczymy.
Resolve this problem this way.
Okay. So we are looking at case discussion.
Wykorzystamy pani komputer.
I think that should work. It's called case discussion Poland or something. Yeah.
So the presentation is on this?
Yeah.
Okay.
I can take my computer off here, so you can put yours. If you give me the electricity, do you want to give me the outlet?
Rozumiem, że na razie pani nie udostępnia ekranu.
Nie, szukam tego pendrive'a.
Prześrubkę też nie mieliście, tak? To jest pan. A pan też nie działa. Teraz powinien... Jest.
Case discussion?
Teraz jest pani dyskretna już.
Na połowę to już. A, okej.
1 second.
Może nowy Mac, nie? To nie jest chyba ten najnowszy, nie? Nie wydaje mi się. Ten taki zaokrąglony.
Perfect.
Wiesz co?
Okay.
Czas trzeba poszukać, bo może headset tam ustawić, nie? A dobra, jest tutaj.
We
Teraz
have
włączyć.
all these things.
But it's not on the screen, okay?
Charger.
Śmiga. Bardzo.
Okay.
Dobra, to my uciekamy. Dobra, ja włączę. Dzięki.
You want to speak first? Thank you. Save the day.
Dzień dobry, witam Państwa serdecznie. Przepraszamy za małe opóźnienie, ale udało się opanować sytuację. Dlatego nie chciałabym tutaj przedłużać wstępu. Chciałam gorąco powitać naszego wprowadzącego, który zabierze Państwa w podróż analizy przypadków klinicznych. Chciałam tylko dodać, że pytania zadajemy za pomocą aplikacji i oddaję głos naszemu prowadzącemu. Okay, so the speak is yours.
Thank you, Lydia. Thank you very much for being here, for being patient. Not everyone is patient. I'm patient. My wife is not patient. But that's okay. I still love her, right? And so thank you for being patient, and thank you very much to the Polish Small Animal Veterinary Association for inviting me for a few lectures this weekend. It looks like a very busy, fantastic congress, and I'm very humbled to be part of it. And so we're starting slowly, okay? Because it's always fun to start gently, and we'll go first to talk about some cases, right? And so that's the plan for the next 45 minutes. And I wanted to say that I am, you didn't know that, but I'm telling you today, I'm one of your representatives. If you're a member of the Polish Small Animal Veterinary Association, you're a member of ECAVA, you're a member of the World Small Animal Veterinary Association, and our vice president, our president-elect is Dr. Jerzy Gawor, and so you probably know him, right? And then we have two representatives for the region that includes Europe, North America, Australia, and New Zealand. and I'm the one who doesn't have an American accent. Yes, because I mean, if you don't speak English a lot, I speak English with a strong French/German accent because I come from Switzerland. So is the speed okay up there? It's okay, very good. So we'll talk today about Olivia and Skylar. I picked them because I thought there was something interesting to say about both cases. So I am sure you've seen cases like Olivia. She is a 13-year-old female spayed domestic short-hair cat that is presenting for complaints of hyporexia, lethargy, periuria. So I don't know if you use that word in Polish, but that's basically urinating outside the litter box, tenesmus, and hiding for 2 days. I guess a lot of cats could fit at least partially this type of complaint. So her history is that she's a cat that's dealt with complication for the last 4 months, and she's been managed with enema and Miralax. So Miralax is a powder that is sold in many places. I don't know if it's sold under that name here, consisting of polyethylene glycol 3350, which is a big molecule that is not absorbed in the GI tract, right? And so therefore, Miralax is an osmotic laxative, okay? And I'm sure it exists in Poland. I just don't know the name, the brand name in Poland. Because there are constipated people in Poland as much as, maybe not quite as many, but as almost as many as in the United States. She was diagnosed with chronic kidney disease, CKD, Irish stage 3. You're familiar with the International Renal Interest Society and the staging of chronic kidney disease. That was 4 months ago. And she currently receives subcutaneous fluids, famotidine, and maropitant as necessary. Right. So that's some screenshots from the Iris website that you can find up there. I am an internist, and I can definitely deal with kidney disease, but it's not what I prefer to lecture on. But I thought, because we talk about Olivia, we just need to remind ourselves of the stage 3, which is here. We measure urine in milligram per deciliter in the United States. Perhaps here you measure it in millimole per liter, but she's just in that category, right? And so then we also would like to substage her. That hasn't been done, but it has an implication on the recommendations from the experts as to how to best treat her, right? And to try and slow down the progression of her kidney disease and manage, you know, her azotemia. So we follow this system because there's no better system that I'm aware of. On physical exam, she has a body condition score of 4 out of 9. 5 would be normal. She's lost some muscle on the epaxial area, so around the spinal cord. Temperature, pulse, respiration are okay. She looks scruffy. She doesn't look like she's taking care of herself. Her oral membranes are pale, and she has a gallop rhythm, 3 out of 6 systolic, with PMI, maximum intensity on the left apex. She doesn't like when we palpate her abdomen, and there is a large amount of hard feces that are palpable in the colon. So she also has some feces around her perineal area. I'm going the wrong way here. So this is our problem list. While there's clearly 2 issues, the one is the kidney disease, chronic kidney disease, and the other one is the constipation, and then potentially an issue associated with the heart because of the gallop rhythm and the systolic heart murmur that we could identify. So we would all agree she has some degree of chronic kidney disease, right? So that's more than a differential, it's a diagnosis. We probably will never know exactly why. We don't know exactly what's happening here, Okay, is it, does she have some type of cardiomyopathy we need to be aware of? Or maybe because she's an older cat, maybe there is an issue with the thyroid, right, that we need to take into consideration. And the other option, the other problem would be the constipation, and see if we can help her in that respect. So if Olivia was with you, what exams would you like to do at this time? You can, I mean, I have the translation from Polish here, and I'll listen to it with, I'm not listening to my microphone. No, I mean, that goes this way. Ultrasound. Okay, you would like to do an ultrasound. Brilliant idea, because you would like to see the kidneys. You would like potentially to see also the colon. I would argue that if you do abdominal imaging, you could also do a set of radiographs to evaluate the size of the colon. That'd be a good idea. I'm sure you're not saying it, but because it's pretty obvious, you would also like maybe to do some blood work, because we have the referral blood work, but we don't have anything recent, and maybe a urinalysis, just to see where we're at with the CKD. And as far as the cardiac issue is concerned, maybe a set of chest radiographs, okay? That would be good as well. So that's what we ended up doing. I'm fortunate because I'm not very keen on cardiology. I prefer GI, but I have people around me who love cardiology, so I ended up consulting with them, and they didn't feel like there was anything to be worried about. We did a blood pressure measurement because it's part of the staging of CKD. So we wanted to see if she was hypertensive or not, and she was not. So that's good, that's a plus. I prefer non-hypertensive. Her blood pressure was 140. You remember that anything above 160 is considered hypertensive, systolic, right? And we did a urinalysis. So, these are some views, excuse me, of her abdomen. Okay, so there was clearly some material in a descending colon that was of increased radio opacity, okay? There was also some in the ascending colon, so it was segmental. You know, kind of heterogeneous type of appearance, and certainly very hard on the palpation, and that would fit with some very hard stuff. We would also, I'm struggling a little bit here. I apologize. We would also evaluate the pelvis. Why? Because we want to make sure that the constipation is not associated with some type of obstruction, right? And so obstruction associated maybe with a pelvic fracture. So that was not the case in that instance. Okay, some people, this is now another radiograph, compare the length of the fifth lumbar vertebra and the maximum colonic diameter, okay? And they do a ratio between the two, and if it's, I think the number is 1.8, but definitely 2, radiologists tend to call things then, well, that's a megacolon. Does it really matter greatly? Probably not, because as internists, we will still go through the same process when we approach those. Okay? So, I think I'm pressing on the wrong arrows, but that's okay. If we summarize the radiographs, generalized large amount of feces, increased opacity, unremarkable pelvis. Oh, I forgot to look at the right kidney, but it was a bit irregular in shape, and you can see it somewhere with, that's mostly feces. You know, I have a wife who does radiology, so I guess from that close, it's probably around here somewhere. And, but anyway, that was her comment. And then the ultrasound, showed some kidneys that were compatible, like they were abnormal looking, right? They were a bit small. The corticomedullary junction was not always maintained. There was some pylectasia with dilation of the kidney pelvis. Okay. And then the colon was distended with feces, and there was a little bit of a thickened colonic wall to be seen. Blood work revealed mostly anemia, right? With all three parameters being decreased. We look at the hematocrit. It was low, and do we expect that? Potentially in a cat with chronic kidney disease. Otherwise, it was normocytic, normochromic, and I don't have the reticulocytes here, but they were below 10,000, so it was non-regenerative. Non-regenerative normochromic, normocytic anemia, which we would see with issues like chronic kidney disease. And here, if we look at the panel, I highlighted in orange the abnormal parameters. The globulins were a little high, BUN, creatinine were not very different than they had been. Phosphorus was pretty high. Sodium was a little high because she was probably a bit dehydrated, and potassium was a little low because she has kidney disease and probably needed some form of supplementation. Right? And the urinalysis did not really document in the protein to creatinine ratio any significant proteinuria, which is good. It's another of the parameters used besides blood pressure to substage CKD. Otherwise, fairly normal. We would expect that specific gravity to be low. And the urine culture was submitted just to be sure, because pylectasia, we're thinking maybe she could have some pyelonephritis going on. We just wanted to make sure, and that was not the case, okay? So as far as constipation, we didn't really see a cause for it, right? And so we decided, well, that's idiopathic constipation. The cardiologist said there was mild hypertrophic cardiomyopathy, but nothing very concerning at this time, didn't require medication. And then we had IRIS stage 3 CKD, not hypertensive, not proteinuric, and moderate to severe non-regenerative normochromic normocytic anemia that was non-regenerative. So that's all her problems at this time. It's not uncommon. I mean, based on one population study that was done in a large hospital in New York City, I believe, they compared constipated cats with other cats of the same age that were not constipated, and those were 3.8-fold more likely to have chronic kidney disease than the ones that were not constipated. So the two go together. I don't exactly know how to explain it. Maybe because animals like cats with PUPD, with a CKD have polyuria polydipsia, and they're more commonly a bit dehydrated and get more water from their feces, potentially leading to drier feces in the colon. It's possible, but that's just a vague explanation that has not been proven. So how do we go about improving the treatment plan here? I guess, you know, there are feces in the colon. They need to be evacuated. There's no question. Miralax is actually a good, or PEG 3350 is a good laxative to give to these cats. I don't think that you have cisapride available in Poland. Is that a drug that you have available from a compounding pharmacy? Oh, fantastic. Because it makes a world of a difference, right? And so cisapride would be the thing. I do not, when I see a cat with constipation, I would, of course, evacuate with enemas, whatever is in the colon when they come and present the cat. But then, if it's the first occurrence, I would probably go and put the cat on a high-fiber diet. One of them is the first one on the market was from Royal Canin, GI fiber response or something. I don't get any money from Royal Canin. I'm just saying this is a good product. Maybe GI Biome from Hills would do the same, or another diet that is available in Poland, and I don't know. But these diets all have increased fibers. So for fiber response is psyllium, okay? And psyllium is the first way to go, right? That's what I would do, just a diet. Then if that doesn't work, I would add the Miralax, the PEG 3350. And then if that doesn't work anymore, we do add a prokinetic such as cisapride. Cisapride is fantastic for that indication. You can give more than that, but we start usually at a low dose. We may go up to all the way up to 5 milligram per cat. And so I had already a plan B, but I've never used prucalopride, which is available in the pharmacy in the human market, but I'm being told that it works well as well. In her case, we needed to figure out a way to put her on a better diet for her kidneys, so we did that. And you're probably familiar with mirtazapine. The question is, in the United States, there's a cream we can put in the ear. You have it here as well? Mirataz. So I find that, again, I get no money from whoever makes Mirataz, but I find that it helps me greatly with many cats that don't want to eat, okay? So this is what we implemented for this cat. So that would be the sequence of things from the most benign to the most advanced, and eventually, when nothing works anymore, it's time to speak to the surgeon and consider colectomy. I will be honest with you, I haven't requested colectomy from a surgeon in a while. I think cisapride works really well with these cats, and this cat, my guess, I don't want to be pessimistic, but there's a chance she may actually die from chronic kidney disease before she dies from constipation. All right, so you know how to do enemas, but what I wanted to share with you is there is a method where you can, it's not really very openly published. It's an abstract from like a long time ago at the American College of Veterinary Internal Medicine Forum, where you give PEG 3350, like go lightly or like to prepare for endoscopy, for colonoscopy, and you give it via a nasogastric tube, so the cat needs to be in the hospital, over this dosage over like 12 hours usually, okay? And on average, these cats defecate 8 hours after treatment, no matter how bad their constipation is. It hasn't always worked that way for me. But then, that's not Olivia, right? But then at least it helps me massaging the feces out rather than having to go with instruments in that animal's colon to extract feces. I hate that. I don't like surgical instruments. I do medicine, forgive me. And also, I don't like surgical instruments where I can't see the end of them, right? And so, versus here, this was another cat we had, and we were able to offer, it was, you know, under heavy sedation. We would massage everything from his colon. But as far as Olivia is concerned, that's what we did. That's the other cats, that's not Olivia, sorry. We sedated, placed a nasoesophageal or nasogastric tube, same thing, administered the PEG 3350, and Olivia passed a large amount of feces in the morning. She had not responded to enemas. And also she was aggravated by enemas. In English, we say there is a certain number of kitty minutes. A cat comes with a clock. The veterinarians come in the room, the clock starts ticking, tick, 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 tick. And some cats, you have 30 seconds. Some cats, you have 3 minutes. And so that didn't work for the enemas very well. Okay, so that's that. And she was better. Now, she still had chronic kidney disease after a week. Colon was empty. She was more active. She could defecate normally because she received that Miralax or PEG 3350 powder. Her appetite was better. And so we were able to help her as much as we could for that problem. Okay, so stepwise approach to the management of constipation. The value of PEG 3350 via NE or NG tube is important, in my opinion, has really changed the way we approach those cats. And of course, many cats come with comorbidities that need to be addressed as well. Any questions on Olivia before we move on to Skylar? How are we doing, Dr. Lydia? Is she here? There she is. And minute-wise, can you tell me how many minutes I have left? I have 5 minutes left. Okay, good. So please bear with me. I'm going to speak a little faster. No, I'm just kidding. I can't speak faster. It was just a joke. No problem. You don't. If you need to have friends with your translators. Right, so let me talk to you in 5 minutes about Skylar. Another case you've probably seen. She's a 13-year-old Maltese presenting for vomiting, large bowel diarrhea, anorexia, lethargy. She was fed pulled pork. So pulled pork is when you cook a pork roast and then you tear pieces like that. In America, especially in the South, people love it. They mix it with barbecue sauce. And somehow she got some of it at a party, I think. And she began vomiting shortly after that. And she showed no improvement in spite of a symptomatic treatment done at a local veterinarian, consisting of fluids and maropitant. Okay, physical exam, she's a little overweight. She is tachycardic. I suspect that part of it is maybe she's dehydrated. Part of it is she's painful. Because her abdomen was tense and painful, and she had a bit of a systolic heart murmur and soft feces in the rectum. Okay, so really here we have this problem list consisting of acute vomiting, large bowel diarrhea, anorexia, lethargy, dehydration, tense and painful abdomen, and grade 2 systolic heart murmur that did not respond to simple treatment. Okay, so I'm going to simplify that. There are when I speak to my students, I like to speak of the trifurcation of vomiting, depending on where the vomiting originates from, the GI tract, the liver, or the pancreas, or outside of these organs, which I call, quote unquote, metabolic, okay? But here is a dog that had access to food that was unusual a couple of days before presentation. So the top 3 differentials were clearly dietary indiscretion, acute gastroenteritis of dietary origin, acute pancreatitis, or gastrointestinal foreign body. So what do we do now for this dog? There's one exam that is going to decide if you act like a surgeon or if you act like an internist. Ultrasound is good, and I would say you could actually do some radiographs, right? So abdominal imaging and ultrasound, you seem to love ultrasound. I love ultrasound too, if somebody is with me that can do it. Because again, I said I'm married to a radiologist, so I don't do her stuff. But yes, absolutely. So we want to rule out obstruction, and I want to argue I'm more familiar with ruling out obstruction using radiographs. But ultrasound can be helpful as well if you know what you're doing, and I'm sure you do. Blood work could be useful, but the one test that I want to do first is this, because either it's a foreign body, then we need to rehydrate the dog and go to anesthesia and remove the foreign body, right? Or it's not, and then it's gastroenteritis or pancreatitis. And so I think there is value in doing blood work to evaluate for inflammation, evaluate the systemic effects of the disease. Is the dog so dehydrated that there is some prerenal azotemia that we need to be worried about? And if we're worried about pancreatitis, we could do a pancreatic lipase immunoreactivity. That's an IDEX test. You know that, right? And I've seen it advertised, either the SNAP or the SPEC or another version of it, right? So here we have the radiographs for Schuyler. We do not see two populations of small intestines. They all look kind of the same, right? There would be, and so one population, it's a little fuzzy up here in the cranial dorsal abdomen. And if I look at the VD, it's not too bad, I guess, but you could say there is a little bit of increased radio opacity or decreased contrast in the right cranial quadrant. And the ultrasound, like this is the Polish preferred method, right, shows here that there is an organ near the duodenum that is very abnormal in its echogenicity and its appearance, and that's the pancreas, where you see heterogeneous echogenicity and you see peripancreatic hyperechogenicity suggestive of saponification of fat. So you're going to tell me, gosh, and I knew from the beginning that this dog has pancreatitis. Tell us something we don't know. I will. Maybe you know it, but I will tell you something that's pretty new for me. That's just the scale that radiologists use when assessing the pancreas. Moving on, this is the blood work. So it's not uncommon to see increased liver enzymes in dogs with pancreatitis, as I'm sure you're familiar with, because the pancreas is the liver's neighbor, right? And the bile duct and the pancreatic duct are very near to each other. And so in the end, there are even situations where we see dogs with jaundice, icterus, that because of pancreatitis, we call that pancreatic associated bile duct obstruction, or PABDO. This was, I wouldn't call it like that here, unless it would get, the bili would get higher. See, that's our reference range, so it was just above the reference range. When they have PABDO, we see values between, I don't know, 4 and 15 or something like that. So 10 to 30 times that. The liver enzymes are a little increased, especially the alkaline phosphatase. That's still, fairly usual. This is the triad for the diagnosis of pancreatitis, the proper clinical signs, the abdominal ultrasound finding, and the increase in the lipase immunoreactivity. The treatment, pretty classic, right? Antiemetics, fluids. We are a little cautious with metoclopramide because metoclopramide could potentially compromise via its dopamine inhibiting effect the microcirculation to the pancreas. One thing we do more so now than we have in the past is consider giving these dogs steroids. Okay, there were a couple of studies from Japan showing that administering prednisolone at an anti-inflammatory dose had a beneficial effect in these dogs. So we can see two graphs here. We have here two groups of patients, those receiving prednisolone, PDL, those that do not, NPDL. This is the duration of hospitalization for those dogs. And so you can see that there was a difference, statistical difference. So I can't remember, that might have been 7 or 8 days, and this is 5 days. If we look at the survival rate, the dogs receiving prednisolone, here you see they stayed alive. That's the percentage of dogs that are still alive over time, and they stayed alive better than those that did not receive prednisolone. Now, this was not a perfect study. There needs to be a better study done, double-blind, study where this is done prospectively. This was retrospective. Nevertheless, I think this was an interesting study, and it has led to many of us considering mild dose, not for long term, of dexamethasone or prednisolone in our patients with pancreatitis that have to be hospitalized. Are you familiar with this drug? You might be, soon you might become, right? This is a new drug that has come to the market in the States. It's been present in Japan for a long time. And basically, it's a compound that prevents extravasation of neutrophils. And the neutrophils are, of course, essential in perpetuating inflammation around the pancreas. So you'll hear more about that. I think it has potential. We haven't yet seen the study that demonstrates that it makes a big difference. It's pretty expensive. And so I'm out of time. I wanted to talk to you about the prednisolone. I want to remind you that you need to do something against the pain. And now we try to be more all-encompassing because the opiates like buprenorphine are not always great. We use a lot of lidocaine as concentrate infusion. We use a little less opioids. We might use other substances such as ketamine or dexmedetomidine, following the guidelines of this International Veterinary Association for Pain Management. And so less opiates, more other possibilities. If you're into acupuncture, there might be things to do here for that, and we feed them pretty early now. I think I've gone over my 5 minutes by a few, right? So we started pretty late, but we don't want to make everybody uncomfortable and have the next person start too late. So I'm going to stop there. What I want to say about that is do feed your pancreatitis patients as soon as you can. It makes a big difference. And I'm sure you'll hear more, or you already have heard more from Dr. Procoli about pancreatitis during this meeting. Thank you, and if you have any questions, I'll be glad to take the microphone, or if you speak a little bit of English, I'll be glad to talk to you. Thank you. Or German. I do German too. All right. What time did we start? What time did we start? 15 minutes late. Okay.
But we need to
I understand. No problem.
be on the line.
Yes.
But it was perfect, yeah.
Thank you. What I'm going to do now, I have a break.
Yeah, we have a break till the...
For the next one.
Yeah.
So
yeah.
I was thinking maybe could I borrow that USB?
Yeah, of course.
Because it's here as well,
I
right?
need my computer only on this part, so
But you don't use the USB.
Włączają.
Szanowni Państwo, prosimy, że jak są wolne miejsca, to proszę się przytulić do siebie, bo chcemy, żeby tam jeszcze weszło parę osób na tą salę, na wykład. Więc tam, gdzie możemy, to zapraszamy serdecznie. Okej. Dobrze, wpuszczajcie proszę tam tych, którzy tam. Dobrze, ja już oddaję tu koleżance mikrofon. Oddaję koleżance mikrofon, już poprowadź to.
Szanowni Państwo, powtórzę po raz kolejny. Jeśli są jakieś torby po Państwa lewej czy prawej, one zostaną usunięte, dlatego że nie możemy niestety zajmować miejsc. I prosiłabym też osoby siedzące na schodach, teraz jest bardzo ładnie, ale żeby po prostu jak najwięcej osób się zmieściło, żeby nie blokować po prostu tych najniższych. Dziękuję. No niestety nie ma zajmowania miejsc. Pani Olu? Tam też pani woła?
Tak, gdzie są już to nie gdzie są moje rzeczy.
A jakie pani miała rzeczy?
Generalnie takie opakowanie miało. To moje. A gdzie są te pozdejmowane rzeczy?
No generalnie powinny być tu. Ale gdzie by pani zostawiła?
Zostawiłam je tam, na trzecim rzędzie. Może na schodach?
To tam są.
What are you telling the people?
I'm telling that
take a seat for the bag. Yeah, okay.
A informowałyście o transmisji?
People sit here like that. It's comfortable.
They want?
Well, better than on the floor, right?
Powiedz, że można siedzieć nawet na scenie, jeśli to nie jest problem. Tutaj jest jak uważasz. Dobra, chodź tam tak.
All right. Thank you very much. Well, I'm okay. You have plenty of
Na ten moment zapraszamy na tamtą stronę na schody. Są raczej zamykane. Można jeszcze się rozsiąść na scenie.
Błażej się spóźnił.
Dlaczego się spóźnił?
Bo był doskanował wyjściówki na
Dosłam cię, dzwoniłaś. Zeskanujemy przy wyjściu. Jesteś w stanie powiedzieć to przez mikrofon, że prosimy o skanowanie ludzi po wyjściu?
You're back.
Czekaj, sprawdź, czy się zaczął, a jeśli nie, to ja po prostu tam wyjdę na
So do I introduce myself?
Dobrze, to wyjdź. Dobra, dzięki.
Oh, you're going to see that. Okay. Can you see the lecture also?
Yeah.
Oh,
So we can start?
yeah,
Yeah.
because I like to start on time, so
Yeah,
this way
okay,
I have
okay.
time to do my lecture.
Tak. Dobra. Tak. Witamy Państwa po przerwie obiadowej na kontynuacji wykładów profesora. Chciałabym tylko dodać, że jest możliwość transmisji tego wykładu po zeskanowaniu QR-kodu. Jest też możliwość zadawania pytań w aplikacji kongresowej, także nie przedłużając, oddaję głos.
All right, thank you. Well, this is the most number one. Welcome. Welcome to this room. It's a busy room. I'm very humbled by that. And I want to thank the Polish Small Animal Veterinary Association for inviting me to speak. It's delightful. People have been very nice. The weather is not as nice as in Florida, right? So I have to say that, especially now that the storm season is over, right? So, yeah, I guess we have 2 lectures coming up, and we better get started, right? So the first lecture is a little bit out of order because I will talk about my general approach to dogs with chronic diarrhea, I guess tomorrow morning or tonight. I can't remember exactly when. But now we'll talk about how to approach dogs with refractory issues, right? And in the past, so when I say in the past, I was there in the past. The mistakes that were made in the past, I made these mistakes, okay? So I'm not saying you, and you, or they, and they. I'm saying we as a profession. But let's get started. So first, I wanted to remind you that as the Polish Small Animal Veterinary Association, if you are a member of that association, you are a member of FECAVA, you know that, and a member of the World Small Animal Veterinary Association, or WSAVA. And our president-elect, you should know pretty well, right? Jerzy Gawor. But there are two representatives at the board, Dr. Julie Stafford, who works in Alaska, and myself, who represent this region. So we are in touch with your association, and you know, we would love, I mean, we'll be here in 2 years, right, in Warsaw for the big Congress in 2026. Right, so now we will talk about issues pertaining to management of CIE. CIE stands for chronic inflammatory enteropathy. Okay, in the past, we used to call that inflammatory bowel disease, or IBD, but we're trying not to do that anymore, because IBD, as you know, is a common disease of people consisting of either Crohn's disease, morbus Crohn, or ulcerative colitis. And the phenotypes, these diseases are very different from what we see in dogs. So CIE, chronic inflammatory enteropathy, or if you prefer, chronic intestinal disease, inflammatory intestinal disease. So we'll see why things could go wrong. Is there a diagnostic error? Is there a problem with compliance from the owners and our treatment is not being implemented? Is there, I'm just keeping an eye on my watch, we'll see about dietary trials and assessing some forms of chronic enteropathies completely. So compliance, I'm sure you're very familiar with it, because people are people if they live in Łódź. See, I didn't say lots, okay? I did my homework. If they live in Łódź, in Warsaw, or in Bradenton, Florida, or in Baton Rouge, Louisiana, people are people. So, and I'm a person as well, so I know sometimes I don't always take the pills I should take. So, you know, you have this dog, and this dog is making a face like that. You say, no, you need to have the diet the doctor prescribed. And you see that face saying, please. Then there is a chance the compliance may go down, and the dog may get something else than the diet that is supposed to happen. I mean, maybe everyone is very compliant in Poland. If so, I will come and work here next week. I just need to learn the language, I guess. Or if your clients have a dog that size and you prescribed 1 milligram per kilogram of prednisone, I can tell you that your clients are not sleeping well. Okay, because this dog has to go out probably 2 or 3 times during the night. So that might limit compliance as well. Okay. On the other hand, if your clients have a dog like this, you can imagine why they are having trouble giving the pill that you prescribed, right? So I think we can have a joke about it, but compliance is a big issue. How can we improve compliance? With the whole team, with veterinary technicians or veterinary nurses, doctors, everyone working to educate the client so that, you know, they understand what we tell them. And we know that dog or cat owners in a veterinary hospital, sometimes they are a little, they find it awkward, they find it difficult. They only remember 20% of what you tell them. So you need to make them feel comfortable and work on the compliance. But it's also important to be humble. is the diagnosis you made correct, okay? I make wrong diagnosis, unfortunately, too frequently. I'm the first one to say that. However, I think about it. I say, well, maybe I did something that was incorrect, and maybe instead of what I thought, it was just something else, right? And so it's important to wonder, you know, about the diagnosis you made. That's the compliance issue. Is the treatment administered correctly? And another thing that's important, especially for severe chronic inflammatory enteropathies, is the systemic impact of the disease appropriately addressed. For instance, are we supplementing this little Yorkie with vitamin B12 if the Yorkie needs it, or potentially with calcium and vitamin D, as these may be deficient in some instances. All right, don't do that now. We're going to do that. And eventually, of course, if everything is okay, you can say, well, maybe we can still improve the treatment in some way. It's important when I talk about chronic inflammatory enteropathies, I assume that we have ruled out parasites. It's important, right? Because parasites are not uncommon. I don't know the situation in Poland well. I know the situation where I work, that it's a parasite kingdom. It's nice and humid. Every parasite loves Louisiana and loves Florida. So it's important to remember that. And so I won't address that any further, right? Giardia, do we have an issue there or others? We've also found recently that Giardia might just be an opportunistic parasite that likes it, where an animal is kind of perhaps in a situation of subclinical disease. Giardia might like that. It's not a horrible parasite, it just affects the very top of the microvilli, but it can still be an issue. And perhaps you're familiar with that. Let's look at this dog. Izzy, 9-month-old Mastiff dog. She was big, and she was female, obviously, and she was cachectic in spite of an excellent appetite. That had been going on for 6 months. You know, fecal parasitology had been negative several times. And she actually was dewormed anyway 3 times. The last time was with fenbendazole, the substance that's in Panacur, if you have that substance, that drug here. And she had undergone several diet changes. I don't recall what she all got. So, what do you think? No picture for you until you tell me what's happening. What do you think would be a possible disease affecting Izzy? I guess we can say, well, she has diarrhea, right? And so the intestine is involved either primarily or secondarily, okay? So it seems like parasites were ruled out. That's a primary cause of GI disease. She could have some types of inflammatory enteropathy, but we know that many of them respond to a diet change. I guess what else are you, what other organ are you thinking of? Absolutely. I don't speak Polish, but what you said sounds like something with the pancreas. And I assume you might have said maybe she has a pancreatic insufficiency. So yes, that's why she's in the first row, because she knows the answers. Soon you can come lecture with me. And absolutely. So what we did here is checking for TLI, trypsin light immunoreactivity, which is the diagnostic test of choice for exocrine pancreatic insufficiency. And it was very low, as you see, 0.4, when it's supposed, at the reference range at the time was 5 to 35, now it has changed. Often we check also for cobalamin or vitamin B12. It was higher than the norm, so that was okay, because these dogs usually struggle with absorbing cobalamin. And folate was high. Maybe there was some degree of dysbiosis associated with the issue. So here, really, the problem was not primarily in the gastrointestinal tract. It was in the pancreas. And one needs to think of that. And what happens in these young dogs is they get these subclinical pancreatitis that is lymphocytic, plasmacytic, that destroys the pancreas without any clinical signs of pancreatitis. And then you're left with no pancreatic tissue causing the insufficiency. How about Libby? She's a 5-year-old female spayed golden retriever mix. And she has had intermittent diarrhea for 6 weeks. Sometimes she's under the weather, which is an American, that means she's not feeling well. She has mixed signs, but predominantly large bowel diarrhea, eating well on most days, no vomiting, no weight loss. Physical exam is unremarkable. Fecal is negative, and she was recently dewormed with fenbendazole, which I consider to be one of the broad spectrum anthelmintics, and usually works well if you give it once a day at 50 milligram per kilogram for 3 to 5 days. All right, so when we look at dogs with chronic diarrhea, we can score them. You might say, who cares? He has diarrhea. Well, good point. But the advantage here is you can relatively objectively figure out put a number on that. So it's a semi-objective assessment of the severity of the issue. Okay, so we look at attitude, activity, appetites, vomiting, fecal consistency, defecation frequency, weight loss, and we score them from 0, which is normal, to 3, which is severely abnormal. And then you obtain an IBD, a canine IBD activity index, or CIBDI. And when you add the numbers, it goes from no clinical significance, mild, moderate, and severe. So if we look here, if you wanted to see the scoring, you can actually look at that QR code and download it from LSU should you want to. So we scored her at 7 in this instance, so moderate disease, okay? So she had a CIBDI of 7. Right, what do we do now for this girl, in your opinion? So are we going, does she look like she has EPI, exocrine pancreatic insufficiency? Not so much, right? That was more the other one. She's a bit too old for that. She's not really lost a lot of weight, but she seems like she has an involvement of the GI tract, probably primary, okay? And if we look at the diseases causing chronic diarrhea, from a recent paper from Romy Heilman, who is in Leipzig, and Al Jurgens, who is in Iowa in the United States, the most common reason for chronic diarrhea in a dog is food-responsive chronic enteropathy. We know that of all dogs with chronic diarrhea, between 50 and 75% of the dogs will respond to a diet change, okay? And we know that not only in America, we know that in Switzerland, that's where we knew it first actually when I was there, then other European countries, Australia and other places. So it's a worldwide thing. It's not just in America. So food responsive enteropathy, meaning that for dogs like her, we have here some population statistics from a study done in Switzerland. It's old, but it's still good in a way that food-responsive enteropathy tends to occur in younger dogs and in dogs that are a little larger. At least that's what it did in that Central European location of Switzerland. So she would fit the picture. She's young, middle-aged, and she is a larger breed dog. And many of these dogs have mostly large bowel signs. So you see here red large intestinal signs with food-responsive disease. That's the majority. Some have mixed signs, large and small. Very few have only small intestinal signs. For dogs that do not respond to food and a diet change, so they have a immunosuppressant responsive disease, then those tend to be more small bowel, or sometimes mixed. And dogs with protein-losing enteropathy, of course, they're always small bowel by definition. So the way we proceed here is that we're going to do things fairly simply. We're going to evaluate the dog with signalment, patient history, physical exam, include the dietary history, deworming status, environment where the dog lives. Okay, we can do a scoring. And if the diarrhea has only mild to minimal systemic repercussions, and by that I mean the dog has diarrhea but is not very sick, not losing a lot of weight, not vomiting, or certainly not much, then I would actually bypass all other diagnostic testing, especially if it's a younger dog, medium to large sized dog, and it has mostly large bowel diarrhea. I would just go ahead and put that dog on a commercial novel antigen or hydrolyzed protein diet, or a home-cooked diet for a novel protein. And I expect at least a partial response, usually a complete response, within 2 weeks. That's fantastic. You are also dermatologists, right? Because you do small animal practice, small animal medicine, and you know that for your patients with food allergy, with skin signs, you have to wait up to 8 or 12 weeks. Who is patient like that? Talk about difficult compliance from your client, and you're very familiar with that. Well, luckily with the GI side, because it's not per se an allergy, then we get a response a lot faster. So there it is. 3 weeks later, the owner started the elimination trial. It takes a few days to get the diet. They used a soy-based hydrolyzed peptide diet. See, I didn't put any brand. There's no, I see there are Polish brands for different diets, and there's no good or bad brand. There's the brands that you know and you're familiar with. Usually, they're the expensive ones because, the processing of that food is not cheap. Anything too cheap, I would say that's weird. And in the last 3 days, she's had another episode of large bowel diarrhea and decreased activity. What is wrong with that dog? She doesn't fit in my nice lecture. So what would you like to do now? I can see, I think there's another black one. Black one, black one, black one. There it is. Don't fall asleep now. Change the diet again, and you're super smart because it's not super new, right? It's not super old, it's rather new. If the diet doesn't work, you need to implement another dietary trial, okay? As long as the dog's condition has not deteriorated. So here, she is the same. She's not worse, but she's also not better. So you need to try a second trial. And maybe for that second trial, if you use the hydrolyzed peptide, you may use a novel protein diet. It's like I'm going to smile for you, no. And a novel protein diet But then you'd have to take a dietary history, right? If it's a dog that goes hunting and brings ducks back to his owner and all that, duck and potato is not a good idea, right? And so you're going to do your own research. There are 2 drugs on the market. They are just here. And it's not advertisement, it's a fact. Royal Canin Altamino, which, I don't know if you have Purina Elemental. Purina Elemental is an amino acid-based diet. Royal Canin Altamino consists of hydrolyzed chicken feathers. They're extensively hydrolyzed, okay? So they could be a go-to product, but they're also more expensive. So it's okay to try just another moderately expensive diet, okay? And if after that there is still no response, then you should probably consider a more in-depth workup with a minimum database, with blood work, possibly abdominal ultrasound, etc. And we should also do that if the dog's condition has deteriorated since the first time. Okay? What we discussed is if the condition is stable. Okay, so some people even recommend 3 different trials before saying that the dog does not have food responsive chronic enteropathy. Just saying. All right, and there was one paper published recently out of Colorado State University where they looked at 23 dogs that were presented to them with inadequately controlled chronic inflammatory enteropathy for like a long time, you know, up to median duration was more than a year. 18 had not responded to a veterinary therapeutic diet, and 9 had even failed 2 trials. And so ultimately, you know, 15, they followed up 22, 1 got lost somehow. 15 responded to a commercial amino acid-based diet, so one of these extensively hydrolyzed diets. That was with the Purina product, right? So just to say, it's not just me telling you that there is evidence in the literature that doing more than 1 dietary trial is recommended. What is the alternative? If you put that dog on steroids, for instance, prednisone or prednisolone, that dog may not respond because dogs with food responsive or diet responsive enteropathy do not always respond to steroids. And then you get to all the side effects of the steroids and you don't need them because the dog doesn't benefit from them. Right, so that's that. The pathogenesis of chronic inflammatory enteropathies, we'll talk about it tomorrow, but it includes an issue with dysregulated immune response, environmental factors such as the microbiota, but also the diet, and in some dogs, a genetic predisposition. And we'll see tomorrow that at the center of it all is the integrity of the intestinal barrier. If it's breached, if the intestinal barrier is breached, there is potential for penetration of factors from environmental factors from the lumen into the mucosa and causing immune issues with the immune system. So if we want to address the microbiota, in the past we've said, hey, let's give these dogs some antibiotics, okay? But we don't do that anymore, at least not as much, okay? Especially in Europe, you're way ahead of America. We are aware that there is a crisis with antimicrobial resistance. It's actually this week the Antimicrobial Resistance Awareness Week, not in America, but in the whole world, right? So also in America. And so resorting to metronidazole or other antibiotics, let's not do it as an automatic gesture, right? So there are other ways to do it. We can use probiotics, although probiotics don't always work as well as we would like it, okay? But they're an option, and especially those who are multi-strain and highly concentrated would be okay. There was one study out there in Italy looking at a probiotic called Sivomix. It's a European version of another name in America, Sivomix. Visbiome is the name in America. And they actually found that it worked as well in a group of 10 dogs. They had two groups of 10 dogs. One they treated with prednisolone, I believe, and one they treated with Visbiome or Sivomix. And they found out that actually both groups responded equally well. These were dogs that had not responded to a dietary trial. So potentially some hope there in that world. Another thing that is more and more recommended is fiber, okay? Dietary fiber. Dietary fiber has a number of positive effects. We know that it can help, let's say, with regulation of diabetes, so decrease the dose of insulin in some cases with a proper diet. It certainly can influence the gut microbiome, and the gut microbiome is huge in its effects on gut health, can impact the immune system in a positive way, will help with transit times, and will make the feces look good usually. So fiber, we've kind of, at least I have kind of neglected it in the past, like fiber, schmiber, who cares? But in fact, we should care. And ideally fiber should be consumed with the diet, but there are also ways to supplement fiber, such as psyllium, etc. We occasionally use fecal microbiota transplantation. It's really the ultimate probiotic treatment. And we consider it in some patients that have failed 2 dietary elimination trials, or some patients we've put on steroids, but where things didn't work out. Unfortunately, I'm not talking about FMT, but it could be that Dr. Procoli is going to talk about it. So time. So I still have 15 minutes, but good. It's good when we can start on time. Let's talk about Jolie. She's an 8.5-year-old Yorkshire Terrier. She is presented because of sudden onset abdominal distension, and tachypnea, lethargy, and hyporexia. She has an increased respiratory rate. She has a decreased body condition score and muscle condition score. And you notice that she has ascites on your physical. Point of care ultrasound that you do just to check. You see moderate to severe abdominal effusion and a little bit of effusion in the thorax as well. Then blood work is performed. Albumin is 1.3, so if you ask SI units, it's 13 gram per liter or 1.3 gram per deciliter. It should be 28 to 35 or 2.8 to 3.5. Globulins are also very low, so there is panhypoproteinemia. Cholesterol, you see is also below the reference range, and calcium, total calcium is below the reference range, which is not surprising because, as you recall, 50% of the calcium is bound to albumin, right? And if albumin goes down, total calcium will go down. The question is what happens with ionized calcium? No protein in the urine, so there is obviously an issue with protein, right? And so we're thinking either she's losing it. If she's losing it, not through the kidneys, because there's no protein in it, so that would be through the GI tract, or there could be an issue with the liver potentially as well. But we didn't really see any indication of that. The liver enzymes were not abnormal, so therefore she's been losing it through the GI tract, right? So protein losing enteropathy, and because she's a Yorkie, we think that it's probably associated with intestinal lymphangiectasia or idiopathic intestinal lymphangiectasia, dilation of the lymph vessels within, or the lacteals within the villi and all the way down into the intestinal wall is usually what happens. Okay, so if we look at her activity indices, SIBDI is not too bad. At 4, SECI, chronic canine enteropathy clinical activity index. This one contains some additional parameters, ascites and hypoalbuminemia. So therefore, she is higher there. So she's more moderate on that. And for SIBDI, she's mild. Okay, so initial management, we want to make her comfortable so that she doesn't have to pant and, you know, be in some type of distress. And then we switch her to Royal Canin GI low fat, or Royal Canin, I should say, since I'm French speaking originally. Prednisone, which is the same as prednisolone. Do you use prednisolone? Probably, because it's, I still like prednisolone a lot, but prednisone is okay. And it's a pretty high dose, right? 1.5 is immunosuppressive, really. And we check in 2 weeks. And then 2 weeks later, we're told she was better for a few days. And since then, there's been a recurrence of hyporexia and bloated abdomen. So the bloated abdomen is the perception the owners have of the ascites, probably. Now she has diarrhea, which was not a prominent issue initially. Serum albumin is kind of the same, really, a tad bit better, but I would like it to be above 2. Okay, so now her, if we put a number on that, she's gone up from 4 to 6 on SIBDI and from 7 to 9 on SECI. So moderate to severe disease. What do we do? Home-cooked, low-fat diet with a different protein. All right. You're too smart for me. I need to go back to America and learn more and come back when I know more. Absolutely. So I guess, you know, another one of these graphs. Dog with significant systemic disease, she has that, right? And that's Jolie. And there's a physical, the lab work. We should have measured the B12 and folate, which we haven't done. So that would be something to catch up on. And plus minor other stuff, but I think this would really be important. We could also assess the vitamin. Well, before we do that, we should assess the ionized calcium. Because her calcium was low, we would want to know, is it just the total calcium, or is it also the ionized calcium? And she is fairly stable. And so the key to her is going to be an ultra-low-fat diet, like you were saying. Home-cooked is probably the best way to go. GI low-fat is not bad. If they were really feeding just GI low-fat, or ID low-fat would be similar, they're pretty low in fat. If the patient is unstable, then you should provide supportive care, nutritional support for the dog to feel better in addition to the new diet. Okay, so if we look here at what commercial diets have to offer, so gastrointestinal low fat has between 16 and 28 grams of fat per megacalorie of metabolizable energy. That's the best way to calculate it. EN low fat, similar. That's the Purina product. ID low fat, same range, right? They're all about the same place. Why are they not lower? Because it is extremely challenging to create a diet, manufacture a diet that is extremely low in fat and still a balanced diet. So they struggle with that, and I don't blame them. I mean, I'm just saying that that's the way it is, right? And so we, let me see here. Yeah, I'm looking at this study from Dr. Jablonski from Michigan State University, where she took 10 dogs that did with PLE that did not respond to steroids. And they all were adjusted from a low fat, which is what's commercially available, to an ultra low fat diet. 1 minute, I'll show you what that is. And out of these 10, 8 achieved complete remission. So the steroids were stopped and they achieved complete remission. And 7 were still in remission after up to 4 years. It's amazing, right? Because a few years ago, we would all have said, "Ooh, let's give these dogs more steroids, and then maybe we can give them cyclosporin, or maybe we can give them chlorambucil." There is still potentially candidates for these immunosuppressants, but they are rare. And to be honest, these immunosuppressants didn't work that well anyway, and so these dogs their prognosis was not good, okay? So it's just, to me, frankly, amazing. Here also, if you scan the QR code, you can, excuse me, I have an itch. You can see a little table from LSU where the recipes are described in more details. But those are recipes to try for a short period of time. These are not balanced recipes, okay? But they include a protein, chicken breast, turkey breast, or some fish that is cooked, okay, with a carbohydrate, and it could be rice, it could be potatoes, and sometimes we give cottage cheese, which is not bad for protein, low-fat cottage cheese, not bad for protein supply. So, and these are the 8 dogs that responded to the treatment out of the 10 that did not respond to steroids. They responded to one of these diets. I don't know exactly which one, but one of these ultra-low-fat diets. So it's only for the short term, okay? What do we do then? Okay, well, in America, I'm fortunate that I work in a university, so I said, well, we need to consult with a nutritionist. And a nutritionist is going to come up with a way to have a balanced diet for this dog, potentially with some supplements, and have a diet that is very low in fat, okay? But so that's what we do in the long term. But these dogs do well, and you saw from the study from Jablonski, up to 4 years. Unbelievable, unbelievable. It's good news, right? So also we need to check for systemic complications in these PLE dogs, and that would include checking the B12 and checking the ionized calcium if you have that opportunity. Then if they're able to eat, then we'll give them, if they're interested in food, we'll give them an ultra-low-fat diet. And sometimes if they don't want to eat, but they're still in a good condition, I will cheat and give them just a little bit of steroids, 0.5 milligram per kilogram of pred, just to try and improve their appetite. Sometimes up to 1, but not more, for 5 days to try and get them to eat. And that puts them in a good mood, because steroids put you in a good mood. And then hopefully, I like my patients to be in a good mood. And so hopefully they will respond to that, right? And they will eat the food and then feel better. Okay, so let's not forget about the systemic repercussions of PLE. Jolie did fantastic, okay? She's been with us actually, she's been treated for a total of 4 years or something like that. And so we had to adapt the treatment. We had to, in a dog like that, you need to see them regularly for rechecks. She needed cobalamin supplementation. She was initially treated with a little bit of prednisolone. And so overall, you know, what I'm telling you is the truth based on the literature and based on experience. Right? So the diagnosis here needs to be correct. She had a food-responsive protein-losing enteropathy, and she didn't need high doses of steroids. So let's think of this. You might think it's weird, but let's think of our ability to put a correct diagnosis, the ability of our client to administer the treatment, and make sure we look at all of this. So I guess in the end, what we've rediscovered in the last maybe 5 or 10 years is the importance of the proper diet for all of these animals with GI issues, which makes sense, right? But for a while, we were so enthusiastic about immunosuppressants that we kind of forgot the basic thing. And that's what I have for you. Thank you. And I don't know if you have any questions. I have my best friend here to understand Polish. Otherwise, if you speak a little bit of English, feel free to come and see me afterwards, whichever you want. We don't have any questions? No. How do you know that fast? You're good. And so the next lecture is going to be a little bit later in, what is it, 10 minutes? In 5 minutes, sorry. Very good. The next lecture is in 5 minutes about diseases of cats. Yes. Hello.
I'm next, moderator.
And then I come back to you.
Very good. Thank you.
Tak. Ja wypędzę na swój i zaraz wracam.
Good luck with your own lecture.
Yeah, thank you.
5 minutes then.
Yeah, 5 minutes. You can slightly rest.
Thank you. I'll do that.
Proszę Państwa, proszę zajmować miejsca, bo zaraz zaczynamy. Dobrze. Chwilkę poczekajmy, bo tam jeszcze jest spory tłum. Więcej chyba Państwa nie wejdzie, jak myśli. Słucham? Tak, bo tu już jest naprawdę... Tam można obejrzeć sobie na ekranie przed tym. Sorry, Frederick. Are you ready? It's time. Oh, sorry. Let's go. Proszę Państwa, miło mi zapowiedzieć kolejny wykład Fryderyka Goschena. Proszę Państwa, będzie zatytułowany Przewlekłe enteropatie zapalne chłoniak i chłoniak jelit u kotów. Frederick, the stage is yours.
Thank you very much. All right. So we talked about dogs, but we're not talking about dogs anymore. We're going to talk about cats. There's still some room here to sit just here. 4 people. Especially if they're nice people. If they're mean people, I'm staying here. There's only nice people in Łódź, I know that, or in Poland. All right, so talking about cats and enteropathies. Now, I want to make sure that I do this correctly. I don't know about you, but for me, it's been a subject of frustration sometimes, okay? And so I decided maybe I could lecture about it so I will be less frustrated. So these are my disclosures. I keep showing a picture of Jerzy Gavor because I'm thinking maybe he'll give me a beer tonight if I show his picture as many times as possible. It's the 3rd time in 3 lectures, so I hope I have witnesses. But I'm very excited to be on the board of WSAVA, and if you have ideas or questions and you would like not to ask them to Jerzy because you don't like him, who can not like Jerzy, but then you can contact me if you want to. But unfortunately, unlike Jerzy, I don't speak Polish. But I have Google Translate, so if you write something in Polish, I'll put it in Google Translate, and there it is. So, a little bit of a war of, thank you so much for bringing water, a war of terminology, right? We've been talking a lot about IBD in the past, and now we're trying to come back from that because, as I mentioned, for dogs, the same is true for cats. IBD is really an inflammatory bowel disease, a disease of people with Crohn's disease, morbus Crohn. I always come to be in the middle of the picture. I'm sorry, I didn't mean to. So if you want to take the slide. Morbus Crohn or ulcerative colitis. And really what we see in dogs and cats is not that. It's something different, usually milder. And so in cats, we talk about chronic enteropathy, and they are divided in inflammatory diseases, chronic inflammatory enteropathies, and in lymphoma. So the latest name for the alimentary lymphoma is low-grade intestinal T-cell lymphoma. We've also called it small cell lymphoma. I don't care which word you use eventually. I'm just trying to bring you up to date. So chronic enteropathies of the cat include inflammatory enteropathies and low-grade intestinal T-cell lymphoma. That's the one that really looks like they look similar to the enteropathy. Right, and so chronic inflammatory enteropathies include both food-responsive enteropathies and immunosuppressant-responsive enteropathies. And so IBD and immunosuppressant enteropathies or immunosuppressant-responsive enteropathies can be used as synonyms. It's still a little confusing, but a little less maybe than before. A pathologist would talk about lymphocytic plasmacytic enteritis or eosinophilic enteritis, more so, but that's a histological diagnosis. And as I said, low-grade, what am I saying now? I can't figure out my own words. Low-grade gastrointestinal T-cell lymphoma include, can also be called alimentary lymphoma or small cell lymphoma. So we'll talk about some elements of etiology pathogenesis, clinical presentation, diagnostic approach, look at how to best evaluate biopsies, how to manage these cases, basically the total thing. I showed this before because in cats, it's pretty much like in dogs and in people, right? There are a number of factors that can contribute to the appearance of enteropathies. And in my opinion, it all revolves around the intestinal mucosa and its ability to keep the what is in the lumen, so you know, the chyle, what the animal has eaten, but most importantly the microbiota on the one hand, and keep a tight barrier between that and the body and the actual immune system. And if this doesn't work, then there'll be contact between environmental content and the immune response, and that's going to be the beginning of the inflammatory process. So we're not dealing with allergies, right? We're dealing with an abnormal contact of the innate immune system in the GI tract with some content from the lumen, be it microbiota or some nutrients. So inflammatory enteropathies can be divided in food-responsive enteropathy. It's not unlike what we discussed in dogs. Tends to happen in young cats, mostly large bowel diarrhea, possibly with some skin lesions, okay? That's the milder form that's going to respond to a diet change. In middle-aged to older cats, they could have either chronic inflammatory enteropathies or intestinal lymphoma. It's going to be very difficult based on clinical features, on lab work, on ultrasound to differentiate which cat has what. And you know that. I'm not teaching you anything new here. The recent question is, could there be some type of continuity between that? Could it be that cats, you know, start having food-responsive diarrhea, or food-responsive enteropathy, move on to chronic inflammatory enteropathy, and then to lymphoma? It's conceivable. It's known that inflammation can be a trigger for neoplastic diseases, and so, you know, the microbiota intestinal microbiota has been implicated in the pathogenesis of low-grade GI intestinal, what am I saying, low-grade intestinal T-cell lymphoma, and chronic inflammation is commonly found together with lymphoma in the same cat. If you do, if you perform biopsies from a cat and you take several biopsies along the small intestine, some of them could show lymphoma and some others will show inflammation. Recently, there's been some cytokines that have been shown to potentially be pro or proto-oncogenic, like oncogenic mediators is the word that was used. One of them is called STAT5, that is produced by inflammatory cells during intestinal inflammation and may ultimately lead to clonal proliferation of T cells. So there is, we don't know for sure, but we suspect strongly that there is a link between both. Lymphoma in the intestine comes in different ways, right? There's the way we just talked about, low-grade intestinal T-cell lymphoma, 90% T-cell. It's quite prevalent. For those of you who have been around as long as me, we didn't have that type of prevalence of GL lymphoma in cats, let's say 30 years ago. But things have changed, and now we're 30 years later, and that's really the most common type. Now, there are other types of lymphoma that tend to not cause diffuse infiltration of the small intestine, but rather segmental, potentially masses that you could actually palpate on abdominal palpation. Those would be high-grade intestinal lymphoma, large granular lymphoma, potentially intermediate-grade lymphomas, and so those will affect the same areas, but again, eventually they give more a picture of obstruction, intestinal obstruction, and therefore vomiting because of that, and also weight loss because the neoplasia is going on, okay? So today we will really talk about that diffuse form, low-grade intestinal T-cell lymphoma, and not about the others anymore. So what do we see in cats with chronic enteropathies? Often, especially those that are, CIE or LGITL, weight loss. That's very common, okay? Initially can be subtle with spinal muscle loss, focal sarcopenia, so muscle loss, gradual progression ultimately, and might not initially be noticed by the owners. Vomiting is present in many of these animals, okay? The question is, what frequency of vomiting is acceptable in a cat? Okay, we're confronted with that fairly commonly. Is vomiting once a month acceptable? You might say it depends on, is it a long hair cat that has hair balls, or is it a medium or short hair cat? So I don't know what is your limit as to where you say, oh, if the cat vomits more than so many times a month, I am not happy. My limit is once a week. There is a paper out there saying 3 times a month. Same thing, right? Almost. I know a week has 4 months. Months have 4 weeks. I need some water. Do you have any water with gin or something? I don't remember the difference between month and weeks. No excuse. Anorexia, quite common as well, right? Diarrhea is common, but only in a half to 2/3 of the cases. So it leaves 1/2 to 1/3 that won't have diarrhea. In physical exam, you'll see a low body condition score, maybe some cranial abdominal discomfort or pain, maybe, doesn't have to be. Maybe that cat also has pancreatitis and cholangitis, and maybe has triaditis, potentially. Or you can potentially palpate intestinal loops. I find that sometimes I believe in myself too much. I say, ooh, for sure, this is abnormal. And then I will look at it with the ultrasound, it's like, not so much. So I tend to be more humble. In a study out of Paris, France, male sex and longer duration of clinical signs and polyphagia were clinical markers for LGITL, meaning cats that had these features tended to be more likely to have lymphoma. So there we have different approaches. In young cats that are in good health, and again, that ominous thing about parasites, where if they go outside, we've ruled out the parasites. Then also in middle-aged to older cats that are otherwise in good health, then we're going to consider just changing the diet. And we've all done that. And in cats, we can go with different diets. They could be GI diets, or they could be novel protein or hydrolyzed diets. There's not a proven benefit. But if we look here at a recent study from Arti Katwani out of the Royal Veterinary College in London, they said the best chances of success for a dietary elimination trial was if the cat was young, so more success in young cats, less than 6 years old. Cats that were not pre-treated with glucocorticoids or antibiotics, and cats that had not been treated with no other treatment. So she looked there at it was a very large study looking at medical records from Vet Compass, which is a medical record system in Britain. And they looked initially at 500,000 cats, and then they ended up having nearly 1,000 cats, 1,000 medical records of cats. And that's where they saw, looking at these medical records, that they could identify these points. The second way to approach them is more appropriate for middle-aged to older cats with systemic signs such as weight loss, lethargy, hyporexia. And because these signs are not specific of GI problem, because cats are not very smart at showing different diseases differently, we need to rule out the other diseases such as chronic kidney disease, hyperthyroidism, and other such diseases. So we want to eliminate them by doing what we call a minimum database, which would include hematology, biochemistry profile, urinalysis, and imaging, usually with ultrasound, sometimes with radiographs as well. And once we've done that and ruled everything out, then it remains, we need to differentiate inflammatory from neoplastic situations. Okay, so we have these cats, we exclude diseases originating outside of the stomach and intestine. They could also have liver disease or pancreatic disease. We do an abdominal, and so we've done a hematology and chemistry here, urinalysis. We do an abdominal ultrasound. It's a good idea to measure serum B12 in these cats as well. And then we really have two ways to go, okay? If the abdominal ultrasound shows signs of abnormal intestinal wall, we can either go the aggressive way, which is to obtain intestinal biopsies and then have them analyzed, or some people may just not have the money for that, the finances for that, or maybe they don't like the idea, and we could consider a treatment with diet and prednisolone, and the B12 is going to be given whichever way you go there. And that would be a start. And if things don't work out and the people still don't want to do a full workup with biopsies, we could add chlorambucil. We'll talk about it in a few more minutes. And then if it doesn't work, then we're in trouble. So we need to start again, right? But here you recognize the small intestinal wall as viewed on ultrasound. The first layer, that's the lumen. The first layer is the mucosa. Second, that's hypoechogenic, hyperechogenic submucosa, hypoechogenic muscularis, and hyperechogenic serosa. Sorry about that. Doing the ultrasound allows you to look at wall thickness, wall layering. We just went over that. Potentially motility. Echogenicity of the periintestinal tissue, is the fluid. We can also look at the lymph nodes and at the distribution of the disease if we see any disease. Let's look at two cases. Cooper was one of them. And Cooper was a 10-year-old male castrated domestic short hair, presented for vomiting, weight loss. He was an indoor-only cat, and he was chronically and intermittently vomiting for 2 years. Now he's vomiting more, so the owner is getting a bit more anxious, like twice a week or so, and his appetite has decreased, and he's lost weight. Okay, so on physical, we have fairly normal basics here, a little bit of weight loss. He appears a bit dehydrated, otherwise he's fairly remarkable. So that's our problem list: chronic vomiting, hyporexia, weight loss. She's vomited blood once, and he's mildly dehydrated. So where do we go from here? Because our differential diagnoses are multiple, right? We do have to consider the kidneys. We do have to consider the possibility of hypothyroidism, potentially issues with the liver, although he's not icteric, but some type of cholangitis, or potentially, what else did I have in mind? Maybe an issue with the pancreas. So we did a minimum database, like I had mentioned before, okay, and hematology, chemistry, and urinalysis. I think they were mostly unremarkable because I didn't put them on my slide, so my recollection is they were relatively unremarkable. Here we're looking at Cooper's small intestine, transverse view here. You can see the mucosa, submucosa, and you see here the muscularis that is quite thickened. Number one, the whole thickness of the wall is more than it should be. It should be around 3 millimeters. Here it's like almost 5. And you can appreciate here the thickening of the muscularis layer. Again, mucosa, submucosa, muscularis serosa. It should be a line. It should be a thin line. Here it's really big. So that tells you that the cat has a chronic enteropathy. Initially, people thought, oh, that's typical for lymphoma, but that lasted about 2 months. And then there was a paper showing it can be lymphoma or inflammatory enteropathy. So it confirms that there is a chronic enteropathy. So these owners were all ago, they wanted to have biopsies, and you can see here, we ended up going, as you can see from the thickness here, with full thickness biopsies taken by our surgeon, right? That's a very good way to take biopsies. Endoscopy is perfectly fine as well. But we felt that the lesions were too far from the duodenum, and we felt maybe we would have trouble reaching them because we can only go with a scope in the duodenum or the other way in the ileum. So we said, let's ask the surgeon. So if we look here at a normal small intestinal mucosa, you recognize these nice villi that are thin and healthy looking, right? And this is Cooper, and Cooper had very thickened villi. They talk about fused villi. So the absorptive capacity was majorly decreased compared to a cat that would have normal villi like that. The absorptive surface was decreased, and so there were also inflammatory cells located there, and the most prominent lesions were lymphoplasmacytic infiltration with neutrophils and eosinophils, and these architectural changes I showed you, and the surgeon took a lymph node and it showed reactive hyperplasia. Okay? So when we take biopsies, of course, we all ask our pathologists to do an Ag-Ne hemaloun and eosin stain, and that's what they did here, and there are criteria to evaluate them. But often it can be tricky because lymphoma and inflammation may look similar. So we use other techniques, immunohistochemistry with antibodies against T and B cells, surface markers of these cells, CD3 for T cells and CD20 for B cells. And sometimes we use T receptor gamma clonality. So we check the PCR for antigen receptor rearrangement, or PAR. And this is something we need to use, in a wise manner. We'll get into that in a minute. These new markers here are not quite available commercially. For Cooper, we can see here a slide like a cut from the mucosa, two sections that were near each other. Here, the stain was against B cells, surface markers, so CD20. You can see positive is that brown color here. So there were B cells there, and there were T cells there as well. B and T cells present makes it that it's inflammatory, right? If it was purely neoplastic, it'd be T cells only. So his diagnosis was IBD. And this looks complicated, but all what I want to say is there's been a number of papers, this one from Betty Chow fairly recently, showing that if you assess biopsies using hematoxylin and eosin, you might be wrong with your assessments. In this study, they looked at something like 48 cats or something like that had been had undergone biopsy collection. They all had some form of enteropathy, either inflammatory or neoplastic. And there 24 were definitely IBD based on their H&E assessment from the pathologist. 4 were possible lymphoma, 11 probable lymphoma, and 18 definitely lymphoma. And then they used immunohistochemistry and PAR, and they reclassified them. And then out of the 24 initially diagnosed with definitely IBD, 11 were reclassified as having lymphoma. So it's very easily to miss lymphoma cases if you do not use additional staining with immunohistochemistry and clonality. Because it does matter, you're going to treat the ones with lymphoma differently as a clinician than you would treat the ones with IBD, right? So just so you know. His COCO was presented for chronic small intestinal diarrhea, indoor cat, with hyporexia, anorexia going on and off, weight loss, 6 months duration, and she had been treated with depomedrol. You probably have that here, which occasionally used for skin diseases. Doesn't work for cats with enteropathies. But they tried, it didn't work. Here, not much to say. She must have been obese a little bit. Now she was okay. And our problem list was chronic small intestinal diarrhea, blah, blah, blah. So not very different from Cooper, if you want. We have to go through the same differentials and the same diagnostic plan, right? So here, CBC was unremarkable. Chemistry panel, a little bit of an increase. ALT, T4 was normal, mild hypophosphatemia, low cobalamin, here at 181, that's the reference range, and high folate. Right, that's what we found. It's not unusual to find mildly to moderately increased liver enzymes in cats with intestinal disease. So we did some ultrasound. I think I have 2 here. And we can see here also in this longitudinal view that the muscularis was also thickened, as was the case with Cooper. And here I won't fall on you, I promise. I have to come closer here. This is a lymph node which appeared enlarged and a little weird and not normal appearance, a little bit heterogenic. So they didn't really know, they being our radiologists, what to do with it, but they wanted us to know that there was lymphadenopathy overall. These are just two pictures from the scope. We felt comfortable here doing endoscopy. And I would say that the mucosa looked a little granular altogether, and it would bleed fairly easily. We took our biopsies, nice biopsies, you know. I didn't take them myself, like I had one of my colleagues do that, so I can compliment my colleague. They're nice biopsies, they're well-oriented, and we see a lot of purple. When you see a lot of purple in biopsies, it usually tells you there is inflammatory infiltration, right? And so this infiltration was mostly with lymphocytes and some plasma cells, and we did here the immunohistochemistry. B cell, CD20, no brown, versus T cell, CD3, it was all brown all over the place. So meaning, in other words, that this was a purely T cell process, and the pathologist, because of this and other features, diagnosed a low-grade intestinal T cell lymphoma. Okay? So when you want to differentiate these two, really, you're going to say, well, the clinical signs are the same, okay? I guess you could do an empiric trial if the cats have minimal systemic issues, you know, for sure, that's always a good idea for a couple of weeks. And empiric medical treatment is an option if the people don't want to pursue further investigations. H&E stain is not good, or is not enough for most pathologists to differentiate inflammation from neoplasia. We know about the two tests we can use, and it's important to work together with your pathologist to get where you need to go. There was recently, so let me see here, I'm just trying to see my timing because I want to be on time with you guys, so I have 30 minutes, okay. I have done 30 minutes. So there was recently a consensus statement published from the American College of Veterinary Internal Medicine, very prestigious people there. Dr. Fresh, she's out of the vet school near Paris. Dr. Marsilio, she's out of University of California, Davis. And they basically confirmed, you know, the statements I made were basically rephrasing their recommendations. So for Cooper, chronic inflammatory enteropathy, okay, how do we treat that? We switched him to a hydrolyzed diet over a short period of time. We figured out that his B12 was within the reference range, but in the low half of the reference range. If a cat has a B12 in the low half of the reference range, you should supplement them. Why? Because B12 in the serum is a poor marker of B12 in the body. There would be a better marker, but it's too expensive to use commercially. So we end up supplementing anything that's, you know, below the middle of the reference range, which that was the case for Cooper. And he was treated with prednisolone initially at immunosuppressive doses. Okay, so if you want to figure out more about the protocols on administration of B12, I recommend you check if you speak English, it helps. I guess the Texas A&M GI laboratory, they have up-to-date information. Usually we give 200 microgram per cat subcutaneously for 6 weeks, then we stop and we recheck a month later. You can also give, if you have an owner with a cat that can take pills, you can give that orally for 12 weeks and then wait a month and check the serum cobalamin. Right? So that's Cooper. How did he respond? Okay, so We continued the prednisolone treatment for quite a while, we were able to discontinue the cobalamin injections. And the last recheck I have from him was 2 years after the initial diagnosis. The vet had discontinued the prednisolone completely at that time, and the cat was still receiving the diet, but that was all. So he did pretty well. And then I lost, nobody knew, I mean, I couldn't figure out what happened with him after then. So pretty well. So we started, that summarizes the treatment we gave him. In some diabetic cats, you're a little bit in a conundrum because, of course, prednisolone has a insulin-resistant effect. So we switched them to budesonide. It's not perfect, but it can help a little bit. And if the disease doesn't respond to steroids, you need to reconsider your diagnosis. Chlorambucil may be added to the management. We'll talk about chlorambucil in the treatment of Coco. Coco had low-grade intestinal T-cell lymphoma, and the treatment for that is prednisolone, same dosage as for Cooper. However, we add chlorambucil. So I don't know if you have access to chlorambucil. You do, fantastic. It's also sometimes difficult because to ask owners to give chlorambucil, see, that would be the dose to give. If the cat is more than 4 kilo, you give a 2 milligram tablet every other day initially, and then you switch when things are controlled to every 3 days. If the cat is less than 4 kilo, you start at every 3 days and you go with maintenance to every 4 days. Some owners are not able to do that, so we do pulse dosing in these cats where we ask them to come to the vet school and we give them a higher dosage, once every 2 weeks or once every 3 weeks, depending on their weight. So, but that's the key to the treatment, and it works well. It has relatively low side effects, but potentially could have cause issues with the liver or the bone marrow. That's why we double check these parameters regularly. And then if the cat gets out of remission, either you can reinitiate chlorambucil at the high dose, or there are rescue options, but there I will admit I am not an oncologist, so it would have to be done together with an oncologist to figure out exactly what is best for this cat. Okay, so we know about the subtypes of lymphoma. In the cat, we followed up Coco over a long period of time. He did pretty well overall. There were some issues with neutropenia associated with the chlorambucil, diabetes mellitus that had to be addressed. But overall, we followed, I think, this cat for more than 2 years. We just recently, Coco was put to sleep because of chronic kidney disease. But I think Coco survived nearly 3 years altogether with low-grade intestinal T-cell lymphoma. So it's not bad, right? It's not bad. If we look at prognosis, a study out of Italy a while ago had a median survival time for IBD. They couldn't really measure it, but for LGITL was 416 days, and a 3-year survival, that'd be the Coco situation, of 15% versus 71% of 3-year survival in the IBD or CIE cats. Bear in mind that they might have died from other diseases as well, such as kidney disease or other things. That was a study from France a little later where you can see the intestinal lymphoma cats had a mean survival, I want to say, of about 500 plus days, so a year and 9 months or something, versus the IBD CIE cats. They did really well. over time, and there's not enough of them that die that we can have a median survival. There, a study out of the Royal Veterinary College where cats with chronic inflammatory enteropathies were followed up. Now, bear with me, this is an institution where they see second opinion and third opinion referrals, so they may see the most difficult cases. They had about a third that were of their CIE cats that were euthanized after about 4 months. And then half of them roughly were still alive and doing well at, what is that, 2.5 years later. And some of them were diagnosed with food-responsive enteropathy and did best of all. Attaining a clinical remission reduced the subsequent likelihood of death. So if they were difficult to put in remission, they were more likely to have issues with a shorter survival. Now, does that mean we don't need to worry about it and we should treat all these cats as if they had chronic inflammatory enteropathy and then escalate to give them chlorambucil if they don't respond? Potentially, but there is preliminary data from an abstract at the European College of Veterinary Internal Medicine a couple of years ago showing that 2 groups of cats were looked at, right, after being referred, and those that had received prednisolone prior to referral and diagnosis survived less long. All these cats ended up having LGITL, while those that had received prednisolone survived about a year, versus those that had not been treated survived about 2 years. So perhaps the data is still preliminary, but if that is true, it might be a reason to push for the diagnosis rather than go with empirical treatment, right? So sometimes there's no other way than doing empiric treatment. We're not going to euthanize these poor cats because they have a disease that responds to some form of treatment, and if the owners are willing to give the treatment, it's worth to go ahead. Prednisolone and glucocorticoids are a mainstay. Chlorambucil is the anti-neoplastic immunosuppressive drug of choice. Antibiotics, we never talked about them. Wasn't it a fun 45 minutes? We didn't talk about antibiotics, so let's not talk about them. And cobalamin should be evaluated as well in these animals. Right, so I'm 2 minutes after time, I think, 3 minutes before time. So if you have any questions, I'll be happy to try and answer them. Otherwise, if you want to ask me questions in English, come forward.
Sorry.
That's the boss here. I'm sorry.
Sorry. Frederick, time is over.
Okay.
Jeżeli Państwo będziecie chcieli zadać pytania, dlatego że przenosimy się teraz do 17:10 na halę 5. Tam będą 2 wykłady jeszcze Fryderyka i myślę, że będzie czas, dlatego że jest Państwa dużo i zostałem poproszony, żeby szybciej troszeczkę opuścić, bo następna, że tak powiem, grupa tu wchodzi, a no jest wąskie gardło, że tak powiem. Także dziękujemy. We are changed the hall, yes? Okay. We go to the hall 5 on the yes, yes, yes.
But I have an hour.
Yes, break. Okay.
I'll go around.
Okay.
Somebody else is coming, right?
And we meet in the next lecture. Okay.
Yeah.
Disease of the esophagus. Okay.
Yeah.
Okay.
Yes, sir. I'll see you.
Proszę Państwa, dzień dobry. Mamy jeszcze czas, 10 minut do wykładu, jeśli się nie mylę, tak? No, powiedzmy, że 7. Pamiętajcie, że zapytania wszystkie przez aplikację. Prosiłabym też, żeby te pytania były konkretne, bo mamy mało czasu. 2 pytania generalnie wybieramy i fajnie, żeby to były jakieś konkretne pytania bez opisów przypadków, jakby, bo to trwa 1 000 000 lat. Pan profesor na pewno na jakieś skomplikowane pytania bardzo chętnie odpowie po wykładzie, także zapraszam do pisania pytań w aplikacji. Najlepiej, żeby można było odpowiedzieć tak lub nie. Także, dobra, zaraz zaczynamy.
To znaczy, ja jestem od kamer, ale
Okej, bo tutaj generalnie...
co potrzeba?
Tak. Pan profesor pobiegł do...
Ale czy ma
po komputer
pan profesor
swój.
komputer? No właśnie.
Tak, bo... jakby,
Nie było informacji.
Nie no, informacje były inne, więc ja potem zadawało inaczej, ale spokojnie damy sobie w tym razie.
Dobrze, czyli tak, to jest...
Akademii potrzebuje ich kod.
Tak, to zrobimy tak. Zależy, jaki komputer pan profesor przyniesie, to ja bym chciał nagrać. No to bardzo dobrze. To będzie w takim razie ten kabel.
Dobra.
To będzie ten kabel, tak mi się wydaje. A jak nie, to go zaraz już przepinam. Natomiast któryś z tych kabli jest do rzutnika na suficie i to jest ten kabel. Po prostu ja nagrywam do Pani wszystkie te prezentacje, a potem to zmontowane. Ale z Macami jest problem, bo trzeba z Maca, nowsze Maci nie pozwalają, że jak nie mają za słaby sygnał czy coś, więc wypuścić na rzutnik, ale ja wtedy nie mogę rejestrować. Więc zobaczymy, co pan profesor przyniesie. Powinno być dobrze.
Proszę Państwa, 4 minutki opóźnienia, wybaczcie nam. Mogę zatańczyć, zaśpiewać, nie wiem. Paduwa. To był taki ten, krakowiak. Krakowiaka tylko z Paryża.
Nie ma problemu.
Nie pierwszy raz. Co pijesz, mój napój?
Stresuję się, że tak mówię. Żeby miał taki furlik.
Jagodowe coś tam.
Jagodowe cukier.
as a cameraman, sorry.
But for us,
Yes.
you are the most important.
So total lack of organization.
Yes. Misleading information.
Yes. Not total lack of organization because we have power supply.
No, it's the other side. It's there.
Jak widać, pan profesor chyba lubi pingwiny.
Everything's fine, I guess.
Jeszcze raz przepraszam za opóźnienie, problemy techniczne, niezależne od prezenterów. Chciałam Państwu serdecznie przedstawić pana profesora. Pan profesor Emanuelis Saridou-Michalakis pochodzi z Grecji, jest uznanym specjalistą międzynarodowym w sprawach dermatologii. Też znany jest bardzo ze swojej wiedzy na temat leishmaniozy. Autor 1 600 000 publikacji. Bardzo w mojej ocenie ciekawy wykładowca. Zapraszam Państwa na wykład dotyczący chorób skóry szczeniąt. Jeszcze raz przypominam, pytania zadajemy w aplikacji i oddaję głos panu profesorowi. Emanuelis, please.
Thank you very much for the introduction. So, the topic of this presentation will be about puppy dermatology. And I will start with some particularities, not too many, we have when we deal with a puppy. In general, dermatology in puppies is quite the same like in adult dogs, like in old dogs, but there are some minor differences that we may have to consider. One of them, when taking the history, is from where the puppy was bought. For example, it may have been purchased from a foreign country, and it may carry parasites that are not common in our country. This is my classical example. Keletiella is extremely rare in Greece. This is an adult, and this is in a high magnification, an egg of a Keletiella. And this was a dog where all these lesions, all these scales and crusts you see are due to Keletiellosis. And the dog was brought from abroad. It's very, very rare to find this parasite in a dog that lives exclusively in Greece. Perhaps you have some similar situations from time to time here in Poland. Another thing is if the puppy was bought from a pet shop, because there it may have some direct or indirect contact with other animal species, and this may lead to some strange contagious diseases, for example, dermatophytosis from species that are not very common in dogs, or transmission of parasites from other animal species.
For example, this is called Roth's flag, is the technique we're using to identify the species of dermatophytes in Saburo and DTM cultures. And you can see that in this puppy, we found this, which is Trichophycoton metagrophytes. And these are the hyphae of this dermatophyte species. And the characteristic here are this spiral shape in the hyphae. The natural reservoir of this dermatophyte are the rodents. So the puppy was bought from a pet shop, and there it was in contact with some rabbits, who knows what else, rodents they may have had there, and it developed dermatophytosis due to this unusual species. This is another example. This is videotoscopy, and now you will see these creatures that are moving, walking on their canal. Obviously, it's Otodectes cyanotis, a very common parasite in cats. Many cats are asymptomatic carriers. And when you have a puppy that was bought from a pet shop with cats, then the chances for the puppy to have otodectic mange are increased. Other than that, considering diagnostic particularities of puppies, the only thing I would mention is be careful of the maximum dose of the local anesthetic if you want to take skin biopsies. Normally, when we have a disease that must be diagnosed histopathologically and we have to take skin biopsies, we're performing local anesthesia and we're taking, depending on the case, at least 3-4 biopsies. And at each biopsy site, we're injecting, let's say, 0.5 to 1 milliliter of lidocaine. And in adult dogs, we don't care about the total dose, but in puppies, we have to be a little bit careful because the maximum accepted dose for lidocaine is 10 milligrams per kilogram. So if you consider that the commercial solution, at least the one we are having in Greece, has 10 milligrams per milliliter, if you have a 1 kilogram puppy, then the maximum total dose you can give is 1 milliliter of xylocaine. And this means that if you want to take 4 biopsies, for example, either you should infiltrate just 0.25 milliliters per biopsy site. I'm afraid the dog will be in pain during the biopsy procedure, or you can dilute the topical anesthetic in water for injection or in normal saline in an effort to increase the volume that will be infiltrated in every single site. So we have 1 kilogram puppy. Maximum dose of lidocaine we can give is 10 milligrams per kilogram, meaning 10 milligrams, meaning 1 milliliter. We're diluting xylocaine with normal saline at 1 part xylocaine, 1 part normal saline, and we're infiltrating each of the 4 biopsy sites with 0.5 milliliters. In this way, we will achieve topical anesthesia. We will be able to take the biopsies without causing pain and without risking an overdose, because these local anesthetics, when they're given at high doses, they can cause seizures and also they can cause heart arrhythmias. So we have to be careful. Now, considering the treatment, if we're going to use topical treatment, especially in the form of shampoos, of solutions, we have to be very careful of the risk of hypothermia. A puppy has a very large body surface area compared to its body weight. Also, the homeostatic mechanisms of a puppy are not well developed. So these animals are prone to hypothermia. So if we're going to bath them, or if we're going to apply a whole body solution, this must be done in a warm environment, and then we have to dry it again in the warm environment before leaving it. The second is about systemic treatments. If you open the leaflets of almost every single veterinary drug, you will see that there is a warning say that this product can be used in dogs over the age of, I don't know, 4 weeks, 6 weeks, 8 weeks, 3 months, whatever. So we have some restrictions in puppies. The question is why? There are 2 possible reasons. One reason is because the drug is toxic to the puppies. This means that the puppy, since it does not have fully developed mechanisms, enzymatic mechanisms in the liver to detoxificate the drugs, to inactivate and excrete the drugs, may be prone to toxicity if it will receive the drug. The second reason can be simply that there are no studies in puppies. Most companies, when they want to launch a product, will test it in dogs older than 2 months, for example, or 3 months. So, if we have a puppy that has to receive a systemic medication, and we do not have an available drug registered for the age of the puppy, we have either to totally avoid it and give just topical treatment, or to risk, but if we're going to risk, we have to be sure that the reason that the product is registered for dogs more than 3 months, for example, is not because it is toxic to younger dogs, but simply it is because it has not been tested in younger dogs. And you can read it in the leaflet. Sometimes they say that the drug is not recommended in dogs less than 2 months because it has not been tested in this age group. In this case, you can risk to give it. It's not usually a major risk. So, let's start with some common diseases in this age group. And let's assume, I'm sure everybody here has seen this presentation. A puppy is coming to your practice for vaccination, let's say, and while performing your physical examination, you discover these lesions. These are the inferior thighs, the inner thighs, excuse me, and a closer view, you can see these pustules. Sometimes the owners see these lesions and they will bring the puppy for this, but most of the times this will be an incidental finding during the physical examination. So what is this? This is called impetigo, and it is a bacterial infection that does not involve the hair follicles. It's a bacterial infection of the epidermis between the hair follicles. The most common organism isolated is Staphylococcus pseudointermedius. And if you look at the books and the literature, you will see a full list of diseases that in theory predispose puppies to develop these skin lesions. You will see poor hygiene, dirty environmental conditions, endoparasites, ectoparasites, canine distemper, and many more. The reality is that the vast majority of these puppies with impetigo have 0 underlying factors. It's just the young age, it's just the immaturity of the defense mechanisms of the skin that allow a commensal bacterium like Staphylococcus pseudointermedius to enter into the corneous layer of the skin and create these characteristic big pustules. And the characteristic of these pustules is that they do not involve the hair follicles. And to understand this, compare the pustules we saw before with this one. This is from a dog with bacterial folliculitis. Here we have infection of the hair follicle. And you can see a small hair inside the pustule. So from this picture, we know that this is not impetigo, this is bacterial folliculitis. Look here that the pustule is much, much larger and corresponds to the area occupied by 5, 10, I don't know, perhaps even more hair follicles. It is important because the treatment is not the same for bacterial folliculitis. In bacterial folliculitis, we always have to use topical antimicrobials and sometimes also systemic antimicrobials. And in impetigo, where usually we're doing nothing. Other dogs with these huge pustules. Another one, you see also the erythema around the pustule. There are developing pustules also in these areas. And the pustules will rupture, and this pus will dry on the surface of the skin, and we're going to have some yellowish crusts. And if the inflammation will expand peripherally, then we're going to have epidermal collarettes. So you see here the pustule, and you can see here the crust. You can see here the pustule, and here the area with the epidermal collarette. It's just the walls of a ruptured pustule. The typical distribution is at the ventral trunk. I really believe that there are also pustules in other areas of the body, but it's so hard to see them due to the hair coat. Simply, it is much easier to see these pustules in the ventral aspect of the trunk where there are not a lot of hair. And typically, this disease is not pruritic. The major differentials are bacterial folliculitis, as I showed you before. Now you know how to differentiate or to try to differentiate these two diseases. And another major differential is pemphigus foliaceus. I would agree that pemphigus foliaceus, an autoimmune disease with production of antibodies against desmosomes, I would agree that pemphigus foliaceus is very rare in puppies. But this does not mean that it does not exist. I have seen this disease in 3-month-old dogs. So the definitive diagnosis usually is based on cytology. And what we expect to see, this was taken from an intact pustule. We punctured it, the pus came out, and then we put a glass light on the pus. And of course, here we have the red blood cells that will guide us to the interpretation. Here we have nucleated cells. Obviously, they are neutrophils. And here we're having one neutrophil that has phagocytosed 1, 2, 3, 4, 5, 6, 7, probably 8 cocci. So this proves that we have an infection in the skin, that the body reacts to this infection and sends the neutrophils there in order to kill the bacteria. So it's a definitive proof of a bacterial infection. If you combine this with the clinical presentation and the age of the dog, then you have the diagnosis of impetigo. But sometimes, in addition to the neutrophils, you can see the neutrophils here, you can see the cocci here, the phagocytosis, everything totally compatible. Again, another neutrophil with phagocytosis. These are red blood cells. This is a macrophage. But look here, there is also this cell. And this is an acantholytic cell. Sometimes in the skin lesions of impetigo, on cytological examination, we may find acantholytic cells. And we know that these cells are more characteristic, more typical of one of the major differentials, pemphigus foliaceus. So you have to be very, very careful not to interpret these acantholytic cells as evidence of pemphigus foliaceus. To put it in another way, since we are having in the lesions neutrophils, cocci, and phagocytosis, this is a bacterial infection. Let's treat the bacterial infection, and we will see if the pustules with the acantholytic cells will remain after the treatment of the infection or not. If they will remain, then we have to consider of the possibility of pemphigus foliaceus. They say that usually the number of acantholytic cells is much lower in impetigo compared to pemphigus foliaceus, and this is true. But this, which is one of my beloved photos of acantholysis, you can see tons of acantholytic cells plus neutrophils. This photo is from a puppy with impetigo. My best cytological photo of acantholysis was not from a dog with PF, with pemphigus foliaceus, but from a dog with impetigo. So be very, very careful. The presence of acantholytic cells along with these skin lesions does not mean that the dog has pemphigus foliaceus. Usually, in this age, it will be impetigo. And what are you going to do? Nothing. Or you may do some local baths with a shampoo containing chlorhexidine, or you may want to use a chlorhexidine spray, or leave the dog as it is. Usually, after a couple of weeks, everything will be off. Everything will disappear. Oops. Sabotage. Okay, corrected. Okay, so next disease. A puppy is coming with these lesions, and these are lesions due to dermatophytosis. The typical cause of dermatophytosis in puppies is Microsporum canis, but I showed you an exception before, a puppy that was from a pet shop with Trichophyton metagrophytes. And we know that the typical reservoir of Microsporum canis are the cats, so dermatophytosis due to Microsporum canis will be more common in puppies that are in contact with cats, for example, in pet shops. And the main clinical lesion is alopecia. Here you see it was a puppy, a huge area of alopecia. The reason that this puppy developed dermatophytosis is a little bit strange. It was hospitalized due to a GI, gastrointestinal problem, and they clipped it to insert an intravenous catheter. And probably the clipper had been contaminated by dermatophytes from another dog, or more likely from a cat. And after the dog recovered for the gastrointestinal problem, it developed this lesion, which is typical of, resembles dermatophytosis. And we're going to see easy epilation of the hair coat at the periphery of these lesions, perhaps some erythema, scaling, and crusting. Here you see the inflamed erythematous lesions. Here you see some erythema, the alopecia, and some crusting. Here you see it's on the digit, erythema again, and crusts. Look here, a lot of crusts. All these lesions were due to dermatophytosis, a lot of crusts, no alopecia. It can happen. We have some special forms. One of them is ringworm carrion, when we have nodules with sinus tracts, and there is pus exiting from these tracts. You can see here a dog with 1, 2, 3, 4, 5 dermatophyte carrion lesions, and here you can see the sinus tracts. Another one with many, many sinus tracts all over the lesion. Another one with a single lesion on the muzzle. And very rarely you will see the pustular form of dermatophytosis. I have just one example to show you. This was a dog, and there was an area of alopecia and a lot of pustules, and it was the pustular form of dermatophytosis caused by a very rare species of dermatophyte. It's called Trichophyton erinaceae, and the reservoir are the hedgehogs. This dog used to take a lot of walks in the woods. Also, another rare manifestation of dermatophytosis is onychomycosis. Many people believe that onychomycosis infection of the nails by dermatophytes is common. To my opinion, it's very uncommon, and personally, I have never seen onychomycosis as the only clinical manifestation of dermatophytosis. And this is a dog. Okay, all these lesions, it was severe. It was not a puppy, first of all. It was a very old dog. With severe generalized dermatophytosis, you see extreme hyperpigmentation here. And look here, the infection of the nails that become elongated, friable. The diagnosis. If we have lesions that are compatible with dermatophytosis, the first thing to do is to do the Woods lump examination. Very fast, very cheap, and very convenient. What we have to look when we're doing this examination, we have to be sure that the fluorescence is on the hair, not on the surface of the skin. This fluorescence is produced by the majority of the strains of Microsporum canis. In the past, we used to say 50%. It's not like that. Probably it's 80%, perhaps even more. And these strains of Microsporum canis, when they grow in the hair, they are producing some metabolites that are, when they are exposed to the Woods lamp light, they are producing this fluorescence. So if you see the skin fluorescing, then it's not positive. The positive result is to see the fluorescence only on the tiny hair shafts, on the infected, destroyed, broken hair shafts that are present within the lesion. And then the next thing to do is to do a trichogram. If it's Woods lump positive, then it is a good idea to take hair from the Woods lump positive area and to examine them under the microscope. And what you have to do is start with the 10 magnification, the low magnification, and look the difference between the normal and the infected hair. Here you see the normal hair, how it is structured. It has the cuticle, it has the cortex, it has the medulla. Everything is nice, everything is beautiful. And here you see this hair that is clearly abnormal. There is no internal structure, nothing. There are just these rails going all over the length of the hair. These are fungal hyphae. And of course, to have a definitive diagnosis and also to identify the fungal species responsible for dermatophytosis, you have to perform a fungal culture. I love these plates. We're using these plates in my clinic. This is Saburodextrose agar, the classical mycological agar, and this is dermatophyte test medium, which is actually more or less the same, but this one will also change color from yellow to red when dermatophytes will grow. And finally, after having a positive culture, you have to apply the Roth's flag technique to identify the fungal species. I know that this is not something that you can do easily in your practice. You have to send the culture to a lab to do this job. Now, about the treatment, clipping. In the past, we were very, very aggressive with the clipping of these lesions. Nowadays, we are recommended just to clip a small area around the infected skin and then to apply topical treatment. I don't know if you have the lime sulfur. You have it here. Okay, it smells awfully, as they say. Okay, I have just read about lime sulfur. It is considered the treatment of choice. So if you have the lime sulfur dip, then this is what you should apply. For sure, you know that you don't have to get the lime sulfur in contact with clothes or with your jewelry, because they will be destroyed, and then that you have to open the windows wide open because it's very smelly. Anyhow, for me, the treatment of choice is chlorhexidine miconazole shampoo, because we don't have lime sulfur in Greece. Now, if the lesions are extensive to generalized, and we have to also perform systemic treatment, the drug of choice is itraconazole. But the puppy has to be at least 6 weeks old to use itraconazole. Before 6 weeks, it's contraindicated because the liver enzymes responsible to metabolize the drug are not well developed, and there is a risk of toxicity. And if you are going to give systemic itraconazole to a puppy, let's say an 8-week-old puppy, use the low dose. The dose of itraconazole is from 5 to 10 milligrams per kilogram per day. Use the 5 milligrams. Go to the low dose. Another dog, quite similar to the previous one, right? However, this dog had demodicosis due to Demodex canis, a normal parasite of the skin transmitted from the mother to the puppy soon after birth, and normally living in a total balance with the body without causing skin problems. But in some puppies, due to the immaturity of the skin immune system, it may multiply and cause lesions of localized demodicosis. These lesions will self-cure. In some other puppies, due to some genetic defect in the cell-mediated immunity against Demodex canis, it will multiply again, but this time the lesions will not self-cure. Now we're going to have a dog with generalized demodicosis. What we're going to see? Fewer in localized, more and more extensive in generalized areas with alopecia, erythema, and hyperpigmentation, like you can see here, alopecia and some erythema, here, with perhaps comedons and scales. Look, this Yorkshire. I'm sure there is alopecia. It's impossible to have demodicosis without alopecia, and the reason is that Demodex is a parasite of the hair follicles. So the first thing to see is alopecia. But it was such long-haired, this Yorkie, that you cannot appreciate the areas of alopecia, but you can appreciate all this tremendous scaling. I know that this does not look like demodicosis, but it was. You may have some crusts, and of course bacterial infections will follow. Usually we're going to have a dip, pyoderma, and you can see here dogs with demodicosis, severe, generalized, due to genetic predisposition, and with secondary bacterial infections. See the pus coming out from these lesions. Another dog. Demodectic pododermatitis with deep bacterial infection in the interdigital skin. And sometimes we're having otitis. Actually, if you check the ear canals of dogs with generalized demodicosis, that you will see that almost all of them have mild otitis. But there are some cases, very rare, this is the only one I have ever seen, where otitis is the only clinical manifestation of demodicosis. This dog developed demodicosis, no skin lesions, nothing, just this black cerumen in the ear canal full of Demodex. And the diagnosis, okay, for the skin lesions, obviously, deep skin scrapings. Typically, the number of parasites is huge, so you will not have a problem to find them in the skin scrapings. And then the current treatment of choice, without a second thought, is the use of an isoxazoline. Do you want lotilaner, foxolaner, flulaner, sarolaner? Use whatever you want. Remember, dermaticosis used to be generalized. Dermaticosis used to be a lethal disease. Until 60s, there was no treatment. Then the extremely dangerous and toxic amitraz came to the market, but it saved lives. Then we started to use macrocyclic lactones. The first one was ivermectin, also very toxic, but saved even more lives. And then after that, we had the isoxazolines that, practically speaking, solved the problem. It seems that gradually the disease will almost disappear due to the widespread use of this class of drugs for the prevention of flea and tick infestation. And here is another puppy that came due to severe pruritus. And it had sarcoptic mange. To have this disease, you have to have a source. Other dogs, usually stray dogs, are the most common source. A highly pruritic skin disease. The primary lesions are papules with erythema, with crusts and excoriations. You can see the primary lesions, the papular eruption. Here you see a lot of papules coalescing together to form small plaques. Again, the papular eruption and some excoriations. Again. And these dogs usually have a positive penile pedalar reflex, not always, but let's say 80%, 85% of the times. And they have peripheral lymphadenomegaly. Doing multiple superficial skin scrapings is the diagnostic test of choice, but it's not always positive. This is an adult sarcoptic mite. These are eggs. But many times you may take 10, 12, even 20 skin scrapings and not be able to find the mites. Just a tip that may be helpful, go to the earpine and play to their age to find a site with a strongly positive penile pedalar reflex and do skin scrapings there. You have higher chances to find the mite. Or check the abdomen or the axilla from areas with the papules that I showed you before that are not traumatized, that are not self-excoriated, and do superficial skin scrapings for there. If you are not able to find the mites, and since we said that these dogs usually have peripheral lymphadenomegaly, it may be a good idea to perform lymph node cytology. You see here the lymphocytes. This is a medium to big lymphocyte. This is a plasma cell. Look, the eosinophils. Again, here, here, some just eosinophilic granules also here. So what we're going to see in lymph node cytology in these dogs almost always is eosinophilic lymphadenitis, which is quite suggestive of sarcoptic mange. And finally, if you have not found the mite, you are going to do a therapeutic trial, which is the same like the treatment. You are going to give isoxazolines. Again, the age limit for these drugs, for all the registered drugs, as far as I know, is 8 weeks. This dog came with an extremely pruritic skin disease, and I would swear that the dog had sarcoptic mange. But finally, the dog had atopic dermatitis. We excluded sarcoptic mange, and the dog had atopic dermatitis. And for those who were not in the morning presentation about food allergy, very, very fast, because we don't, how much time we do have, Agnieszka? Okay, I have to be fast. So atopic dermatitis is not a hypersensitivity reaction to environmental allergens and things like that. It's a multifactorial disease with many, many, many causes, genetic predisposition, sensitization to environmental allergens, to food allergens, skin infiltration by inflammatory cells, cytokine production, abnormal epidermal barrier, staphylococcus and malassezia proliferation, and many, many more. It's an extremely complicated disease. It's not a simple allergic skin disease. And the typical clinical presentation is a pruritic disease involving the head, the earpine, around the eyes and the lips, again the earpine, the legs, the posterior aspect of the elbow joint, the posterior aspect of the carpal joint, the digits and interdigital skin, the ventral trunk, like the abdomen or the axillae, and the perineum, as you can see here, and also the ventral tail. And what we're going to have in these areas are the primary lesions that are erythema with papules, some excoriations, and in chronic cases, hyperpigmentation and lichenification. The main differential is sarcoptic mange. And what we did with that puppy that I showed you before was to give isoxazolines for 2-3 months, but there was no response. And then if we exclude all the other pruritic skin diseases, we're going to end up with a diagnosis of atopic dermatitis. And in this case, the treatment is a whole strategy, is a big fight, especially in severe cases, like the one I showed you before. It's a topic for one-day lectures, not just for 5 minutes, but very, very fastly. Long-term, lifelong treatment with isoxazolines for ectoparasites, treatment of infections and skin hydration is the first step. Investigation for food allergy is the second step. A baseline treatment is the third step. And in the puppies, you cannot use oclacitinib. It's not a very good idea to use prednisolone because, especially for prolonged periods and high doses, it may delay the growth of the dog. But if it's severe pruritus, you will use it. Cyclosporin can be used, is registered for dogs older than 6 months. So you don't have a lot of choices actually in puppies. Lokivetmab is one choice, the cytopoint, the monoclonal antibody, and topical steroids, hydrocortisone aceponate is the other choice. And then you have some additional treatments of lower efficacy. And the last disease I would like to show you is this one, sterile granulomatous dermatitis and lymphadenitis, huge title. Used to be called juvenile cellulitis, used to be called puppy strangles. And this is a disease that usually appears in dogs less than 4 months old. However, in recent years, we know that the same disease can appear in adult dogs and even in geriatric dogs. So it's not just for puppies. We don't know why some puppies develop this disease. Perhaps some genetic predisposition. Some people say that the skin lesions may relapse after subsequent vaccinations and have considered vaccines probably responsible for the occurrence of skin lesions. Anyhow, we don't know, so we cannot prevent it. This problem appears acutely with edematous lesions, sometimes pustular lesions, with some sinus tracts, and there is a pus coming out of there. Initially it's sterile pus, later on it will be contaminated by bacteria. We may have purulent otitis, and the characteristic is the distribution of the lesions around the mucocutaneous face, mucocutaneous junctions of the face, like around the lips or around the eyes, on the ear pinnae, and less commonly in other areas of the body. As you can see here, you see the typical lesions of juvenile, let's put it that way, cellulitis. You see here the edema around the eyes. The characteristic finding, because otherwise these lesions are not always very easy to help you in diagnosis, the characteristic finding is that these puppies also have systemic signs. And lymphadenomegaly, especially in the mandibular lymph nodes, is the most common one. So you have a puppy with edema around the eyes and the lips, with some purulent otitis and large lymph nodes, then you almost have the diagnosis. Just do deep skin scrapings to exclude demodicosis and check for deep bacterial infection, because as I told you before, the lesions are initial sterile here, but later on they become infected. And if they are infected, then you have to give systemic antibiotics along with prednisolone. The treatment of choice for this disease is prednisolone. And usually we are starting at 2 milligrams per kilogram per day, which is a high dose for a puppy, usually an unvaccinated or semi-vaccinated puppy. So don't risk to give just steroids without antibiotics, systemic antibiotics, if there is a secondary bacterial infection of these lesions. Usually in puppies, after 2, 3, 4 weeks, we can stop the steroids, and typically the lesions will not relapse. And finally, we have a lot of congenital diseases. The only important thing here, these are diseases for specialists. There are hundreds of diseases, different congenital diseases in dogs. I will just show you some photos. The only important thing here is to know if the disease in question is heritable, meaning it's in the DNA of the breed, meaning that we need to do some breeding counseling to block the appearance of disease in more and more offspring of the same male and female, or if it's not heritable and it's due to a de novo mutation during the gestation. In this case, we really don't care. It's a single dog. It will not happen again. Very, very fast, some photos. This is a case of ichthyosis, quite common in golden retrievers. We see these big brownish to black scales. I'm sure you have seen them. This is not a nice disease. It's congenital epidermolysis bullosa, a lost nail, huge ulcers, very poor prognosis. This is dermatosparaxis. The skin becomes extremely extensible and tears very easily. This is, you have seen it hundreds of times, and for some breeds it's the standard. It's called pattern baldness, but if you see a French bulldog, for example, like this, it's totally normal. And this is another rare congenital disease called Trichorexis nodosa. So if you have a dog with a congenital disease, just check if it's heritable or not. If it's not heritable, you simply don't care. Thank you very much for your attention.
Thank you very much, Manolis. W aplikacji nie widzę żadnych pytań. Jak ktoś się wstydzi, to pan profesor zapewne chętnie odpowie później na pytania. Thank you very much, Manolis. It was a pleasure to host you, and see you soon, I hope, in Poland once again. Dziękujemy brawami.
Thank you for the invitation.
Szanowni Państwo, z powodu ograniczonej ilości miejsc na sali nie możemy zajmować miejsc dla innych osób, dlatego prosiłabym również o to, żeby nie kłaść swoich ubrań i swoich toreb obok, a także jeśli będą pojedyncze miejsca, takie jak widzę w 4. bodajże rzędzie, żeby się ściaśnić, żeby osoby, które wchodzą, miały jak najwięcej miejsca. Dziękuję.
Czy ktoś z Państwa zostawił okulary?
So, 45 minutes. I'm feel good, thank you. So, 2 left. 2 left for today and then 1 tomorrow. Yep. So, I recently was in a meeting where I had 9 and that's too many. I don't know what to do for 9 hours. So, but, your wife? No, she had to stay home because her mom is not well. So she's giving she's recorded the lectures, and they're going to be given and should be on Zoom tomorrow.
Okay, so she's not.
So she had to stay home. Well, that happens, right? Okay, so we can put that on. Yeah. All right. We can wait until everybody's sitting.
Yeah.
It's the first time I give this one, so I'm just checking what I have.
Wszystko okej? Mogłabyś mi zająć tam jedno miejsce? Tak, żeby się...
Z kolei osoby siedzące na schodach prosiłabym, żeby nie zajmowały całej szerokości na dole, żeby osoby kolejne mogły wejść jak najwyżej. Żebyśmy się wszyscy chętnie zmieścili. Dziękuję bardzo.
Would it be possible to have the sound for, could they give me a sound connection? Is there one here?
The sound.
Sound. Otherwise, it's okay. That's no big deal. I can do it with my microphone.
Okay. Okay. Maybe you can.
Yeah, that's what I'm doing. Yeah, no worries.
I'm not sure that they organize this so quickly. Halo? Nie mogę gadać, tylko prowadzę teraz wykład. Ogarnij to.
You want to do it?
Yeah.
Okay.
Więc chcielibyśmy Państwa zaprosić na kolejny wykład. Prosimy już o zakończenie dyskusji i oddaję głos do naszego prelegenta.
Okay, thank you very much, Dr. Lydia. Very well. So again, I want to say dziękuję to everyone here who has been so kind and has invited me to speak. It's a shame you don't live closer to where I live, or I don't live closer to where you live, because it's not easy to get to Poland, but it's not too bad either. And I've already had the opportunity to speak about WSAVA, so we won't go there. It's, for the record, the 4th time I'm showing the picture of Jerzy Gawor, okay? And I've just maybe he already gave me mineral water and an espresso, so it's pretty good. So I noticed there was a bit of a difference between what it said in the program, because I don't speak, of course, Polish, but I do know how to use Google Translate. So, chorobi, przyjęliu psów, whatever, esophageal diseases in a dog. So we had arranged something slightly different, but that's okay, because now that I've noticed there was a slight mistake, because I prepare things at the last minute, I had a chance to make some changes. So we will do a brief refresher on esophageal dysmotility and megaesophagus in a dog. That was not part of the initial plan. Therefore, the notes are mostly about gastroesophageal reflux, the notes that are probably translated in your things. So we'll talk about GER in people and in dogs, and that's the plan for today. So let's start with the fact that esophageal diseases, no matter what their causes, are going to cause a similar set of clinical signs. And I'll go over it. Regurgitation, big one, right? When we were in vet school, we learned how to differentiate it from vomiting. Our professors made it sound like any idiot can do that. Well, that's not true. Because it's sometimes difficult, right? Sometimes the regurgitation is protracted, and it can be tricky to differentiate both, but we always do our best. Hypersalivation is a number 2. Lip smacking, which means basically licking the dog licking his own lips. Dysphagia may be present in some cases. Empty swallowing or swallowing for no reason, right? These animals are often hungry if they are well enough. They may have pain on, on swallowing. Odynophagia is possible, and they may have weight loss. There was a study out of Germany. What's his name? I forget his first name. Ralph, I think. Münster practices near Frankfurt somewhere. And he reported 20 dogs with gastroesophageal reflux, and they were all pretty typical in their clinical signs. They also were pretty severe based on their clinical signs. So we see regurgitation, retching, gagging, eructation, repeated swallowing. Then they all had pain, sudden restlessness. Probably when they had reflux, suddenly they, oh, heartburn, that hurts. Vocalization, abdominal pain, odynophagia, praying position, which seems a bit extreme, but that's what he saw. Hypersalivation, licking the lips, lip smacking, and associated signs as well. So these 20 dogs, Michael is his name, it's coming back. Michael Münster reported were pretty severe dogs. So that's the symptomatology, if you want, of esophageal diseases, including gastroesophageal reflux. When we talk about esophageal dysmotility, we all think of these dogs with megaesophagus, okay? megaesophagus. You can see in this older dog here, Sophie. Oh, I'm not sure. I think she was more than 10 years old, female spayed. And she had esophageal signs, and you can see the border of the esophagus. You can see what the radiologists like to call the tracheal stripe sign, because there is air on both sides of the trachea in the esophagus, which is not normal, and in the trachea. And there you see the ventral wall and such. You can see similar stuff on the left lateral view, and also actually on the VD, but I'm not going to show you the VD. So for a diffusely dilated esophagus, or an acquired megaesophagus is often secondary. And so what could cause it? Inflammation, esophagitis could cause it. And then diseases that sometimes have mixed expression in the esophagus and on the skin, not polymyopathy, but SLE, dermatomyositis. Polymyopathy is another thing. Remember, dogs have striated muscle going along the muscularis of the whole esophagus. We and cats have striated muscle only in the proximal third, and the rest is smooth muscle. So it has an impact on the types of diseases and the expression of diseases in dogs. So a disease of the neuromuscular junction, right? Myasthenia gravis. In people, it affects mostly the throat muscles, but it doesn't affect the esophagus. In dogs, it definitely does affect the esophagus. As a matter of fact, of all dogs with acquired megaesophagus, I would say roughly, it's an estimate, about 30% of them have myasthenia gravis, while 70% have other issues. Endocrine diseases such as hypoadrenocorticism, potentially hypothyroidism, although that's controversial, may cause megaesophagus. Luckily, if that's the case, it might be secondary to neuropathy and myopathy and be reversible. We don't see a lot of lead-related toxicities or organophosphates anymore because we have so much less toxic products in our paints to paint our houses or as insecticides and parasiticides. Dysautonomia, I don't know if it happens here. It happens in Great Britain. It happens in some part of the United States. It's obviously a disease of the autonomic nervous system. And a big part of those dogs with secondary megaesophagus, we have no clue why they have it. So of course, we can't say that to the owner. We have no clue doesn't sound very scientific, so we say it's idiopathic, right? And that's the way it goes. So how do we rule things out? Because the idiopathic diagnosis is a diagnosis by elimination. So we tend, in animals, we see presented with megaesophagus to check for myasthenia gravis by having antibody titers determine these antibodies that actually lock on the neuromuscular junction, where particularly on the acetylcholine receptors on the side of the striated muscle. And I don't know if this test is available in Europe. It's available in America. So an increased titer makes it likely that this dog has myasthenia gravis, which would be a focal form, not a full myasthenia gravis where the dog has exercise-dependent weakness. So we tend to do that, take a good history. If we really think the dog may have hypoadrenocorticism, even the eukalemic, eunatremic form will do a resting cortisol concentration as a screening test, maybe some T4 testing. The history is going to tell us about lead exposure. There are still some old houses that have lead paint in our area, so we ask about that. But anyway, it's a diagnosis by elimination. And then the treatment, really relies on a dietary approach. This is a Newfoundland. I saw that on the internet. I mean, he's in a Bailey chair, right? That Bailey chair is called Bailey chair for no reason. Anybody can build their own Bailey chair. I think the first dog who was in a Bailey chair maybe was called Bailey. I didn't know that dog. But the idea is to put the dog sitting in a vertical position so that gravity can be used for the food to go from the throat to the stomach, right? It can be pretty messy. Now, on the other hand, Newfoundlands are usually pretty messy. And it looks like a baby really in a baby chair. It works great, okay? Exception, if this dog was an older dog with hip arthritis, that might be difficult for him to sit in a Bailey chair. But you see, it's well padded. Most people build their own, or they have a handyman building the chair for their dogs. And there are some, you can find that on the internet. If the dog is diagnosed with myasthenia gravis, a focal form of the disease, then we will treat with pyridostigmine. We start at the low end of the dose, and we might occasionally add prednisone or prednisolone as well. The issue with administering drugs by mouth to dogs with megaesophagus is, where do these drugs go, right? I know they go in the esophagus. When are they going to get to the stomach? I don't know for sure, and that's a bit of an unknown. I would certainly give it while the dog is eating, probably before the meal, when the dog is in a Bailey chair, right? So pyridostigmine, you're probably familiar with it. And there is hope on the horizon. There is a group at the University of Missouri who's been saying, yeah, that idiopathic megaesophagus, it's just like there has to be a reason for it, right? We need to understand that better. And that group has published quite a few papers, and they performed video fluoroscopy, swallow studies. They even came up with a plexiglass cage that is ideal for positioning the dog, and so they can take a video of the dog, like a video fluoroscopy of the dog when it's eating. So you feed the dog food mixed with barium, usually different consistencies, and you see how the food gets to the esophagus. And so Dr. Grobman is the lead person on that. Dr. Renero was her main professor when she did her PhD. And they did here video fluoroscopic swallow studies of 130 dogs, okay? Those dogs, it's a retrospective study, so they had 30 dogs with megaesophagus. One wouldn't think of doing a swallow study in a dog with megaesophagus, or wouldn't have thought that a few years ago, but they did it. And they noticed that in dogs with generalized megaesophagus, there were a significant proportion, more than half, that have what they call lower esophageal sphincter, lower esophageal sphincter achalasia syndrome. Okay, that means that what's happening is that lower esophageal sphincter does not relax. And that's the reason why nothing goes through, or it relaxes very episodically. And that's the reason why ultimately these animals get megaesophagus. But in the other, like what, 40% of cases, there was an issue with the esophageal body itself. And then, yeah, so they noticed other things. But even in dogs with no megaesophagus, but for some reason they still did these this study, probably because the dogs were not quite normal. They did see a lot of gastroesophageal reflux disease and other things as well, and even some of that lower esophageal achalasia syndrome. All right, and so what is fairly typical, this is a view where you see the spine, you see the esophagus. The dog was, you can see that the dog was fed probably some either liquid or thin canned food mixed with barium. You can see the dorsal wall of the esophagus along the spine, the ventral wall, the heart would be around, I guess, around here, and that's the diaphragm, and that's the stomach, okay? And they noticed that those dogs with lower esophageal sphincter achalasia syndrome had that parrot beak or bird beak like the beak of a bird, that appearance here of the colon that was fairly typical, showing that basically here it's closed, and that's the reason why the contrast is not going any further. So there is still a lot of studies, there are still a lot of studies that are required to better understand what's happening, but let's remember that in their patients, more than 1/2 of the dogs with esophagus, what was called idiopathic megaesophagus, had this situation, right? This lower esophageal sphincter achalasia-like syndrome, right? And so that has implications, because if that's the case, then maybe there are drugs we can administer that will open that sphincter, and one of them is sildenafil, which is known for other properties, but nevertheless also has a relaxing function on the lower esophageal sphincter. Okay, so there was a study, only one so far, out of, I want to say, Brazil, where it was used in dogs with congenital megaesophagus, so young dogs in probably a colony or a family of dogs with that problem, and it was relatively helpful in limiting the regurgitation episodes. Another option would be to inject the sphincter with botulinum toxin. That's also Botox, used a lot in cosmetic things, right? But Botox would relax the sphincter if the injections are a little challenging to perform under endoscopic control. And so that's usually what is done before then. It's done, and then most of the people who work on that would not do a surgical approach before having tried the Botox. If the Botox works, it's limited in time, 1 to 3 months, and then potentially you can send that case to a surgeon who's going to address the issue surgically. Don't ask me too many details, I don't do surgery, and luckily for the animals. So the fact is, megaesophagus has a horrible prognosis, right? 90 days based on 2 studies, one from the United Kingdom and one from Switzerland. And so the median was 90, meaning like a lot of, and the mean was 12 months, 90 days, 12 months, probably because a lot of dogs were euthanized at the time of diagnosis because people could not cope with it. And so aspiration pneumonia at diagnosis, adult onset, were negative prognostic factors, but there was no association with severity of dilation, etiology, or any particular treatment protocol. And of course, those, the main issue here is going to be aspiration pneumonia or animals that cannot be fed, period, and end up starving. So this is the nightmare picture in a dog with megaesophagus that you want to avoid if possible, although it's very difficult in many instances. So that's what I wanted to tell you about esophageal dilation. There are some good news on the horizon, but we still need some more work to understand better who, if anyone, would benefit from sildenafil, would benefit from injections of Botox, and so on. So far, it's a little haphazard. Now, let's look at the other issue. Here, we were talking about achalasia. At this time, we're talking about that same sphincter not doing its job. That's what happens with gastroesophageal reflux, okay? The lower esophageal, the esophagogastric junction is a fairly complex and well thought of, how should I say that, structure that consist of the lower esophageal sphincter, the diaphragmatic crura, the phrenoesophageal ligaments. The angle of His is important. That's just at the beginning of the stomach between the junction and the cardia, and the plaques of the gastric cardia. And so it's, you know, it works really well. The part of the esophagus experiences the intrathoracic pressure. The stomach, of course, is going to experience the intra-abdominal pressure. And all this is well-oiled and functions well in patients that don't have gastroesophageal reflux. However, gastroesophageal reflux is a big issue in human medicine and probably in canine medicine as well. So the confusing part is that those of us who are healthy and normal also have gastroesophageal reflux. It's a physiologic mechanism, right? And on the left, we have listed parameters that are important for and that are functional in healthy people when they have their gastroesophageal reflux, which could be at night and not even noticed. Intact saliva production and swallowing mechanisms in case if there is a reflux, good motility of the esophagus. The esophagogastric junction only has infrequent lower esophageal sphincter relaxation, okay, which is normal, but if it has to be, it's a rare event in normal people. Intact lower esophageal sphincter tone, and a good anatomic superimposition of the sphincter and the diaphragmatic crura, and a normal gastric emptying. Well, all those are things that are lacking in a patient, and we're talking now human patients, that have gastroesophageal reflux that causes disease. There is impaired saliva production and reflex-induced swallowing, maybe esophageal hypomotility, excessive numbers of transient lower esophageal sphincter relaxation, a hypotensive lower esophageal sphincter, maybe even a hiatal hernia, and potentially delayed gastric emptying. So, the possible complications of GERD are Barrett's esophagus, which is a transition, you know, it's a pre-neoplastic stage that could eventually lead to esophageal carcinoma. Now, not everyone with gastroesophageal reflux disease is going to develop those diseases, but when they develop, they are obviously serious complications. And so, you know, in human medicine, you know, the signs of GERD, gastroesophageal reflux disease, include heartburn. That's one thing that our dogs may have, but boy, you know, at least my dog cannot tell me when she has heartburn, right? So regurgitation, that we would probably see, but it goes beyond just that. There can be discomfort in the cranial abdomen, maybe some chest pains, nausea, dysphagia, pain on swallowing, burping, and there can be extra esophageal symptoms such as throat clearing, sore throat, the feeling that there is something in your larynx, that's called globus, an abnormal voice. I know people who have GERD, and when they wake up in the morning, their voice is all weird because they've had regurg during the night, right? And chronic cough is possible, wheezing, potentially even dental erosions. So there it is, what's typically recommended when there is a suspect GERD, they go with a protein pump inhibitor, such as a omeprazole or another one, trial for 4 to 8 weeks. And this has a good sensitivity. At the same time, it's a trial that has diagnostic value, treatment trial with diagnostic value. Specificity not that great. They said avoid large meals, avoid meals just before going to bed, you know, sleep with your head elevated, sleep in left lateral recumbency. It's an anatomic thing. In people, if you sleep on your right side, it's more likely, that the content will flow from your stomach into your esophagus than if you sleep on the left side. Lose weight, easy to say, right? I'm fighting with this one myself. I did stop smoking when I was 25, so that's okay, but it's also very difficult, right? Easier said than done. So, GERD in dogs. For a long time we said, oh, gastroesophageal reflux disease, that doesn't happen in dogs because we didn't know any better. It also happens in normal dogs, but we have issues with general anesthesia, brachycephalics, and we'll talk about other situations. This was, oh boy, that's a very large writing. I need to make it a little smaller. I'm getting dizzy. So that was a paper by the team at Missouri where they actually used nuclear scintigraphy and they fed dog a meal with your radioactive marker, and they followed these animals over a period of time and were able to detect that many of these dogs had reflux in the esophagus. In some of them, and really half of them, it would reflux into the pharynx and proximal esophagus, so it would go really far. These were healthy dogs, okay, that were fed that meal. And there were 2 events per, and that was postprandially, right? 2 events per 5 minutes, and the duration of these events was about 6 seconds, and no dog had detectable aspiration or detectable disease for that matter. So that's the team at Missouri really was interested in investigating the relationship between the GI system and the respiratory system, aerodigestive disorders. And so in human medicine, gastroesophageal reflux has been associated with upper airway disorders, even airway disorders, bronchiectasis, dilation of the bronchi following chronic inflammation, aspiration pneumonitis and pneumonia, lipid pneumonia, and even interstitial lung disease such as pulmonary fibrosis. All this because these patients had regurgitation that was probably causing micro aspiration, so not a big aspiration pneumonitis, just small amounts would get into the trachea and into the lower airway. And there is anecdotal data connecting gastroesophageal reflux in dogs with similar issues, even in Westies with idiopathic pulmonary fibrosis. Well, that's not good when it's black, but it's just for a short moment. I pushed the wrong button, that's why. We are familiar with the fact that our patients, while they're under anesthesia, have a high prevalence of gastroesophageal reflux. More than half of the dogs under general anesthesia have reflux, presumably secondary to decreased lower esophageal sphincter tone and increased transient lower esophageal sphincter relaxation events. So that could occur with any surgical intervention or non-surgical intervention that requires general anesthesia, but appears to be more common with abdominal surgery. And if you look at the different papers, sometimes they say, do this, and then you look at the next paper, it says, don't do this, do that. And I would say the data is still fairly controversial altogether. One thing that people have noticed who've studied that, say there is really no need to fast animals too long prior to anesthesia. If you fast an animal 12 hours or longer, of course the stomach is going to be real empty, that's good, but the content is going to be real acidic, okay? Acid, not so good, right? If there is a regurg and it's very acidic, then there is a chance of damaging the mucosa more than if it's not acidic. Even non-acidic reflux can damage the mucosa because it contains pepsin and maybe bile acids. And these substances are also toxic to the mucosal lining. All right, so here it seems like, from what I could see, most people tend to agree that between 3 and 6 hours of fast prior to anesthesia is a good compromise. And I'm not talking that we should feed these dogs a large meal, but a small meal, maybe a little closer than 12 hours prior. And then pre-medication drugs and anesthetics probably play a role, but that's also another situation where you look at the paper, they say, well, morphine, for instance, not great. Acepromazine, not great, because they can all relax the lower esophageal sphincter. The alpha-2 agonists, so dexmedetomidine, not great. So there are chances, even with gas anesthesia, I'm not even talking about halothane, but also isoflurane can influence the tone of the lower esophageal sphincter. So, but it's all relatively controversial. So I'm talking here about esophageal strictures, which is what happens sometimes following regurg in anesthesia. As a matter of fact, I'm just showing you the appearance of a narrowed esophagus that is ballooned, dilated with a balloon placed in the esophagus. In a little study we did, and it falls in line with much of the published literature, amongst 28 dogs and 4 cats, so 32 animals with strictures, most of them had issues after regurgitation. Some of them, it was after a foreign body in the esophagus, and some of them after vomiting. Some, for instance, after pancreatitis or something like that, right? I seem to press on the black button a lot. So, diagnosis of GERD in dogs is not easy. I wish dogs could come and say, Doc, I have heartburn and I want to know what this is all about. We don't see them at that stage. We see them later when the problem is more severe. At the bottom is what we should all do, in our clinics. Observe eating and drinking, okay? There is, and I'll show it to you in a second, a dog, I'm having a moment here. A dog swallow test assessment tool that you have also a link to in the notes. That's checking, does the dog have a swallowing problem, swallowing water, swallowing food? Has he lost any weight? Is it better with canned or dry food? Does the swallowing appear to be painful? So these are important questions to ask to the owner. You might say, oh, that's really about swallowing. But I think that it's about swallowing, yes, but it's also about regurgitation, about the bark having potentially changed, so the voice might change also with regurgitation, drooling. Does anything come out of the dog's nose? I'm going to let them catch up. Etc., regurgitation and such. So that's a good set of questions to ask, to have somewhere, in case if you see one of your patients, as you observe that them eating and drinking is ideal, you can do the swallowing assessment test, check the sigament history, good physical exam, and then you're going to want to do thoracic and cervical radiographs to assess the esophagus the best way we can. Are we dealing with esophageal dilation or not? Potentially do an ultrasound of the abdomen, for instance. And then you could decide, listen, I haven't found anything here that makes me think that this dog has an issue with esophageal motility or an issue with another organ. we should consider empiric therapy, much like in people, you know, with administering PPI for a couple of weeks and see how the dog does. Remember, in people, it's 4 to 8 weeks that they do the trial. And then dietary modification, maybe administer a food that is lower in fat, and food like low fat, not ultra low fat, but lower fat content may accelerate gastric emptying, meaning that the food is not going to be in the stomach too long and maybe not participate in the reflux. But other studies would have to be done in a specialty hospital. Video fluoroscopic swallow study. Now, I know some of you have endoscopy. That's a good way to evaluate the esophagus, okay? It requires general anesthesia, okay? You could do esophageal pH studies. That is done commonly in people, not so commonly in dogs, mostly in research centers or high-resolution manometry. So I guess that's where most of us would be, right? We're going to rule out other stuff, question the owners, and do empirical treatment and see how that works. Okay? So observing, you know, but the fact is, the sensitivity of what we can do is not great now. Let's say if we do thoracic imaging and we see hiatal hernia, then that's one thing we can potentially treat. Now, initially we would treat it medically with PPIs. And then the other things that have a higher sensitivity are more difficult to perform under clinical conditions, okay? Again, the esophagoscopy is the one technique that is available to several of you that has a fairly high sensitivity but requires general anesthesia. Okay, let's see here. I have this dog belongs to a student. She showed it to me recently. So this dog had anesthesia. It's an 18-month-old standard poodle, was 3 days post-operative for a spay. So I'm gonna, on the left side, the video here shows her kind of swallowing an empty. And there you see her having a reflux moment. She stretches her neck. It's a longer one. She licks her lips. So things are happening there. Right? So you can see her displaying many of the clinical signs that we discussed. She has a little tire around her neck because she had been spayed, and it was the better version of an Elizabethan collar. I think it's much better, and it's not that was causing the signs, right? We're all clear that she had gastroesophageal reflux post-operatively. And there is Buddy. Buddy was an Australian terrier. He was young, 1.5 year old, and he was presented for coughing, hacking, neck extension, severe talism, and dysphagia. And the previous history is he had a cryptorchid castration 2 weeks ago. And that's what happened. He had moderate talism, hard swallow, neck extension, cough and gagging on tracheal palpation. So we did a thorough explore of the history for clues. Obviously, there had been an anesthesia. We did chest radiographs to rule out foreign body, megaesophagus, also rule out aspiration pneumonia, and continued the search for underlying disease. We did lab work, CBC, chem panel, urinalysis, and we found this on the radiographs, okay? So we see here that there is see the trachea, you see the spine, and you see some accumulation of air in the cervical esophagus and a little bit in the thoracic esophagus, right? Like where the arrows are showing, but there is no widespread dilation altogether, but still not a normal appearance. We didn't really see evidence of hiatal herniation here in this case. But if we look at his esophagus, it looked terrible. On the right is how esophagus looked like. Very smooth, very pale pink. Here it was very rough. There were multiple ulcerations and it was all red. He had a very widespread esophagitis that went from the lower esophageal sphincter all the way to the upper esophageal sphincter, if you want, in the throat. So horrible esophagitis documented with endoscopy. We actually even took some biopsies. The esophagus is very difficult to biopsy, but when it's inflamed like that, you can take biopsies, and it was necrotic and horrible. So we administered omeprazole. Okay, that's one of the indications where the consensus statement from the American College of Veterinary Internal Medicine recommends using proton pump inhibitors. At that dose, okay, you have to give PPIs twice a day in a dog. In people, it's once a day, really, and at this dosage, right? Don't do anything less than that, okay? And so that's that. This is a study out of Davis that came out a while back, showing that omeprazole, or esomeprazole actually, given orally, didn't really change much in the number of reflux events during surgery, during anesthesia. You have placebo or esomeprazole, but it changed a lot in the acidity of these events. I think I'm getting close to my end point here. And however, when they gave cisapride, which is a prokinetic drug that I know you have access to, cisapride actually tightens the lower esophageal sphincter and prevented the regurgitation. A study out of Colorado demonstrated that actually giving esomeprazole not only the day off, but the evening before anesthesia, and then again 3 hours prior to anesthesia, was the best way to significantly increase the pH of the what was refluxed in the esophagus. You see the controls, and only one dose of esomeprazole, the pH was around 5, between 3.5 and 6.5, versus if you gave 2 doses, the pH was around above 6 and between 5.5 and 7. And anything really above, let's say, 6 would be very good to achieve and to strive for, to limit the damage. Sucralfate is another drug that is administered, but not so much as a preventative, but as a treatment for esophagitis. There is not much data to confirm that it works, but we kind of like giving it anyway, okay? So sucralfate, omeprazole, potentially prokinetics. If you have cisapride, great. Sometimes it takes a while for us to obtain it, and immediately we want to do something, so we give metoclopramide. It has no effect on the lower esophageal sphincter. However, it enhances gastric emptying, and it's a good way to bridge, you know, like until we can get the cisapride, which may take about a week or so, right? And in some instances, you even have to consider placing a percutaneous endoscopic gastrostomy tube, right? So the prognosis is fair to good for esophagitis. Better, of course, if you can eliminate the inciting cause. So if there was one anesthesia where it's not happening again, right? And that's better than a dog that has continuous reflux. And possible complications include strictures or aspiration-related disorders. I think I'm going to conclude here because of the time factor, because I always get confused with the time. Is that with Dr. Lydia? There she is. Am I supposed to finish at 6:15? Yes? Well, it's only 6:18, so it's not too bad. And the next speaker is myself, so I will accommodate. But thank you for bearing with me on that. And then we'll reconvene in about 5 minutes then. Thank you. Going well. I have never done the other one, so it was too long, but so I got the last full slide. That's okay. I know next time I need to cut a few more slides. My people are tired, logically, I understand that. I'm going to I'm not sure about these glasses.
Nie, ale weź tam czapki, bo teraz jeszcze mam jeden.
Of course. Yes, I don't have a stick, but can I send it to you via WeTransfer?
Yes, please.
I thought I had sent it to that email.
For some reason, the file just disappeared.
Oh, I see. Things happen, right? So
it surprised me a lot.
We're going to go to WeTransfer. Here.
And I can write down my email address in the WeTransfer.
There. Internet is a very slow here.
The internet's not working.
It's okay, but it's a very slow. Yeah, so what I had is this this one. No, that's my address. It was this one, Trasla.
I will type in, it's our boss's mail,
Okay.
but I will type in my email. Alexander, yes, correct.
Okay, and then we're going to take the file, which is this one. Right?
Yeah. Wonderful, thank you much. Which part of Switzerland do you come from?
From the western part where we speak French. Neuchâtel is the name.
Neuchâtel. I know Switzerland very well.
Szanowni Państwo, z powodu ograniczenia liczby miejsc prosiłabym, żeby wszyscy zajmowali po jednym miejscu, czyli nie kładziemy swoich torebek, nie kładziemy swoich ubrań i ściaśniamy się maksymalnie. Czyli jak tu są 2 miejsca, to się przesuwamy. I jeśli zabraknie miejsc na fotelach, siadamy na schodach, jeśli Państwo będą mieli takie życzenie. Od samej góry, żeby nie przeszkadzać osobom wchodzącym. Dziękuję.
Yes.
Okay. Is it necessary to reduce the dose of omeprazole maybe in 4th week of use
Yes, it's recommended to go maybe every other day, and yeah, so decrease progressively. If you've given it for 4 weeks, yes, so over maybe 2 weeks, decrease, reduce. 4 weeks full or whatever time you decide the full dose. You say, okay, I want to give 2 weeks, 4 weeks. If you give 4 weeks, you should decrease the dose progressively over 2 weeks. Does that make sense?
Okay, yes.
So you give 4 weeks full dose, 2 weeks decreasing dose.
Okay.
Maybe every other day.
Thank you very much.
You're welcome. It's amazing how it changes. People go, people come, people go during the lecture. So this is the last one. Yes, migration patterns, yeah. My migration pattern after this is the bar where I get a beer. I have not taken any alcohol because I don't like to drink when I speak, but I will after I'm done. Yes, I will come. I know usually a little bit, so we've been somehow. You should have gotten my file now. Almost there. Done. Okay. So we're starting, that's now is the time, or are we late?
No,
20 was the time? Okay, well this one I know really well, so I can adapt it.
Okay, so we can start, I guess.
Yeah, if you want, I would love it.
Okay. Serdecznie zapraszamy na ostatni wykład profesora. Porozmawiamy o chronicznych przypadkach biegunki. Zapraszam do wysłuchania.
Thank you. I'm just trying to see 18. Oh boy, yeah. Okay, very good. We have until 7. I need to entertain you until 7 o'clock, and then you need to have a beer or a glass of wine or whatever, and then you go to the big party. So that's a busy program, but for the next 35 minutes, you're with me, and I'm very grateful for it. Did you get the file, Alexander? Okay. You always want to be in good terms with the translator. So I went over that. Oh, I'm showing the picture of Jerzy Gavor one more time. So that's 5 times today. And I will tell him that at the Ghana dinner. So we'll talk about chronic diarrhea in the dog. Okay, we'll talk a little bit about the terminology, and we did talk about it already a little bit earlier, so we can go a little faster on some concepts. We'll talk about the approach to these dogs with chronic diarrhea of unknown origin, diagnostic workup, recommended in different situations, and we'll take it from there. So again, as I've said before, I'm always talking of what happens after you have ruled out GI parasites, okay? Because GI parasites are a common cause of diarrhea, but we're not talking about them today. So you've ruled them out either by testing or potentially a trial treatment with fenbendazole or something like that. So we went over that before, and to be honest, I keep using old words myself sometimes, but what has been discovered in the last 15 years is that like many dogs presented with chronic diarrhea respond to a diet change, okay? Food responsive enteropathy, between 50 and 75% of those dogs. There is a percentage of them that will respond to immunosuppressants only, but we always try with administering a novel diet, or almost always. Some have some issue with dysbiosis, so an abnormal intestinal microbiota, and some don't respond to anything. And if we look at the protein-losing enteropathy, I had a chance to talk earlier about the fact that these often also respond to a new diet. Different diet, though. We're dealing here with novel protein and hydrolyzed peptides. Here we're dealing with low-fat or ultra-low-fat diets. Some need immunosuppressants, immunosuppressant responsive PLE, and some just don't respond to anything. The pathogenesis of chronic inflammatory enteropathies involves a number of things, and I'm checking my slides here. I don't have that one. But the central element is really that there is a disruption in the intestinal barrier, in the integrity of the intestinal barrier, and that's going to cause abnormal discussions, if you want, or communications between the innate immune system and the microbiota, potentially some nutrients, and some dogs might be predisposed genetically to these issues. And so speaking about which dogs, we know that Yorkies often develop lymphangiectasia. Another breed for lymphangiectasia is a Norwegian Lundehund. We don't see very many of those where I work. Rottweiler, Maltese, boxers develop granulomatous colitis of boxers. So we know some factors. Maybe I should have had German Shepherds, which can be very challenging to treat for their chronic diarrhea. I don't have a picture of them. So I wanted to go over a study that comes from Finland. It's a large scale study where they collected information directly from dog owners. There were not any veterinarians involved there. And so there's two parts to that study, like more than 16,000 dogs where they had collected information over the years, and they analyzed that information. And they saw that looking at the prevalence on a y-axis and the age of development of chronic intestinal diseases, the dogs that were from IBD-prone breeds seem to be prone to develop IBD relatively early. And they had the dogs that showed you, plus other breeds as well. More interestingly to me is the fact that for dogs that had a maternal history of enteropathy, in blue here, there was an increased tendency, if we look at the prevalence in percentage, to develop signs of chronic enteropathies if they were the offspring of a bitch that had chronic intestinal disease versus if their parents, or definitely their mother, did not have any issues with intestinal disease. Interesting. And then they went on, and so this does not necessarily reflect my belief. It's just something I wanted to share with you because it's literature out there, and maybe you wouldn't see it because it's not a very, that's scientific reports. Maybe you don't read it. I don't typically read everything off it. So they looked here at, in this population, does the diet have an influence on the development of chronic inflammatory enteropathies? Diet early in life, during puppyhood, okay? So it's a bit complicated with letters, okay? But they had they tried to figure out which puppies got non-processed meat-based diet. So that would be basically, homemade diet, leftovers, stuff like that. Or those that got ultra-processed carbohydrate-based diets. So that would be the kibbles, that often we give to our dogs. And so dogs which in the puppyhood had like non-processed food tended to be protective for developing chronic intestinal diseases later in life. So blue is protective, right? The odds ratio is less than 1. Versus if they did get the processed diets during that period of time, it seemed like it made them at increased risk. And if they were eating leftovers, so that would have been a home-cooked diet here, if they were eating leftovers, they were also protected from developing chronic intestinal diseases later in life. That's a bit of a paradigm change, right? Like we don't typically encourage anyone to feed leftovers to their dogs. But then again, that's the study, okay? That was during puppyhood. So I would assume, if I recall correctly, up until 4 months or something, then they did the same for what happens during adolescence, probably 4 to 8 months or something. And there also, it seems like home-cooked diet was more protective and processed diet was more a risk factor. Now, I've shared that with you. That study had a lot of potential, weaknesses, but it was reviewed by a serious journal, and I think it adds to the information we have out there. So perhaps the fact that we need to feed our dogs easy things that make it possible for us to have dogs and otherwise busy lives is partially contributing to the diseases. One thing we know also is that dogs that have had parvovirus infections early in life, they tend to be more likely to develop chronic GI signs than those that have not. That was a study out of Germany comparing dogs recovering from parvo with dogs that went to the vaccine clinic. And you can see here, the prevalence of those dogs with recovering from parvo is much higher, about 40%, versus here it's about 15% in the dogs that didn't have parvo. And then there was yet another study documenting that dogs, also from Germany, that have had acute hemorrhagic diarrhea syndrome, AHDS, we used to call that hemorrhagic gastroenteritis in the old times, were also more likely to develop chronic intestinal disease. So an insult, acute and severe insult to the GI tract may be a predisposing factor for developing chronic disease later in life. So that's the little information that I can find for you at the level of the pathophysiology. Now let's look at this dog. Just walked in. It's like we can't even listen to a presentation. There is somebody coming to the clinic with a patient that we need to see. This is Jeb. He's a 5-year-old male-neutered Labrador Retriever. He's actually a mixed breed, but we don't tell that to the owner because they're very proud of their Labrador. His history has had chronic diarrhea for a year. So not an emergency, but it was in their eyes an emergency to see us now. Defecates 2 to 3 times per day, light brown puree consistency. The problem has been waxing and waning, so not all the time. Sometimes bad, sometimes better, and like that, waxing and waning. Unresponsive to deworming, diet change, and metronidazole. We'll talk about metronidazole tomorrow. It's a great drug, but not my favorite for GI issues. He's been quieter in the last weeks. We do a physical. He's a little lean, very excited in the treatment room. However, his heart rate is only 60. His rectal exam shows diarrheic feces and mucus. So there is Jeb for you. Okay, I mentioned before that we like to score our patients, especially in a multi-doctor practice. It can be nice to have a number that we can compare to when the animal comes back for a recheck, sees a different doctor. Okay, so we look at 6 different parameters, grade them from 0 to 3, and then total the number and get to the chronic inflammatory bowel disease activity index. Jeb had a 4 to 6, okay, depending on how you'd grade it, mild to moderate disease. All right, so what do we do for Jeb at this time? I'm not showing any slide before you give me an ID. What would you like to do for Jeb? Like he's presented, the owners, it's very chronic, but the owners want a solution now. And so if you want to say it in Polish, I would be more than glad to listen to the translator, or maybe Dr. Lydia can translate for me. No? I hear, in English we say, what I hear is crickets. Good, 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 good. Okay, well, you could tell me if you want. I wonder what's happening with this dog, right? And should we do a full workup of this dog? What are we suspecting? He could potentially have some type of diet-responsive enteropathy, but is Gershon trying to fool us? Maybe he is. What was a little weird is that this dog was excited and had a heart rate of 60. Does that make you think of a disease? I think I hear high. I'm thinking you're probably saying hypoadrenocorticism. And I think that's definitely worth a thought, right? And there is a form of, if I can only make that work again, there is a form of hypoadrenocorticism called eukalemic eunatremic form. We had actually done electrolytes, and the electrolytes were normal. You know that with hypoadrenocorticism, the potassium is going to go up and the sodium is going to go down, but that doesn't need to be. And we do a screening test with a baseline cortisol as a first approach, right? And if it's below 1 or 28 nanomoles per liter, I don't know what you're familiar with, it would be considered really low. And then we need to do an ACTH stimulation test, okay? The idea of doing only one test, it's a screening test, so it's relatively cheap, right? If it was between 2 and 4, we'd say, oh, maybe he has it, maybe not. If it was between 1 and 2, maybe he has it or not. If it's above 2, you don't even need to do an ACTH stim test because the dog does not have hypoadrenocorticism. Here, we did, because we had the option, we did an endogenous ACTH coming straight from the pituitary gland. It was very high. The pituitary was saying, what the heck is happening down there in the adrenals? Because we don't get any feedback. And therefore, with that very high ACTH, it was confirmation of hypoadrenocorticism. And the eunatremic, eukalemic, also called atypical in some circles. I used to say that, but I was told not to say that anymore. And it's been shown that it can present as GI disease. In Germany, I think it was Germany and Austria, a study came out documenting that 4% of dogs with chronic diarrhea had eukalemic, eunatremic hypoadrenocorticism. This was not really confirmed by a study out of Scotland where they had less than 1%, 0.3% of their patients with that disease. And a study from Italy and Portugal this year tended to say, yeah, it's really rare. So is it a disease that occurs in German-speaking countries more than in Italian or English-speaking countries? I don't know. The fact is, I was a little surprised by this, and so I was considering it as a differential. With these numbers, maybe a little less. There is no data out of the United States, or for that matter, no data out of Poland that I'm aware of. Right, let's see another patient, Bear. Had intermittent diarrhea for 6 weeks, predominantly large bowel, mucus, and blood were mixed together. There was tenesmus. The dog was eating well, and no weight loss, no parasites documented, and the physical exam was unremarkable. The CIP-DI was 4, mild disease. The question is, what do we do here? Well, I wouldn't show you 2 cases of hypoadrenocorticism in a row, right? Because otherwise, I would be taking you for idiots. So I'm not doing that. But I guess we get to the heart of the matter here, where this dog, you have to consider the possibility of food-responsive chronic enteropathy or diet-responsive chronic enteropathy. And here is the initial study we did in Bern like years ago, showing that of all dogs referred to the vet school at the time with chronic diarrhea, we had 56% that responded to an elimination diet, okay? So that was very surprising to us and to everyone. And since then, it's been shown that between 50 and 75% of dogs with chronic diarrhea respond to a diet, okay? I showed you that before. If you were there, the food-responsive enteropathy dogs tend to have large bowel diarrhea, possibly mixed large and small, rarely only small, versus the dogs that do not respond to a diet change tend to have more small bowel, potentially mixed, rarely large. Dogs with PLE, purely small intestinal. All right? And so what we do here is we save everybody time and money. When we see a dog like Bear, we say, let's go and try. And we do a physical, right? We're not completely yahoos. But we would do a physical, a parasitologic exam if it hasn't been done, plus minus a baseline cortisol if we think, let's say if it's a poodle dog, a large poodle dog, I would consider, because they're predisposed to hypoadrenocorticism, I would consider doing it. And if there is only minimal to mild systemic repercussion and the CIP-DI score is low up to moderate, especially if it's a younger dog, Bear was 3 and something years old, medium to large size, large bowel diarrhea, elimination trial, right? With a novel antigen or hydrolyzed protein diet. Alternatively, you can do home cooked. And I expect a response within 14 days. I do expect that response. And I was once in Hungary, and they had a dog bakery, and the specials were puppuccinos and pupcakes. I thought that was cute. They also had food for the dog's companions that were, more like human food-like. But we typically decide either for a novel protein or a hydrolyzed peptide, and then I have to say I often go for the hydrolyzed options because it's a bit simpler. You don't have to take a detailed history on the antigens the dog might have been exposed to. We do in-depth client education so that they can implement a proper dietary trial. Okay, and we expect these results within 2 weeks. And how does that diet work? Good question. I guess initially everybody was thinking, well, it has to be some degree of food allergy, but we did some unpublished studies like showing that really that's not the case. I think that there is a lesion there that's probably a lesion, as I told you before, of the intestinal barrier, and that lesion basically allows communication between the diet and between nutrients and the innate immune system that typically do not happen. And so you actually pour oil on the fire with the wrong diet. Administering the right diet, you're going to decrease these reactions. And that is not a certainty. That's the way I see it. Nobody knows for sure what happens. But with the proper diet, you're going to decrease the response, hopefully favorably modulate the gut microbiome, right? And we saw before that if in bear one diet doesn't do it, and they come back after 2 weeks, same thing really, then I would say let's try another one, okay? Either with a different brand, or instead of novel protein hydrolyzed, or instead of hydrolyzed novel protein, or we have these extensively hydrolyzed products. I know the Altamino is available here. They are more expensive, but that's hydrolyzed chicken feathers. There is the Elemental from Purina, which is an amino acid-based type of diet. Also, I would consider the option of adding some fiber, especially if the dog has large bowel diarrhea, okay? And that fiber I would add is probably psyllium, right? And so I'm going to go relatively quickly over this because of time constraints, but psyllium exists everywhere, including in Poland, I am sure. And these are usually the dosages that are recommended, okay? We start with the lower end and then give a little more. If you give a lot immediately, animals may be bloated and have, flatulence and things like that, which owners don't always appreciate. Okay, so psyllium, for instance, that dog might benefit from it. Oops. So the key points are that a high proportion of dogs will respond to a diet, that in some dogs, they may progress, but in many instances they don't, and we should not forget the benefit of fiber supplementation. Here's another case scenario. Ariella, 7-year-old Yorkshire Terrier, 10 days of small bowel diarrhea, decreased appetite, lethargy. She's lean, she has ascites, otherwise no abnormal findings. So clearly here, her CIBDI is higher, moderate disease, and we're worried, right? We're more worried, so we are going to do something, investigate what may be happening. Maybe she has protein loss, and we need to know about that. What are the repercussions of that disease on other organs, potentially? So we definitely will want to do what I call a minimum database with lab work, hematology, chemistry panel, urinalysis after we've done our physical and history. And I would actually also recommend more than the blood work, but that's what we may see, evidence of protein loss with low albumin, often low globulin, cholesterol. Total calcium might be low. Occasionally, we might see evidence of inflammation. Lymphopenia is possible with lymphangiectasia, and malabsorption of fat. So occasionally, not only the total calcium, which is low because of the low albumin to which it is bound, but the ionized calcium might be low as well, probably secondary to low, to an abnormal vitamin D absorption. Vitamin D is a fat-soluble vitamin and potentially could be poorly absorbed. B12 is certainly something we're going to look at with hypocobalaminnemia, for instance. Okay, so these were her panel results. You will agree with me that she is severely hypoproteinemic and hypoalbuminemic. And that's a bit on the scary side. If we look at the chronic canine enteropathy clinical activity index, which includes ascites and hypoalbuminemia in its criteria, she has very severe disease. Okay, so we talked about this already, and if we look at her intestines, the wall the layering of the wall is abnormal. That here is the mucosa, and you can see these striations that go from the serosa towards the mucosa like this. You see them better from far away. These lines are suggestive of protein-losing enteropathy. In this instance, there is even a fully abnormal wall with fluid accumulation. You see free fluid here as well. So ultrasound can be helpful, but we have to look at the whole dog, and we have to consider the hypocobalaminemia, hypovitaminosis B12, and address it. If there is a low ionized calcium, we probably should consider hypovitaminosis D. We could determine the vitamin D levels or just go ahead and supplement the calcium, potentially the vitamin D. Look at the magnesium. These dogs tend to be hypercoagulable. That's why we recommend clopidogrel, like here. That's B12. That's vitamin D supplements. This is calcium carbonate here. And these dogs are often in a state of malnutrition. But if the patient is stable and able to eat, often we will start them on a low-fat or ultra-low-fat diet and address all their issues as they are, if they're low in B12 and things like that. If they're not stable, we'll provide supportive care and nutritional support. But I sometimes try to encourage them eating maybe with a little bit of prednisolone just to increase their appetite. They don't need more than just a little bit, maybe 0.5 to 1 milligram per kilogram for a few days, and see if that increases their appetite, okay? So we're going to confirm the diagnosis, right? Screen and address systemic complications. And if the clinical activity score is low, then dietary management is the way to go. If it's higher, like was the case in Ariella, then we would probably either go on with more investigations, including potentially endoscopy, or just add prednisone. Honestly, I don't do that many endoscopies anymore on those guys. So, you know, we know that dietary management, different type of diet, this time it's low-fat or ultra-low-fat diets, is super helpful in these dogs. And we have to consider the whole dog when we initiate the management. And potentially, we could also administer a probiotic, as I mentioned before. Right. So there it is. I can even say, I know it says, enjoy your evening in Lodz, in Łódź. And we're done 4 minutes ahead of time. Amazing. Is that correct? So if you have any questions, I'll be here, or you can ask them, whatever. Otherwise, I might see you tomorrow. Enjoy your evening in Łódź. Yes, of course.
About the situation with this Yorkie, do you also suggest to give her some plasma transfusion to stabilize?
I would give her plasma, if you allow me.
Yeah, of course.
It's no big deal. Yeah, so the plasma, I would say, because if you do that outside, tomorrow, I think so I will give plasma if I decide. course,
Yeah.
yeah.
And what about human album?
Oh yeah, that's been we've done that for a while, and we did that because we took more biopsies and took less biopsies.
Nie, ja tylko potrzebuję, wyszedł na nogę.
It seemed great until we started to see
support?
I'm okay. I think I'm just gonna wait for some space, and then. But I think it's okay. Yeah. And then just start turning everything.
Yeah.
So that's when we stopped because the risk was higher.
Understood. So we are not practicing, but I know that my colleagues from Estonia are sometimes doing that. And I thought I'm working in an emergency clinic, and then we're thinking we don't everywhere have a donor, so they don't have a donor back. So, yeah, so.
Yeah, so then everyone needs to be determining the risk benefit.
So better not.
But I did it a lot.
Yeah.
And then suddenly all the complications happened. I said, oh my God, never.
Never ever. Thank you.
Hello.
My name is Ruslan. Yes, I'm representative of Hills here in St. Louis, Middle East. It's a very good lecture.
Oh, thank you.
Thank you very much. And yeah, we recently launched the new product that really focused on chronic enteropathies in dogs. I have what to say, good low fat.
Oh, you have it as well.
So yeah, I just wanted to check with you. You mentioned Purina and RC product. Have you ever got experience with Hills?
Yes, yes. So I was just mentioning the extensively hydrolyzed. So the Purina is amino acid based, and I work with this a lot. And the raw Cayman is hydrolyzed. But yeah, I use a lot of it's sparse hydrolyzed.
It's your okay. Sorry.
These are my first steps. Hills, Purina, raw Cayman.
This you have to switch with professor's laptop. Yeah. Okay.
I'm sorry, I have to.
Hi, Frederick. We have that.
Oh, yes, sir. Hi, my friend. How you doing?
No, very fine.
I owe you some shirts, right?
Yeah, very important.
Yes, you.
Winter time is coming.
I see that. I see that. There are my stuff.
Your charger, yeah?
Thank you. And so I will. Can I bring it to you now?
Maybe no. We put it on our section of the congress.
Fine.
At the desk?
Yes, on the desk. Yes, on the desk.
I will bring it.
Now, where's the area where we have the reservation, the registration?
Yeah.
No, this is for me and Frederick. Some souvenir from Poland. Maybe. Yeah, there's some nice pictures. Maybe Poland will be close to.
Very nice. Close to my heart.
Yeah, no.
I'm definitely going to see that. I see that's my team. Right. And fantastic. Thank you very much. I appreciate it.
No, thank you very much. So I will be on VMX in Florida.
You will?
Yeah, I will be. But maybe I haven't free time. So I asked Colombia and they be afraid about
Okay, it's fine.
the posted to the hotel.
Oh, I see.
Sometimes they have maybe for the some parcel. No, to co? You should start.
Okay.
Hello, Frederic. How are you? Features. How are you?
Doing well.
Good. Good. I tried to come earlier, but you left us wrong.
Frederick,
But yeah, no, go rest. And I'll see you later tonight.
Frederick,
Okay.
follow me.
I'll take the steps.
Safe way.
Just making sure on my phone. I
Yeah,
have
check
my
it.
little
There's
thingy.
none of this. Hello again. Oh, awesome. Thank you. Great.
Do you have any problems? No.
At the beginning, small problems, but we resolve them, so that's good.
In the first, no, sometimes you have
Yeah,
the
that
same.
happens. That happens. No big deal.
How was your trip? All
The
okay?
trip went good, except that they didn't have my luggage, but I got my luggage eventually.
Yeah.
Today I got my luggage.
Well,
It was fantastic.
I'm gonna make sure
Béa, I
we
see
finish
you
my
later.
flight. Oui, oui.
À tout à l'heure.
Oui, okay. Bye. It's 45. And I'll make sure I finish on time because I know.
Thank you.
No, so I'm gonna speak for 40 minutes maximum because we're supposed to finish at 9. 40 minutes for lecture? Yeah, and then 5 minutes. Yeah. And honestly, we can let them go, and then whoever wants to come talk to me. People are tired. Exactly. Yeah. I wouldn't be here if I were. Yeah. Tomorrow, yeah. Tomorrow, 9 to 12:45. Yeah. Screaming. Alô? Alô?
Raz, raz. Raz, raz, raz. Should we close? Dzień dobry Państwu, a właściwie już dobry wieczór. Dziękujemy za przyjście na ten wykład. Ostatni wykład na dzisiaj będzie prezentować pani doktor Beatrice Monteiro i kilka słów na temat tej osoby. Jest to bardzo aktywna osoba. Ukończyła studia weterynaryjne w Brazylii. Następnie przeprowadziła się do Kanady i w Montrealu obroniła pracę doktorską na temat bólu i tutaj się tak intensywnie zaczęła praca w tym kierunku, w kierunku bólu. W tej chwili uważam, że jest jedną z najbardziej doświadczonych osób, jeżeli chodzi o lekarzy weterynarii na świecie w zakresie badania bólu u psów i u kotów. Jest autorką ponad 70 artykułów, jest autorką rozdziałów do kilku książek na temat bólu. Tak prywatnie miałem okazję spotkać panią doktor 2 razy na kongresach międzynarodowych i raz nawet miałem zaszczyt wspólnie prowadzić zajęcia warsztatowe z nią. Jestem pod wrażeniem, czuję się taki, jeżeli chodzi o wiedzę na temat bólu, taki bardzo mały. W 2014 roku został wydany w języku polskim przewodnik z zakresu diagnostyki, oceny i rozpoznania oceny i terapii bólu u zwierząt domowych. I w tej chwili jest w języku polskim w 2016 roku, ale mamy nowsze wydanie w 2022 roku i pani doktor jest współautorką, oprócz niej jest dr Duncan, profesor Duncan Lessels i inni współautorzy, nowy przewodnik na temat rozpoznawania, oceny i leczenia bólu u psów i u kotów. Myślę, że warto, żebyśmy, jeszcze nie ma tłumaczenia na język polski, ale sądzę, że warto by było potem przewodnik w Sawy spojrzeć, jak będziecie chcieli zgłębić dokładnie działania bólu. A teraz zapraszamy do pierwszego wykładu. So now, you can start your presentation. Thank you.
I'll take that. Thank you so much, Greg. I heard Canada and Brazil, and I know na zdrowie, so that's as far as I go with my Polish tonight. But thank you so much, Greg. It's a pleasure being introduced. We have worked together in the past. And you guys are warriors. It's 7 p.m. and you're still here, so thank you so much. I understand it's a greater effort, so I'm very honored to have you guys here in the audience today. And we will speak a little bit about many things, but mainly today I'm going to tell you 3 things. 1, how animal welfare impacts all of the domains, how pain impacts all of the domains of animal welfare. I'm going to tell you how chronic pain is this complex disease and how it really is a disease in itself. And then I'm going to tell you how treatment of chronic pain is multimodal. And so that's what we're covering today. I have a little disclosure slide. Let's see how I move them. Okay, we're do like this. So I am a full-time employee of Zoetis. However, for the purpose of this presentation, I'm here as an invited speaker. I'm not speaking on behalf of Zoetis. All right, and I mentioned we're going to talk a little bit about many things, but one thing will be constant, and that's Lucy. Now look at her and think about what information can you get from this picture. So Lucy presented to us for a wellness exam. And this picture, I had just opened the cage door. And look at her, she's walking towards me. Her tail is up, so she's very friendly. She's not shy by any means. She has a neutral facial expression. And she's a bit overweight, right? And I'm sure you could collect all this information by just looking at this picture. And Lucy, just wondering if I'm having issues here. Yeah, well, just gonna use my computer. Lucy is really show off. Look at her. This is rare, right? A cat that this is the first time she's in the clinic and she's rolling and exposing her belly to us. So loving the cuddles. But look at her face now. Look at what happens when our colleague held her by the elbow to turn her around. Look at her facial expression. Immediately after this picture, she was upset and she walked away and she didn't want to hang out for a little while. So spoiler alert, we later found that Lucy has osteoarthritis. So that's why Lucy is going to be with us across this lecture. And we're going to try to understand what are the things in her life that are affected by osteoarthritis, what is happening inside her body, and what are the things that we can do in practice, in clinical practice, that are supported by solid science. So we'll start with animal welfare. And we still do not have a single widely accepted definition of what animal welfare is. Animal welfare started as a science that was predominantly studied by animal welfare scientists. So it was around the 1960s that we first started talking about this. And us veterinarians, it's not until recently that we started being incorporated into the animal welfare world. But if we don't fully understand what it is, then it's hard to talk about it, right? So I'm gonna start with the easy part, and that is, let's make sure we align on what animal welfare is not. It is not animal rights activism. So animal rights is an ethical point of view, and they believe that there are things that we simply cannot do to animals. So this is an ethical view. It's not animal welfare. It's not traveling to places and posting pictures with wildlife. And it is not posting cute pictures in Instagram when we're anthropomorphizing animals. And don't get me wrong, I'm not necessarily saying that posting a picture of your pug on Instagram is wrong, but I want us to take a step back and start thinking, what is the impact of this action? What is this causing to this dog? So let's do a reflection with this last picture. So this is a woman in Hong Kong, and she's taking her dogs for a ride. Now, if these dogs have severe mobility impairment, and they're not able to go for a walk, putting them in a trolley is probably a good thing, right? They have the chance to go out, to see people, to have some excitement in their lives. But what if they're perfectly capable of walking? Then it's probably super frustrating, right? All they want is to be on the floor, greeting other dogs, smelling the urine from the previous dog, seeing people. So that's what I want you to start doing. I want you to start thinking that animal welfare is trying to understand the life experience of that animal from the point of view of the animal. And that's the catch, right? How can we try to make inferences about the life experience of that individual? And animals have superpowers, right? Some of them have echolocation. Some of them can see heat. Some of them can fly. So how us, with all our limitations, can try to make inferences about their lives? Well, we're trying to do that. We've been trying for a few decades, and we're getting better at it. So the most simple model that we have for understanding what animal welfare is the body, mind, nature. So this framework will try to think of the body is the physical health of the animal. And we're all pretty good at this, right? That's why we all went to vet school, to nurse school, to understand the physical health of the animal. But now we want to start thinking a little bit more about the mental health of that animal. And then nature, it really relates to the nature of that animal. So what does that species have evolved over thousands and thousands of years to need and want? What is the relationship of that animal with the physical and social environment? What are all the species-specific motivated behaviors that that animal has to perform to feel satisfied? So it's trying to think of all these things. And how many of you here have heard of the 5 freedoms? Yeah, that's good. The 5 freedoms is very popular, right? And they were, again, that's the one that started around the 1960s, and it was the first time that people were starting to think about animal welfare. What about the 5 domains? Who's heard about that? All right, that's good, a few of you. So the 5 domains model is a more modern understanding of what animal welfare is. It's a device, it's a tool for animal welfare assessment. And the way this works, it has 4 functional or physical domains. And we understand that each of these domains will result in a more positive or negative mental state. So each of them will contribute to the mental domain, and then in the end, we make inferences about the welfare state of that animal. So I'll just give you an example with nutrition, for example. We're not only talking about, does the animal have enough food? Well, quantity is obviously important, but what about the quality? How is the food offered? So let's go back to Lucy's ancestors, or even a feral Lucy. So a feral cat will spend 12 hours of its day looking for food, trying to get food. So it will be stalking, jumping, pouncing, killing, ingesting. And what about Lucy? Well, probably the owner puts food in her bowl and he eats in 30 seconds to a minute. So is she having the opportunity to express some of those behaviors related to the feeding experience? What about taste pleasures? So a feral cat will eat a mice, a bird, a reptile, and Lucy might have the same kibble every meal. So they don't have the chance to experience different taste pleasures. So I think my point here is just so that we can start thinking about all of these things that will influence that one domain, and then from there we can try to make inferences. Yes, she has lots of chances to have positive mental states or less. So that's how this model works. And then there's one thing that we're here to talk about, that will impact each of these domains, and that is pain. So by definition, pain is a negative emotion, and pain will negatively impact each of the 4 functional domains. So that's why, that was the first thing I wanted to tell you, how pain negatively affects all domains of animal welfare. So for example, nutrition. An animal that is eating does not necessarily mean that it's not in pain. Once I saw a horse with an exposed fracture and he was eating. Well, eating can be also a distraction, and eating is a survival mechanism, right? So they will still eat, but we know from research that they eat less and they take longer to eat. So it affects how they eat. It affects how they can use the environment. So Lucy was no longer using the stairs to go sleep with the owner. That was one of the things that the caregiver noticed. It affects their health, it decreases their immunity, and it absolutely affects their behavior, right? So now let's go to the second topic that I want to talk today. And let's understand a little bit what is pain. And now I just want to challenge you a little bit to think that pain has these 2 components, and they both are negative. The sensory component refers to the perceptual qualities of the sensation. It's a burning feeling. It's a sharp feeling. It hurts all the time. It hurts when I move. So what does the sensation feel like? That's the one component. And it is only when pain arrives in the brain that the emotion is associated to that sensation. So, oh, yeah, it bothers a little bit, or I feel miserable. So it has these both components, the sensory and the emotional, and they're both unpleasant. So if pain is negative, why do we have it? Well, the world is full of dangers out there. And let's pretend this is Lucy. And Lucy is approaching her paw to the fire. Now, as her paw is approaching the heat, the nerves, the sensory nerves that are innervating her paw are going to feel the heat, and she's going to withdraw. So that's protective, right? Pain is protecting her from getting hurt. Now, let's assume that Lucy was not very quick, and she did burn herself. Now her paw is burnt, and for the next few days to a week or so, she's not going to be using that paw because it hurts. So the tissues can heal, and she can go back to life. And once the tissues are healed, there's no more pain. So pain can be physiological, it can be protective. The problem is when pain is no longer protective, and that's when we're talking about chronic pain. And we'll look into that in a little bit more detail. But first, I just want to do a quick review of the pain pathway, or somatosensory system. The somatosensory system involves all the structures implicated in the perception of pain. It involves the peripheral and central nervous system, and we divide it in 4 steps just so we can understand what's happening. The first step is called transduction. So when Lucy's approaching the fire, she feels the heat. Lucy, now we know I gave an spoiler alert, we know she has osteoarthritis in her right elbow. What is happening there? So with osteoarthritis, we have degradation of all the joint tissues. With tissue damage, you have release of inflammatory mediators, and these mediators are the ones that activate the sensory nerves that are innervating her elbow. So that's what we call transduction. In transduction, the simplest way to think about it, it's an electrical signal. It's depolarization, if you remember that from, it's basically an electrical signal, and we call that a nociceptive signal. that signal is transmitted from the periphery to the spinal cord. And in the spinal cord, something very interesting happens, and that is called modulation. So that signal that was coming from Lucy's elbow, when it arrives in the spinal cord, it can be increased, what we call pain facilitation, or it can be decreased. And the messages, the mechanisms that tell the signal to increase or decrease, they can come both from the periphery and from the brain. So remember how I mentioned, well, Lucy's really not shy. She's bold. She's coming to say hi. You would expect that she's predominantly in positive mental states. Well, that is sending messages to her spinal cord to decrease that electrical signal before it reaches the brain. That's amazing, right? And we all have that. We have the exact same mechanism. So back to distraction. One time I did a camp just for pain nerds, and they put capsaicin, which is like this cream that hurts a lot. It's basically, they do a lot of research on that. And they asked me to give a score from 0 to 10, how much that was hurting my arm. And it was a 7. It really hurts. It's like burning. And then they asked me to do an activity where I had to read the names of colors, but the words were written in different colors of the name of the color, if that makes sense. It required thinking and cognition. And then after that, they asked me, okay, what's your score? And it went from 7 to 4. So that's distraction, right? So we have all these mechanisms, all of us and animals, that will decrease the message before it really reaches the brain. And really the last step is perception. That's, again, when that electrical signal finally arrives to the brain and an emotion is associated with it. And I know that you probably don't need all of this in your clinical practice, but I think my point here is just so we remember how complex this whole thing is and how we have all these modulation mechanisms that can increase or decrease the message. So just another visual to repeat what I just said. The pain that we finally perceive is the result of these mechanisms that increase the message and mechanisms that decrease the message. And everything that is happening inside and outside of the body of that animal. That's why, for example, ISFM does such an amazing work in helping us use more feline-friendly techniques. We have the pain-free program in the United States, and I think they're expanding, but the point is, if we can decrease fear and anxiety in the hospital, we're also helping with decreasing pain in the hospital and at home. All right, and then I hope now it's going to make sense why Lucy versus a very fearful or shy cat, she's in a better place to modulate her pain. She has more emotional resilience. And we do know that positive emotions decrease pain and negative emotions increase pain. So on top of everything that we do to treat pain, can we think about the things that will decrease negative emotions, such as fear, anxiety, frustration, and will increase positive emotions? So bonding with the caregiver, having more opportunities to experience positive emotions in life. What can we do, especially with chronic pain in the home environment, to reduce stress and fear and frustration in dogs and cats in their home environment? We're also helping with the management of pain. And I only have 3 more slides on. I know this is a bit content heavy for 7:30 on a Saturday, but we're almost done the pain pathophysiology part. So again, Lucy approaching the hand to the fire. What type of pain is that? That's acute pain, right? It's a pain that's physiological. It's there to protect her. That's nociceptive pain. And then we're here, the rest of this lecture, we're mostly going to focus on chronic pain. This is the second thing I want to tell you today. Chronic pain is a disease by itself. Just like we have diabetes or chronic kidney disease, it's the system, it's the somatosensory system that now is malfunctioning, and it doesn't have the purpose to protect us. Everything is malbalanced. And most of the time, chronic pain is secondary to a primary condition. And the most common that we see, osteoarthritis, cancer, periodontal disease. So these are primary conditions that are feeding this chronic pain system. And we also know that acute pain, so big surgeries like amputation, thoracotomy, where you're going to have a lot of nociceptive messaging arriving in the brain, when we don't treat appropriately acute pain, postoperative pain, traumatic patients, they can develop chronic pain, something that we call persistent post-surgical pain. And the classic example is amputation. So about 30% of humans, after amputation, they have phantom limb pain, right? They're feeling pain from a limb that is no longer there. And that's why. It's all in the brain at the end of the day. So that's what's happening. And I lied. There are 3 more slides from now. We're almost there. So I want to clarify two mechanisms, just so we really understand what we're talking about. When we say peripheral sensitization, what does this mean? So back to Lucy's elbow. In her joint, we have degradation of tissue, of tissues. With tissue damage, we have release of inflammatory mediators. I'm sure you're all very familiar with prostaglandins, and I hope by now you're also more familiar with nerve growth factors. And we know more about them because they are very good targets when we're treating pain. These mediators will activate the nerves that are innervating that joint. Now, initially, you have a signal here, another there, another there. And what happens with peripheral sensitization is that you start having a bunch of signals, pain signals that are being sent from the periphery. You have nociceptors that before were silent, and now they're activating. And this is what we mean by expansion of receptive field. You have a greater area now that is sensitized. So it's a lot easier for a pain message to be generated. And that's why Lucy was so upset when our friend tried to turn her from the elbow. That's hyperalgesia. She's feeling more pain than she should. A healthy animal, if you gently pull by the elbow, they wouldn't complain, right? But an animal with a painful joint, it hurts. So they have hyperalgesia, more pain than they should. This is peripheral sensitization. And the other concept is central sensitization. Similar idea, but in the central nervous system. All those messages from the Lucy's joint are constantly going to the spinal cord. And now what is happening in the spinal cord is that you have more pain facilitation and less pain inhibition. This is what we mean by central sensitization. It's easier for pain to be generated, and we're losing those mechanisms that were decreasing that message before it arrives in the brain. And on top of that, you have something that we call neuroplasticity. Think about it. Something plastic is something that changes shape, right? Neuroplasticity, a very good example is, imagine a nerve and all the dendrites of that nerve. In chronic pain, patients lose, I don't have a lot of coordination with my hands, but let's imagine that I lose some of my dendrites. You're losing gray matter mass. And then you're also changing the neural connections in the brain. We all have that, humans and animals. So we're changing the function and the shape of the nerves in the central nervous system. That's what we mean by neuroplasticity. And the good news is that it is reversible. We can't say that we cure chronic pain, but we can reverse some of central sensitization. And when we talk about neuroimmune interactions, now it's the immune system causing more pain. So you can see how complex this goes. And this is our next slide on this, just to give you a little bit more visual. Let's imagine, I know this is not an elbow, but let's think this is Lucy's elbow. We have degradation of tissue joints. When you have tissue damage, release of inflammatory mediators, some of the ones we know the most and that we have therapy for, prostaglandins and nerve growth factor. And then specifically with nerve growth factor, I want to talk a little bit, just because it's something, it's more recent in our knowledge. Nerve growth factors, they will act directly in those sensory nerves. So in there, they're going to make it easier for the nociceptive signal to be generated. They will act in immune cells to release more inflammatory mediators, including NGF itself. In the central nervous system, it will lead to something we call neurogenic inflammation. So that's the release of CGRP, substance P, mediators that are very implicated in central sensitization. And on top of that, it will lead to more innervation and more vascularization of that joint. So you can see how it's this vicious cycle of pain, inflammation, peripheral, and central sensitization. And again, we use a creativity. Let's pretend this is Lucy. I know this is a darker tabby, but that's what's happening with a cat with osteoarthritis. She wants to go up. The owner's sleeping upstairs, but she's fearful that going up is going to hurt. She's frustrated that she can't do something she used to enjoy doing. So this is an example of osteoarthritis. And now, if we had to guess, what are the 3 most common chronic painful conditions in dogs and cats? Come on. Osteoarthritis, yes. Yeah, periodontal disease, exactly. And then something you see probably almost every day, cancer, yes. So we don't have large prevalence studies. We have a few surveys, but I think all of us would agree that's probably what you see the most in terms of chronic painful conditions, both dogs and cats, right? So whenever you see these patients, we have to assess pain in them, right? And there are just some other examples. Europe, you guys don't do that, but in Canada and the United States, veterinarians are still doing onychectomy, declaw. That's an amputation, right, of the last phalanx. This is a cat 12 years after surgery. So she has allodynia. She has pain from just bearing weight on that paw. We can't touch that paw because she feels pain. So this is a classic example of a cat with central sensitization, for example. That's a cat with orofacial pain syndrome. We don't know much about this, but it's a type of neuropathic disease, periodontal disease. In the bottom, it's a cat with squamous cell carcinoma of the mandible. And then in the middle there, it's a cat with feline hyperesthesia syndrome, which is a type of neuropathic pain that we also don't understand fully, but they pluck the hair from their backs. And then here to illustrate dogs with the same 3 types of chronic pain conditions. So now in the next 15 minutes, I'm going to tell you the 3rd thing of today, and then I'll let you go to the gala dinner and get ready and pretty. So these 2 documents, who has heard about any of them? Please, come on. Yay, thank you. Okay, so these are amazing documents. I am totally biased, obviously. I was involved in the first one. But they are really good tools and quite different. And I think they are complementary. So the WASAWA guidelines, which is not yet available in Polish. If any organization wants to translate this document, please get in touch with the pain committee. It's a very extensive document. It's very long, but the chapters can be read individually. And the Warszawa one has a lot of nice tables with a summary of all the information you need to know from pain scales, for example. I'll show you an example. It has beautiful figures. The AHA has very nice diagrams, and I will show you a few examples. So I do think they're complementary. I don't expect you to sit down and read them at once, but perhaps print a version of each and leave that in the clinic. And then all the free time that you have in the clinic, you go and you read a page or two. But just leave it there, and you can scroll through a few of these pages at a time. And both these documents highlight how we don't make animals with chronic pain pain-free. That's not realistic. And we need to be realistic with ourselves and with caregivers that will manage pain, but we can't absolutely treat chronic pain. That's not a realistic goal. But what we're trying to do is improve quality of life. And we can discuss for many hours about whether there is a difference or not between animal welfare and quality of life, but really, it's the same thing. So think about those 5 domains. Think about what is important for the life of that animal. And that's what we're trying to do with pain management of chronic pain. Specifically talking about chronic pain. Acute pain, you can absolutely treat it. I'm gonna go them all because... All right, so pain management, it's a therapeutic continuum of chronic pain especially. Pain assessment. I really hope I will encourage some of you to start using pain scales. Tomorrow, I'm doing a lecture where we're going to practice the use of some pain scales with videos and pictures. I know that initially it's going to feel like it's taking more of your time, but I promise that over time, it's only going to improve your management of pain. It will be quicker, and then you will be able to compare pain scores from different people across the hospitalization of that animal or across the management of chronic pain. So I'll talk a lot more about this tomorrow. Treatment, this is the third thing I want to tell you today. Treatment of chronic pain is multimodal. Multimodal meaning drug and non-drug therapies, not polypharmacy. We want to avoid polypharmacy, but we want to have an analgesic as base, non-pharmacological therapies, and we'll go through a few examples quickly, and then you can add more adjuvants if needed. We need to routinely reassess them, and then you keep revising the plan according to what's happening. Remember, with chronic pain, most of the time you have a primary condition, and that condition will progress. So that's why we always need to get back to understand what's happening. This is one of the examples I mentioned from the AHA. I think these diagrams are amazing. So here what they're doing is showing us what are the things that we can do to assess chronic pain in dogs and cats. The first thing is the checklist. I'll show you an example in the next slide. So the pain checklist is an instrument for triage. So to help you identify the patients that are at risk. And then you do your diagnosis, and I'll show you in a moment. Then you have your pain scale. CMI stands for Clinical Metrology Instruments, pain scales. And I'll also show you how you can choose some of them. And then you have your physical exam, orthopedic, neuro exam. And obviously, you usually get a lot more information from dogs than cats in the clinic. And that comes the value from the video from the owner. Last week, I was talking to a surgeon and friend of mine, and I asked, what do you think has been the most amazing thing over the last few years in your practice, specifically chronic pain management? And that was his answer. Well, because now everyone has a smartphone, and they can do videos anytime of their dogs and cats, that's when you get the most valuable information. That animal in their own environment, you learn about the environment, you learn how the owner reacts to that animal when they're performing that behavior, and you see the behavior. So please encourage your clients to start doing videos from their animals. This is the example of the checklist for dogs. So these were developed by researchers at North Carolina State University. I heard Greg mentioned Dr. Duncan Lascelles. So this is research being done by independent researchers. And then Zoetis went there and made them pretty. So if you want access to these tools, come by the Zoetis booth or ask your reps. So they are a triage tool, sorry. It's 6 simple questions, yes or no. And if the caregiver answers yes to one of these questions, you know that that dog or cat is at risk of having osteoarthritis, and then you perform your diagnostics. So it's a triage document. Pain scales. This is just an example of a table at the WASAVA guidelines. And again, this is all free. Just type 2022 WASAVA guidelines. We have tables for acute and chronic pain, dogs and cats. And in there, we listed the pain scales available, whether they are validated or not. And if you come to my lecture tomorrow, I'll explain what that means. And then also where you can find them. So it's all in there. It's a lot easier than trying to do the research yourself. And then pain management is multimodal. Thank you. So again, another what I find beautiful diagram from the AHA guidelines. And what they did was to list, and again, this is all available. It's amazing that you guys are taking pictures, but you're going to have a better image. Just go to the AHA guidelines. So they listed what would be considered first line, second line, third line, drug and non-drug therapies for management of chronic pain. And then the little, oh, I forgot the name. What's the name of the spaceship? Yeah, the spaceship means the level of evidence. So it means it has a strong scientific evidence for the recommendation. And the little human there shows that it has a high burden to the caregiver. So a lot of work or emotional, financial, or time-wise. So this is a zoom of the first line therapy recommended. NSAIDs and anti-NGF monoclonal antibodies are listed as first line as analgesic therapy. So those are the analgesics that you're going to choose to start managing pain. That is the base of the treatment. And then in terms of non-drug therapies, you have your omega-3 fatty acids. So in terms of supplements, they are the ones with the strongest evidence for efficacy. So if you want to choose one, go for omega-3s. And today we have amazing supplements or commercial diets with enriched omega-3s. Weight management, I guess that's super obvious to all of us. Fat is an inflammatory organ, so fat produces inflammation. So we have to optimize the body weight of our patients. Everything that we can do to their environment to encourage controlled exercise for dogs. And obviously, if you have an indication for surgery, these animals need to go for surgery. Now, this analogy is not mine. It's from Dr. Kristen Schoss. She's a surgeon in the US, but I think it's an amazing, so I'm sharing her ideas. That building an osteoarthritis plan is like baking a cake. So the essential ingredients is it's like the flour, right? And the sugar. Well, actually today you can have like sugar-free cakes, but you need the flour, a type of flour. So the flour would be your analgesics, right? NSAIDs or anti-NGF mAbs, you need those, you can't escape. You need to optimize their body weight and include nutrition and omega-3 fatty acids, and everything that you can do to the environment of that dog or cat. And then the rest are the icings and decorations. So this part, the part before, is pretty much the same for everyone. And this is where you change according to the caregiver and the patient that you have. So the icing and the decorations are customizable. And this is just an example of some of the non-drug therapies that we can do. Anyone has ever done or seen this, the toilet paper rolls? Honestly, this is like so, thank you, some of you have. This is so amazing. That's actually my cat. And I love doing that. So that's a shoebox with toilet paper rolls, and then you put the kibbles in there. And then my cat especially, instead of eating in like 30 seconds, she takes like 15 minutes, and then she'll forget about it, and then come back later in another 10. And basically, they are smelling, trying to find the kibble. They're looking to trying to find the kibble, and then they're going, and then the kibble flies away, and then they run after the kibble. So remember what we mentioned about trying to mimic a little bit of the natural behaviors related to feeding. That's what we're trying to do with puzzle feeding. And because they eat slow and they are stimulated, it also improves, I hate this word, satiety, but it decreases their hunger. So it really helps with weight management. I'm almost done. This is material from Zoetis that was developed by surgeons and rehab specialists. And this, again, get to the booth and ask about these. They're called Back to Play. So these are recommendations for caregivers and veterinarians to help them develop a plan. Once you give analgesics, you want your dogs to slowly get back to physical activity because they are deconditioned, right? So we want to slowly gain that muscle mass. And then just to finalize, a big thanks to Lucy for being with us on this Friday night. And this is what Lucy was prescribed. And my point here, I want you to challenge to start writing some of these things that will promote positive emotions in your prescriptions. If you go online and you put like prescriptions, medical prescriptions with love or hanging out with friends, you know, some doctors will write that down, like have dinner with your partner, go play with your kids. So that's what I want to challenge you today. Can you start writing some of these things in the prescriptions? So we're ingraining in caregivers' brains that that's part of the treatment, and we're empowering them. They are part of the medical team that is taking care of that animal. And then to finalize, if you have not heard about it, the Wasava Certificate in Pain Management is an amazing program. Access to the content is entirely free. Right now, you can't register because they're going to start a new cohort in January, but you can register your interest. This is over 40 hours of continuing education on acute and chronic pain management in dogs and cats. Amazing content. And thank you so much. This is a quick summary. So the 3 things I told you: animal welfare, pain affects all domains of animal welfare. Chronic pain is a disease by itself. It has all those peripheral central sensitization mechanisms. And treatment of chronic pain is multimodal, drug and non-drug therapies. And I am 2 minutes past. I thank you so much. I'll let you guys go. If you want, come talk to me. Thank you so much.
Thank you, Beatrice, so much for your very exciting lecture. Przypominam, jeżeli mamy jakieś pytania, możemy pisać na telefonach komórkowych. Jest jedno pytanie, które przeczytam. Here is one question for you.
Okay.
So, do you think it is possible to treat hyperesthesia syndrome in cat with Solensia if gabapentin is not enough to help?
Well, that's a very good question. And then I'm putting my Zoetis back now. We do not have any data, any studies looking at the efficacy of Solensia for feline hyperesthesia syndrome, so we cannot recommend. Now, my Zoetis head off, just a little bit of food for thought. So feline hyperesthesia syndrome, I'm not a neurologist. We still know very, very little about it. It is a type of neuropathic condition and it seems to be very much related to stress. We know that stress can cause chronic pain. There's a whole mechanism in the brain that I'm not going to go there, but we know, and this is the same for us humans, that we're so, honestly, we're so similar to our patients. So stress can cause chronic pain, and stress, just like idiopathic